We're thrilled to host you for this landmark conference on scaling up innovative cervical cancer screening in India, a project that's equal parts research, innovation, and pure passion. On behalf of MAHE, the organizing team, and PRESCRIP-TEC family, I extend a very warm welcome to our distinguished guests, speakers, and delegates from across India and beyond. I am Dr. Raghunandan, postgraduate from the Department of OBG, and I'll be the Master of Ceremonies for today. To set the stage and share the vision beyond PRESCRIP-TEC, we have with us Dr. Kirtana Prasad, Professor and Director, Manipal School of Information Sciences. She is also the lead PI of PRESCRIP-TEC. Ma'am is here to walk us through the vision and overview of PRESCRIP-TEC, the big picture that makes all this possible. Welcome, ma'am.
Good morning and welcome to this event. This is the PRESCRIP-TEC. That's a prevention and screening innovation project toward elimination of cervical cancer. This is a Horizon 2020 funded grant, but for the Indian counterpart, it is the DBT which is funding us. This is a project of with a fund of 4.96 crores funded by DBT and around 3 million euros for the activities in the Europe. Netherlands, the UMCG from Groningen is the lead institution for the overall consortium, and MAHE, represented by me as the lead PI from India. We have 7 partners within India, across India, and we have all the representatives for all the partners here. Thanks for joining us. And we have the partners from TMH Mumbai. We have Dr. Shamla with us. We have CNCA Kolkata. We have TMC Kolkata. We have St. John's Medical College in Bengaluru, along with Swati Mahila Sangha or Swasti as the partner from Bengaluru. Sikkim Manipal University from Sikkim, and we have SDM Udyavara as part of this Indian consortium. Through this collaboration, we were able to reach diverse kinds of population from urban slums, hilly region, female sex workers, and rural population. So there was a good diversity of population that we could reach through this project, through this collaboration. This is just to give you a brief about what the project is, and then HPV self-test and the AI-supported VAA were the 2 technological innovations that we tried in this project. The main 3 activities were of this implementation research project was, one is creating awareness, conducting screening activities with the innovative screening approach, and capacity building. These were the 3 main aspects of the project in this project. This project aims to evaluate the acceptability, adherence, uptake, coverage, and cost effectiveness. This also includes cost effectiveness and capacity building activities, so that even after this project, people should be able to take this forward. That was the intention. Further, a few details about the project. We use the HPV self-test as a primary test, followed by, and those who had HPV positive, who were tested HPV positive, they were followed up with the VIA test, which was supported by the AI. We also obtained the expert evaluation of these tests to assess the performance of AI, and because VIA evaluation is subjective, we had for the VIA images that we have captured through the AI device, so we had 8 experts going through these images to assess the positivity or so, and then we went for majority voting to establish the ground truth. The AI was designed to avoid false negatives, thus favoring slightly more false positives. Initially we obtained the, further about how we did the project, initially we obtained the required approvals from the government authorities and also from the ethical committee from all the centers. We also conducted a baseline survey of the to assess the awareness of the people about cancer. A dry run was also conducted to evaluate the AI. AI was developed indigenously by the research group in Mahe, so it was it is not at the level of commercialization. So we first had a dry run using the AI to decide whether it will be okay to do that, or whether we should have an expert parallelly with the AI evaluating and things like that. So but then throughout the project we had AI as just an additional reading along with an expert evaluation, and then we have compared the performance of AI with in comparison with the expert. We also then went for preparation of the training manuals, we have questionnaires. We had many questionnaires, both quantitative and qualitative, so we validated the new questionnaires. We used some of the existing questionnaires, we adapted some of the questionnaires, and the topic guides for the qualitative study was also prepared. And we had a workshop, and all the partners within India were brought together, and we had a training workshop. And after that we started with community mobilization, and as I said, we have reached multiple different types of partners, so we had to accommodate the differences, and the community mobilization also happened in different ways in different places. It was through ASHA workers that we reached the people. In some other places it was the village heads who could reach out to the people and get the people. In some place it was the organization, the counselors who counseled the people to participate in this screening activity. We had good support that we obtained from the PHCs here in Udupi district. And the VIA was conducted either in PHC or in some hospitals across the India, in different places. It was slightly different. The questionnaires were administered to assess the awareness and experience after the test. So, and that was to evaluate the cost effectiveness, and the client factors and the health system factors were assessed through these questionnaires. Also we had a discussion once we were done with the project, we also had a discussion across all the partners to understand the experiences of each of the people. We shared our observations and experiences through the 3 to 4 years of our project. Data collection was performed to perform the analysis to assess the uptake, coverage and cost effectiveness. Capacity building was an important aspect of the project, and we conducted capacity building initially with mannequin. We trained the healthcare professionals. After that we went for the subjects, the participants who were undergoing VIA, and we had the healthcare professionals trained, and we performed skill test whenever they conducted that VIA. So we have multiple skill tests that we performed, and that is what gives us helps us to quantify how much of effort is involved in training the manpower for conducting VIA with the help of AI. So that was the capacity building activity that we performed, and we saw that it could be really beneficial. Of course, we will have further discussions on that later on. So this particular event today is to disseminate the activities, disseminate the observations and impressions that we have got through these 4 years of project, and also to listen to the experts who have joined us here to understand their viewpoint. And finally we would have panel discussions in which we will brainstorm and understand a few aspects that could be helpful in deciding what could be the future and how would we be able to scale up cervical cancer screening activities. We have this event structured as 3 main themes. One is awareness, mobilization and HPV insights in India. The second session today afternoon is going to be smart screening, technological innovations and India's path to cervical cancer elimination. And tomorrow morning session will be focused on towards national scale up, cost effectiveness, integration and India's elimination mission. We look forward to have our project partners share their experience and to hear from the experts in the field about the comments, observations and their inputs, and to have a fruitful discussion with the various panel members to bring out useful insights that could help India scale up the operations. This is because we need to march towards the cervical cancer elimination as per the targets given by the WHO for the 2030, that we have to have screening covered at least 70%. So we are for, this was a small attempt towards that, and that's from my side about what we are going to have in the today and tomorrow. Welcome you all once again, and happy to have you with us. Thank you.
Thank you, Dr. Kirtana ma'am, for setting the tone so perfectly. That was equal parts insight and inspiration, the ideal morning blend. I call upon Shamla ma'am to hand out a token of appreciation for Kirtana madam. With that, let's begin our first session, Empowering Communities, Awareness, Mobilization and HPV Insights in India. I invite Dr. Bensi Joseph and Dr. Shripad Hebar to chair the session and introduce the speakers. Dr. Bensi Joseph is a scientist at ICMR, National Center for Disease Informatics and Research, Bengaluru, currently working in the National Cancer Registry Program. She is involved in many institution-run projects, including all the principal investigator of a project on evaluating the management of cervical cancer care practices in India using quality indicators. Madam started her medical career by serving in the armed forces, where she was actively involved in implementing cervical cancer screening using pap smears. She honed her skills as a researcher by working in several projects at the ICMR in tuberculosis in Chennai before joining ICMR NCDIR. Her experience spans field level screening, program implementation and national level research in cancer surveillance. I welcome you, ma'am. Dr. Shripad Hebar, Professor and Head of the Department of OBG, KMC Manipal, has been institutional in heading the department for the last 10 years. His areas of interest include gynec oncology, basic and advanced obstetric care, and gynec oncology surgeries. Sir is a member of the Manipal OBG Society, Kasoga and Foxy. I welcome you, sir. I request the chairpersons to introduce the speakers.
Good morning, everyone, and I would like to thank you all for having me here today. Today, our first speaker is Dr. Cherian Verghese. It gives me great pleasure and it's a privilege to introduce him to this august audience. Dr. Verghese works as the coordinator for the management of non-communicable diseases in the WHO Department for Management of NCDs, Disability, Violence and Injury Prevention. He was responsible for the overall guidance and program management related to NCD management, multi-sectoral plan development and research. He has led the area of integrated NCD management and is working on models for populations at district level. Dr. Cherian Verghese holds a medical degree with postgraduate qualification in radiation oncology from India, where he has also trained in health and hospital management. He also holds a Master's of Philosophy from Cambridge, United Kingdom, and a PhD from Tampere, Finland in cancer epidemiology. He has worked in clinical oncology and epidemiology in India, cancer research in Leeds, UK, and has been with the WHO since 2001. at the country, regional and global levels. He has published over 70 articles in the field of NCDs. I now call upon Sir to address this audience.
Good morning, and thank you for giving me this opportunity. I know the audience is experts in every aspect, so it will be like carrying coal to Newcastle if I talk about cervical cancer. But I had the good fortune of actually being part of the initiation of the global elimination of cervical cancer. In fact, when I was in WHO in Geneva in 2015, we were saying this is not going to work. We need to have something very big. We need to have at least 100 million women screened or something like that. So that was the origin of that time. The current DG was running for DG of WHO, Tedros. He took it up and then it became the global strategy. Now let me just give you a bit of a background in the next few minutes. That poster is something that I got it developed, maybe Abhishek from WHO will know, when I was a WHO officer in India office long time back. It was a very catchy one. Are you dying of embarrassment? Because most of the women might not go because of that. But even the system is embarrassed. The system, the governmental system is embarrassed, and that is why we were not able to advance cervical cancer. Very briefly, 1.4 million cases are occurring every year, about 900,000 deaths, and about 3 million prevalent cases. India contributes 9% to 10% of the global burden of cervical cancer. That is very high, okay? And about 8% of deaths. Mortality incidence ratio is in a way the indirect way of looking at survival. If 100 people are getting cervical cancer, what percentage are surviving? We are dying. So India is 62% are dying, Australia 35%, Singapore 43%, and Thailand 53%. Okay? So that is an unacceptably high MI ratio. As we heard, if an epidemiologist has a dream, it is cervical cancer. Because it can be prevented, it can be vaccinated, it can be screened, it can be treated. There is no better disease to manage, and that is why most countries in the world have gone far ahead except us. So everything that one can wish for cancer control is present in cervical cancer. Since there are many students, I think you need to get this clear. When we say elimination, we are not going to say that after elimination there is no more cervical cancer. Okay? There will still be a lot of cervical cancer. So the terms are, one is control. Control is the reduction of a disease incidence, prevalence, morbidity or mortality at locally acceptable level. Okay? Elimination as a public health problem is a term related to both infection and disease, defined by achievement of a measurable global target. Eradication is like smallpox. There is no more smallpox. So please be very clear that when we say elimination as a public health problem, it is not that after that there is no more cervical cancer. There will be cervical cancer, and that is of course extinction and other things. So what is the elimination target? Anybody knows? What is the global elimination target? What is the parameter used for that? Incidence. So the incidence should be less than 4 per 100,000. What is current incidence of India? What is the rate of incidence if we have to reach to 4? Where are we now? About 18 to 20, very depending on that. Okay. So the most important thing to understand is 90-70-90 is not the elimination target. 90-70-90 is the in-between milestone that we have to achieve so that we will reach the 4 per 100,000. So the plan is to reach 4 per 100,000. Okay, and then 90% of girls should be vaccinated, 70% screened as Kirtana said, and 90% should be treated adequately. See, how did we do this? Actually, I was part of this whole process. We looked at various scenarios. So those are the scenarios which will say something like status quo is that line. So if you start with 20, that is the panel A, and then it will just continue like that. Vaccination alone, vaccinations plus 2 lifetime screens, you can actually bring it down. Okay. And if you look at the x-axis, if you start in 2020, by about 2060, 2070 only we will be able to reach. So it is not like that. Okay, this will take time. Remember that. This will take time. It's a long journey, it's a marathon, it's not a 100-meter dash. So the system has to be prepared for that, which is not the case. What are you doing? I'm doing cervical cancer. What are you doing? I did 10,000 screening. So what? I don't know, so what? This is what is happening. No, it's a major effort. It's a major effort to look at the total number of people, how we are going to screen them. Here is a very good example. We think that in the UK cervical cancer is very high, very low. Okay? Why? Because there is very good screening. If there was no screening, England will have more cervical cancer than sub-Saharan Africa. That is very important thing to remember. Why? Because we have this general tendency, oh, cervical cancer, some poor women in poor country are getting it. It is not. Rich women in rich countries are at a much higher risk of cervical cancer because of the very high HPV infection that they have. So this is a very good scenario building. So if you take the screening out, that means the impact of screening is very high. So if you add the mortality reduction, if you add the treatment also into this, you are going to have a much better mortality impact as well. So with all this, we gave this life course approach to cervical cancer prevention. Primary prevention before HPV occurs, girls 9 to 14 years. Ideally, boys should be vaccinated in my view, because boys are the ones giving it to girls, no? So why should only the girls be given the vaccine? So girls and boys, in many European countries, girls and boys are vaccinated equally. Secondary prevention, of course, there is no need to screen at 20 years of age. I think we have to really be very careful, because you have to screen at an age where there is maximum peak of precancerous lesions. Our thing is that, oh, I found one girl who had cervical cancer at 19, so screen everyone from 18. No, you have to look at the population incidence, where it is peaking, and then find 5 to 10 years before that to find the year of screening, okay, the age of screening. So that is why WHO says 35 and 45. Even if when earlier we did even one screening in a lifetime of a woman can reduce cervical cancer by 30%. One proper screening, okay, and 2 means almost 80%. And the third pillar is the treatment. The treatment also is important. We have gynae head here, he will assure that, because in stage 1 and 2 we can get very good survival for cervical cancer actually. Almost complete cure you can achieve. But that is also not happening. What is the average stage at presentation in India? Stage 3. Why should we have that? We say that we have a lot of referral systems and everything. So many of the things are embarrassment actually. It is actually unacceptable. Let's be very honest and brutally honest to the reality. The other thing is that we need not cover up. We have to say the right thing so that we can change things. So that is the global strategy. And the primary target is for girls 9 to 14 years of age. Now there is catch-up vaccine coming. We were actually part of another project called therapeutic vaccine. So even after an HPV infection, we can actually have an HPV vaccine. So that is also under development. So a lot of things are happening. Secondary targets, as I said, boys and older women are also there. So there's a very recent paper from IARC, which is very good actually. It came in vaccine yesterday or day before. Beyond promises, why India must act now to deliver HPV vaccination. Problems are perceived low priority. Why? Because people are thinking that cervical cancer is actually going down as improvement in living standards, less number of children, more genital hygiene, things are going down. But that is called the social vaccine. So there is a social vaccine which is bringing down cervical cancer, but that is not good enough. And as they are saying in China and Brazil it happened. But then with the current behavior pattern of youngsters, this cervical cancer will go up. So this is the right opportunity for India to actually, without wasting a time, go in for universal HPV vaccination. Cost is also coming down, and anyway economies of scale will take up. And some people thinking that, okay, there is no need, we can do other strategies. And Partha Basu also others have come up with this thing saying that we cannot afford to delay HPV vaccine. We have people from Sikkim here, madam will say that Sikkim has achieved 90% coverage of HPV vaccination. Those who have gone to Sikkim will know how difficult it is to climb each mountain and give vaccination. So if Sikkim can do, why not Karnataka, why not Kerala? So we can easily do that. Second pillar is screening. Again, a lot of confusion. It is good that Kirtana and Ardi and others are doing the PRESCRIP-TEC to say what works. Most of the time we are not actually thinking too much. We will just say, oh, okay, we will do VAA. And then what? Then we don't know. So that is not the case. We need to have an end-to-end solution. We need to know exactly a woman X 37 years coming into screening and all the steps that she will go through and until she comes out of that. It is immoral and unethical to screen somebody and leave them without doing the rest of the things, which is happening quite a lot. What is the coverage of cervical cancer screening in India? According to NFHS 5, it is about 4%. That other diagram is something very important that you should look at. That is UK. In 1971, the coverage of the incidence of cervical cancer was about 16, okay, and then it has actually gone down to about 9. So until 1987, you see, is there any change in cervical cancer incidence? No. And the blue line is the coverage. The coverage was less than 40%. So they put a lot of effort, increased the coverage to 90%, and then incidence came down. Okay? And what is our coverage? 4%. Are we going to see any difference in 400 years? I don't think so. So where is 4% and where is 90%? So the scale, the magnitude of issue is so big. 200 women screened here and there is not going to make a difference. What is the population of Udupi? 1.1 million, 11 lakhs. How many women? 5 lakhs. Even if you take 30%, 1.5 lakhs women to be screened. How many women are screened in PRESCRIP-TEC? Yeah, in Udupi?
7,500 all India.
All India 7,500. Udupi alone needs 1.5 lakhs. I will leave it to you to decide the maths. So what are the elements of screening? You have to actually invite people, apply a test which is safe, highly sensitive, specific and easy to use. Test result should be unambiguous. One of the most difficult things in cervical cancer is that it is either this way, that way, come back, and the woman will never come back. Okay? So remember this sort of a diagram, that you get women, come to a facility where there is all facilities to screen. If you tell a woman to go into PHC and get screened, she will go there, nothing will happen, and she will go and tell 10 other women that no need to waste your time. So we need to make sure there is supply side and demand side. One problem in public health is that we are not looking at supply side. We want to go and train each woman to be gynecologist. That much public education is given. When she comes to the health facility, are we providing that? No. So we have to make sure that happens, and then the whole thing. So I think what every health system should do is, before screening, is that am I ready to do screening? So there should be a checklist. Is there a national policy how to invite women in the eligible group? What level of health system will do the screening? Will they have a personnel who can have the testing capacity? How many people can they screen every day? Are they adequately trained? Where is the treatment for pre-cancer? Where will cancer be treated? Who will bear the cost? You have to answer those questions. Only if it is yes, you should start. If it is no, you are actually wasting time of everybody and wasting resources. You have to communicate effectively. The communication has to be very different at policy level, program level, implementation level, and potential participants. Okay? You have to segment your target and communicate effectively, because what the policy maker wants to know about cervical cancer is not the average woman in Udupi wants to know about cervical cancer. So the strategic actions, I think new HPV, 2 more HPV tests have been pre-qualified by WHO recently. So I think more work is needed in that area. Once we get a very good HPV test, things will be much better. Or if there is an AI which comes up, that is also fine. Finally, the treatment pillar, again the same problems. An average woman takes about 80 to 90 or even 120 days from the sign of symptoms to get treatment, because there is no clear referral system. So they go back and forth. Sometimes the stage 1 will become stage 2 by the time she gets treatment. Okay, so that is what it says, that cancer may or may not kill, but delay certainly kills. Okay, so delay in diagnosis, delay in treatment. And again, there are enough gynecologists who can manage cervical cancer adequately. Don't forget about palliative care. In my clinical career, one of the two most difficult diseases at the end stage are head and neck cancer and cervical cancer. They are making people miserable to the core. Every system gets affected, and usually these two happens unfortunately to poor people, so they don't get any palliative care also. So those who do palliative care make extra effort. Finally, what do? We need to measure everything. What gets measured gets done. Okay, so we have to measure it properly. How many women are screened? How many women are test positive? How many women are managed? Is it possible? Yes, Bangladesh, a country which is even slightly lesser capacity, can have screened 1.5 million. Among them 1.5 something million have they invited, screened. Among that, how many were positive? 40% were positive. How many had colposcopy? About 6%. And among those, how many had cervical precancer? About 81%. And how many have been treated? So the whole chain they could work out. Even interesting is Bhutan, almost like Sikkim. Bhutan has actually done 90% coverage. Bhutan is the first country to achieve 90-70-90. It's a very small population, but a lot of difficulties. But even then they could achieve 90-70-90. The summary is that we need to have cervical cancer screening vaccination and treatment to make a change in incidence, change in survival and change in mortality. And elimination is feasible. Status quo is not an option. You have to learn by doing. Don't just start something. Do a phased approach with constant monitoring. Why? Because by tomorrow evening when the meeting is over, 700 women would have developed cervical cancer and 425 would have died from cervical cancer in India. So now you decide what to do. Thank you.
Thank you very much for your lovely insights, sir. Now I call upon Dr. Hebbar to introduce the next speaker.
Dr. Abhishek is here. Yes. Yeah. So he's a WHO representative from India. I came to from LinkedIn that he has worked as a manager in clinical pharmacology unit, Jubilant Life Sciences, from 2006 to 2010. Is it right, sir? Yeah. And he was a deputy research team lead, WHO India, from 2011 to 2018. He is a national professional officer, non-communicable diseases, 2023 onwards. He is a physician, he is a public health leader, and he is an epidemiologist too. So I invite Dr. Abhishek Kunwar to the podium to deliver his lecture.
Thank you, sir. Thank you, ma'am. Thank you for inviting me. And sorry I could not join my bio. Thank you. First of all, I would like to thank Kirtana ma'am and Mahe for inviting me for this such a important topic which is being globally discussed, and India is one of the topic which has been discussed almost daily in all levels of the policy makers at the national and the state level. And after Dr. Cherian presenting, Cherian has been my teacher, so after his presentation it's very difficult to present because he always presents like a teacher, and I keep on learning from him. Today I was telling that there are a couple of slides I want because I learned a lot from your slides. So thank you, sir. Thank you for this presentation. So I will just give you the overview of the current screening process and status for the cervical cancer in India. So if we start with the burden in India, so after the breast cancer, cervical cancer is the highest burden in India among the females. And in terms of the incidence, what Dr. Cherian has already presented, India accounted for the 19.3% of the global cervical cancer cases and responsible for around 22.9% of the global cancer deaths, cervical cancer deaths. So you can just imagine the number of the incidence and the deaths due to the cervical cancer. So this data itself shows that there are a lot of challenges and gaps which needs to be fixed to reduce the burden of the cervical cancer in India. So NFHS data Dr. Cherian has already presented. I will not go into detail of that. But if you focus on the screening coverage, the 1.9% of women aged between 30 to 49 years of age has been screened as of now, and it's not there is a not very variation from the rural or urban as we talk always there. But there is a disparity and the variability among the states from the northern and southern states. If you see this, the percentage of women, including the income wise also, there is a variability. But state wise, there is a variability from the region, from north to south and east to west. So southern states are doing better in terms of the screening, including Tamil Nadu, Kerala, Andhra. So these are the states which are doing better in terms of the screening as per the NFHS 5. But if you come to the current process of the cervical cancer screening and referral process in India, so it starts from the community level where ASHA starts with the feedback form and do the checklist for the assessments for risk scoring for the NCDs. That also includes hypertension, diabetes, and 3 common cancers. And then it goes to the Ayushman Arog Mandir, where CHOs has the role for doing the VIA screening, what we are talking now. India primarily does the VIA screening for the cervical cancer at the public health sector. And also there are symptom-based screening also being done. I will briefly talk on that also. And then the third referral is at the primary healthcare centers, where if you see the referral mechanism starts from the ASHA level at the community, then goes to the Ayushman Arogya Mandir Health and Wellness Center previously called, and then the primary health care center, the PSCs, what we call, or urban health center in the urban area. So then the fourth referral is the community health center, where the medical officer and specialist and NCD nurse and counselors, there is NCD clinic is there at the most of the community health centers, and the key roles also the confirm and manage the referred cases. So this is the referral mechanism. What I say, it may not be what is written here, may not be all activities are being done at the all levels, but this is the main norms which has to be followed in terms of the referral mechanism. But there are a lot of gaps and challenges. It may look good here, but there are challenges. So then it goes to the district hospital, where gynecologists or the female medical officers are there, and NCD clinics are there, counselors are there, where the confirmed diagnosis, referred cases for VI colposcopy and biopsy is done, and then they manage the pre-cancerous and the cancerous cases, and then link it with the tertiary care. So there is the linkages from the secondary. So mainly if you see the Ministry of Health, Government of India or the state government, it caters till the secondary care level, and then the referred for the final diagnosis and the further treatment goes to the tertiary care. But the good thing is that now Government of India, Ministry of Health is coming with the establishment of the daycare centers, chemotherapy at the secondary care, mostly all the district hospitals. The process of the establishment and planning is ongoing. So that will take care of most of the chemotherapies at the secondary care level itself. So, but this needs a lot of logistics and a lot of preparations. But I think this is a good initiative by Ministry of Health in terms of, and then the linkage, the final linkage is the tertiary care. But all this, the chain which I am trying to mention it here, is all the continuum of care. Starts from the community till the tertiary. But there has to be a referral, upper referral and the back referral, because this needs the long-term treatment, long-term management for cervical cancer or any other cancer also, if it is in the scope of the linkage methodology. So the whole issue lies between the dropouts. So when the linkage is established, there are dropouts, and I will show you in my further slides. So if you talk about the screening, what under the NP-NCD program of Government of India, so there are two types of screening is being done. What I mentioned about the population-based screening, for all the 30 plus females are being screened for the cervical cancer, and at the community level and the Ayushman Arogya Mandir level. So population immunization is done in the population-based screening, risk assessment. There is a CBAC from which is ASHA's fields, and the community mobilization for the screening and health promotion. So these are the four components which are covered in the population-based screening. And then opportunistic screening, when when the female goes herself to any of the health facility. So based on the age group of the 30 plus, the opportunistic screening at the health facility itself, the screening can be done. So the ASHA feels conduct the household assessment and educate and motivate refer risk individuals. Risk means that in any individual with a risk score of more than 4 are prioritized for the screening. And of course, the population-based screening is all meant for the early detection. So as Dr. Cherian mentioned, so when we detect, we try to detect early, but delay in the treatment, there is the problem. So early detection and early treatment, that is the whole idea of the population-based screening and all the screening programs in India. So if you see the Government of India, the screen and treat approach, so it all talks about and based on the framework of the operational framework and the NP-NCD program. So eligible women 30 plus undergo the VIA at primary health care. So that is the norm which has to be done. So there are if the negative, the re-screening will be done after 5 years. If suspicious of cancer, refer to the tertiary care center. There are linked tertiary care centers for the cancer care. Ministry of Health and many of the states have this for the further management and treatment and continuum of care. The positive cases found through VIA at the primary health care, if lesions eligible for screen and treat, then cryotherapy or thermocoagulations are being done, and then follow up after 1 year with the VIA. Second is the positive but lesions not eligible for screen and treat, so then refer for colposcopy to the secondary care level or the tertiary care level to the gynecologist, and then the treatment will follow up based on the diagnosis. So the three methodology of the screening which has been adopted, which has been currently done, not adopted, currently been done at the India mostly. It's the VIA, visual inspection with acetic acid. This is the mostly done at the all healthcare facility level of the public health facilities from Ayushman Arog Mandir, primary health care, community health centers, district hospitals, and the many of the tertiary care centers. Pap smear is being done, but this is to be done by mostly at the secondary care or the tertiary care, and some of the states are doing it the camp basis also in the monthly basis. And the HPV DNA test mostly done at the tertiary care. So that we will be hearing from this implementation study how the HPV DNA will be the more appropriate for the screening in the future, and which will derive the best screening methodology, hopefully. So detects high risk HPV infection, the main cause of cervical cancer, and highly sensitive, what WHO also recommends, as we have heard from Dr. Chiri. So now if you see the actual data, so I'm trying to present some of the data which is which will give some understanding of the continuum of care for cervical cancer screening trend. If you see in the last 5 years, so very categorically, number of women screened saw a significant increase from 5.6 million. So we need to appreciate this also. So in 2020-21, around 5.6 million females were screened. Now if we see in 2025, there is a 10-fold increase. So there is a system to screen. So I'm talking about screening now only. So there is a system to screen. I'm not going to quality of the screening. I'm not talking about the referral mechanism or the diagnosis or treatment. So if you see, there is a 10-fold increase in screening, and coverage is now 1/3 of the target population of the screening. If you see the denominator, the number of 30+ population for female, so out of that, around 1/3 of target population has been screened, and the focus must now shift maintaining this trajectory and closing the remaining 65% gap. So there is still 65% gap of the screening. So if you take the whole number, so there is a gap of 65%. There is a 10-fold increase in last 5 years, but there is a gap of 65%. So this trajectory shows that how the screening has improved year by year from this 0.56 crore to the 5.68 crore. So there is a good increase. Yeah, that is a good achievement what all the states and the Ministry of Health has been doing. So now if we come to the other component, if you see this data, the cervical cancer referral. So referral means screening till the treatment. So there is an issue. There is a good achievement, but there is an issue. So how? So this can be seen like this: that screening coverage among enrolled women. When there is the enrolled women, 2 minutes, 5 minutes. Just so screening coverage among enrolled women 30+. So if you see that out of this, the women who are enrolled, only 17% were screened. Primary screening I am talking about. And then referral to screening and completion, if you see, out of those screened, so around 27% were screened after referral. That is more likely VIA, or there are some symptomatic screening also being done at the Ayushman Arog Mandir by CHO. But mostly it is VIA. And then, but the issue is again remains about the 72% referred but not screened. So there is a big gap what we are talking. There is a good achievement, but still there are the issues and challenges in terms of referral, in terms of the quality. Treatment among diagnosed cases. So among the diagnosed, so on treatment is 78%. So at least out of the diagnosed, 78% patients are put on under treatment. But we are not aware about their follow-ups, their continuum of care, their treatment continuity. Only this is the data which is the first time initiation of the treatment. So out of those, around 78% patients are put under treatment. That is also a good achievement in terms of the treatment. In terms of the care cascade trend in last 5 years, you see the cervical cancer diagnosed increased significantly. I am talking about diagnosed now. So from the 3,308 in 2021, now it is around 50,000. So it's a good increase in terms of diagnosis. In terms of under treatment also, from nearly 2,000 to around 37,000. But there is if you see in terms of the care continuum gap, there is still an issue in terms of the continuity of the care. So, but there is an increase in terms of the treatment, in terms of the diagnosis, in terms of the screening. But the follow-up and the continuum of care still remains to be seen. So as Dr. Cherian was talking about demand side and supply side. So demand side, of course, the VIA, there is an issue, there is a stigma, there is a myth, and a lot of social challenges in terms of the VIA because of the process is being followed, and the awareness is one of the key where the low awareness among the population. But the supply side, which is more important, so limited reach to the government facilities, quality of screening, what we are talking about, quality doesn't mean only the type of screening, also means the whether it's acceptable or not acceptable, and awareness is there for the court to take that quality. Subjective nature of the VIA, inadequate follow-up and referral mechanism, which I have shown in my data. Data management gap, the information system is the key. You learn with the data and you work while implementing. So you improve by implementing and learn from the data. If you don't see the data, so I don't think there is a chance of learning and improving. So we have to see all data has a quality, and all data can be seen in a very broad way and in a very micro level also. And then resource constraints, we all know that there are some resource constraints are there in terms of the supply side. So this is my last slide. And Dr. Cherian, I will not talk about 90, 70, 90, we all know about this. But building on that, we need to see all collectively, because this is an academic institute, and Manipal Institute of Technology is also associated with my family, because many of my family members have alumni from this institute. So this is my first visit, but I think a lot of academicians are here, experts are here. We need to come up with the operationally feasible. We are talking for India, 35 states, union territories. It's not like small country. We did a hypertension project. Hypertension is easy to manage in community. It was one of the most successful NCD project in India, which received a global UN award. Ministry of Health received. But again, the control rate, we are still struggling for the control rate. It achieved 50%. Now it has gone down when number is increasing. So we need to maintain this quality, but operational feasibility is very important, cost effective, and high performance test for cervical cancer screening at community, primary and secondary level. It may be HPV DNA, any equivalent, any AI based, or VIA positive with HPV DNA, VIA negative for HPV DNA. There has to be some sort of evidence, and good evidence for the policy makers. WHO promotes, and I will not go into that, but WHO has to come with the best practices which country has adopted. There are many countries, there may be many other pockets in the world, those who have done this HPV DNA testing for the screening, which has given a good result globally. We need to come, WHO also needs to come with those best practices and present to the policy makers. And expand screening capacity and strengthen referral and follow-ups to avoid dropouts. See the data, and based on the data, we have to expand the screening capacity based on the whatever means available. And what's more important, screening without access to treatment is unethical. You diagnose patient, you screen patient, and then don't do anything. I think that should not be it. You screen small and treat better. But if you don't have the treatment, if you don't have the service for the treatment, please don't go for the screening and leave the patient in between. That is very unethical. Strengthen health systems and workforce, that is an ongoing process, training, capacity building, information systems, treatment protocols, it has to be there. But the more important is that we have to come together to generate scalable and sustainable evidences in the country context for the policy makers for the cervical cancer screening. We cannot come with some examples which are not replicable in India. We see many times some examples come from some small pockets, some pilots, and then we want that replicate India. I think it's one of the biggest challenge. India, you know that India, the health is a state subject. We need to factor all the policy level and all the administrative level in the mind before coming with some very scalable and sustainable model. So I will stop here, and thank you very much for the opportunity. I again thank Krishna ma'am and all of you for this opportunity. Thank you very much.
Thank you, sir, for grounding global vision in local reality and for reminding us that progress isn't just policy, it's persistence. I would like to invite Dr. Bensi ma'am and Hebar sir to hand out tokens of appreciation to the speakers. Sir, could you please join us? I would also like to invite Dr. Kirtana ma'am to hand out tokens of appreciation to the chairpersons. Thank you, sir. Thank you, ma'am. I would like to invite Dr. Aarti to commence the inauguration ceremony.
A very good morning to all the assembled dignitaries, delegates, participants and organizers of the PRESCRIP-TEC closing conference today. I am Dr. Aarti Rao, Additional Professor and Head, Department of Global Public Health Policy and Governance, Prasanna School of Public Health, Mahe, Manipal, and also the co-PA of the PRESCRIP-TEC project, and I have the privilege to take you through the inauguration of the conference. We have with us Dr. Prashant Bhatt, District Vector-Borne Control Program Officer, representing the Department of Health and Family Welfare, Udupi, as the chief guest. The inauguration will be presided by the Pro-Vice Chancellor, Faculty of Health Sciences, Dr. Sharad K. Rao. May I request Professor Kirtana Prasad, Lead Investigator of PRESCRIP-TEC, to escort the dignitaries onto the dais. Thank you, everyone. To invoke the blessings of the Almighty, we shall now proceed with the invocation song to be rendered by Professor Shamala, Professor for BGYN and Co-Principal Investigator of the project. I request everyone to kindly remain seated.
काले वर्षतु पर्जन्या काले वर्षतु पर्जन्या पृथ्वी सस्यशालिनी पृथ्वी सस्यशालिनी देशोऽयं क्षोभरहिता देशोऽयं क्षोभरहिता सज्जना सन्तु निर्भया सज्जना सन्तु निर्भया. Thank you.
Thank you, Dr. Shamila, for the melodious rendition. PRESCRIP-TEC project has lit the lives of close to 7,500 women across India With the same thoughts, we shall now proceed with the formal inauguration of the conference with the lamp lighting ceremony. May I request the dignitaries on the stage to do the honors, please. Thank you, everyone. May I now request Dr. Kirtana Prasad to welcome everyone present here.
Good morning, everyone. It's my privilege to welcome you all to this event, the PRESCRIP-TEC closing conference, as we come to the end of the project period in the last 4 years, and we are bringing the curtains down. It's a time when we put things together, share our experience and observation, and disseminate our findings. PRESCRIP-TEC project began with a call from Professor Yap Koot, who is a professor of public health from University Medical Center Groningen, who approached us based on our publication of an AI approach that we had published. We had the AI that we developed and we had published as a part of a PhD project. We were invited to be a part of the consortium to submit the proposal to the Horizon 2020 grant call in 2020. Even though the selection was announced by the end of 2020, the funding from DBT, that the Indian activity was supported by DBT, and the funding had arrived by the end of 2021 November. So this project has been running from 2021 November till now. Due to various reasons, the fund disbursements were delayed. Hence, we have got, this was a 3-year project, but we got a year of extension, and because there were delays in the funding that we received. It has been a wonderful experience with a lot of learning and exposure. We are here to share with you our observations, listen to the experts in the field, and brainstorm the possibility of upscaling to meet the WHO 2030 target for cervical cancer screening. Our activities in Udupi district was fully supported by the Department of Health Udupi. It's our honor to have Dr. Prashant Bhatt, District Vector-Borne Disease Control Officer, Department of Health and Family Welfare, Government of Karnataka with us as the Chief Guest of the occasion. On behalf of PRESCRIP-TEC team, I extend a warm welcome to you, sir. Our university management has been the pillar of support throughout the project period, even during the delay in funding. MAHE has supported in providing the salary to all our research staff. We have with us the MAHE PVC Health Sciences Dr. Sharath Rao, who has readily agreed to preside over this function. A hearty welcome to you, sir. We are going to have experts from various organizations share their knowledge, including Dr. Bensi Joseph from NCDIR, Dr. Abhishek Kunwar, who has just given us the talk from the WHO country office, Dr. Anu Uman from CMC Vellore, Dr. Esmi Okur from CFCHC Tamil Nadu, Thanks for accepting our invitation and coming down here to Manipal for this purpose. A warm welcome to you all. We do our project well due to the active support of the medical officers of various PHCs around Udupi. We will have 3 of the medical officers present their perspectives in this event later this day. They will join us slightly later in the afternoon. I welcome each of them in their absence. We have 7 organizations as part of this consortium from India, including TMC Kolkata, CNCI Kolkata, SMU Sikkim, TMH Mumbai, SAMC and Swasti from Bengaluru, and SDM Udyavara. We have the PIs and investigators and research staff from these centers who have joined us here, who have come from far across the country too. Thanks everyone for joining us on this occasion. We have Dr. Shripad Hebbar, head of OBG, KMC Manipal with us. He has chaired the session now. We are happy to welcome Dr. Shripad Hebbar. Dr. Cherian has supported us during this project, actively guided us in organizing this event too. He has just now addressed the delivered the address. Thank you and welcome you, sir. Welcome to the university officials, faculty and staff of various institutions of MAHE, all the participants of this conference, the volunteers from the 3 organizing institutes, namely PSPH, KMZ and MSIS. Welcome you all, a very warm welcome to you all, and thank you once again.
Thank you, Kirtana. I now proceed to request Dr. Prashant Bhatt to provide the chief guest address.
So, good morning. Respected Chairperson, distinguished faculty of PSPH, esteemed guests, students and colleagues. It's a privilege to join this conference hosted by Prasanna School of Public Health, MAHE, one of the finest public health institutions in India. PSPH consistently commit itself to evidence-based practice, field epidemiology, health system research, and its close collaboration with national health programs is commendable. That makes it a true leader in shaping country's future public health workforce, you all know. Their contributions to maternal health, digital health innovations, health financing and operation research continue to strengthen India's public health architecture. So it is both an honor and responsibility to address this august gathering on a topic that is profoundly impact women's health in our country, as already spoken by various speakers earlier. Cervical cancer, a disease that is largely preventable, continues to claim the lives of thousands of women every year in India. Cervical cancer remains the second most common cancer among women in India, contributing to nearly 1/5 of global burden. According to ICMR and WHO estimates, we record over 120,000 new cases and approximately 70,000 deaths annually, already spoken by various speakers earlier. So what makes this particularly tragic is that cervical cancer is one of the few cancers that can be completely preventable through vaccination, early screening and timely treatment. The paradox we face today is not the lack of technology or the medical knowledge, but rather a gap in implementation, awareness and equity. In the last decade, India has made commendable strides, my earlier speakers have already spoken about it. NPCDCS has integrated cervical cancer screening at the primary healthcare level. Operational guidelines for screening and prevention of cancer, cervical cancer, is published in 2016. It laid a robust sort of framework for VIA-based screening. The recent launch of India's indigenous HPV vaccine, Cervivac, makes a game changer. Its inclusion in the universal immunization program is a major step forward in eliminating cervical cancer as a public health problem. States like Sikkim, Punjab and Delhi have initiated school-based HPV vaccination with promising results. Yet, despite the policy intent, coverage remains very, very low, both in vaccination and screening. This gap must be our collective focus in this particular conference. The barriers to cervical cancer control in India are multifocal. Low awareness among women and communities about disease and its preventability. Cultural stigma, gender barriers prevent women from accessing gynecological care. Limited trained manpower at the PSCs for VIA or pap smear screening. The fragmented referral pathways and inadequate follow-up for positive cases, out-of-pocket costs for HPV vaccination in private sector and its limited access. Addressing these requires multifocal collaboration between health systems, education, community organizations and private sector partners. To move from aspiration to elimination, India must focus on 5 strategic pillars: awareness and advocacy, HPV vaccination scale-up, screening and early detection, treatment and palliative care access, data, research and innovation. As health professionals, educators and policymakers, our role extends beyond the clinic. So we must advocate for policy coherence across reproductive health, adolescent health and NCD programs. Leverage CSR partnership for HPV vaccination and awareness drives. Engage medical colleges, NGOs, local governments to create sustainable community-based screening models. Encourage indiscriminatory, interdisciplinary collaboration between epidemiologists, clinicians, social scientists, and educators. So WHO's strategy calls for 90-70-90 target, I already told. So India has the scientific capacity, political will, and community resilience to meet these targets, but it demands urgency, accountability, and innovation. Let this conference not merely be a platform for discussion, but a springboard for action. So that is my wish. So every mother, sister, daughter, deserves a life free from preventable cancer. So as we stand at the intersection of science, compassion, and leadership, let us commit to making cervical cancer elimination a reality in our lifetime. Thank you for this opportunity. Jai Hind.
Thank you very much, sir, for your motivational words about the project as well as the activities. Your presence reflects your support for collaborations with MAHE. Thank you, sir. I now request our Pro Vice Chancellor, Dr. Sharath K. Rao, to deliver the presidential address.
Dr. Prashant Bhatt, Chief Guest of today's function, Dr. Kirtana, dignitaries in front of the dais, respected resource persons, esteemed faculty members, and my dear delegates. Greetings from Manipal Academy of Higher Education, an institution of eminence. It's an honor and privilege for me to be in this august gathering of interdisciplinary scientists and the policymakers together. I think this is the way forward for any disease is concerned, where public health, clinician, people from technology, and the policymakers have to come together to meet the challenges of any disease. forums like this create futures for healthcare system. I'm an orthopedic surgeon and novice to talk in this particular field. I know that India is a center for capital of cervical cancer as well as diabetes in the world. Highest number of cases, maximum cancer related deaths among women in India. I think this is time to have a policy in place. We have a technology. Look at what we have created. After technology has invaded medical science, even in my field today, robotics are the ones which help us to do perfect surgeries. Even in the field of cervical cancer, mobile devices, artificial intelligence in interpretation of results, all these are, or any kits which are tailor-made for prevalence in India and self-sampling, all these are game changers. But all these game changers, tools, unless they are scaled up, will remain as pilot studies. It is important to scale them up so that it reaches to every woman, every eligible woman in the remotest areas, in the underserved areas, and which is the most difficult part, looking at the terrain in India. You need to have a multi-pronged approach for scaling up, creating awareness, creating war against misinformation and taboos. And every woman in India understands the importance of screening. And we need to move away. Many camps are held. I've seen even the camps for healthcare which are being held is fire and forget. We have to move away from fire and forget to screen and treat. And that is important. And integrate whatever tools which you have created into a primary healthcare system. And that is when the success story starts. And you have a vaccine which will prevent the disease, and we need to move from 90, 70, 90 to 100. Maybe in 2040, you are the young generation who will be the torch bearers for this. Yes, we have eliminated many diseases from the world. Let us target for 100 of WHO in 2040 and eliminate cervical cancer from this world. Thank you for the
Thank you very much, sir. We are extremely grateful for your presence and encouraging words. And from the project, we are extremely thankful to Mahi for the constant support over the last 3 years with the project. May I now call upon our project manager, Mr. Aditya Bharadwaj, to propose the vote of thanks.
Good morning, everyone. And as we know, we have come to the conclusion of the inauguration ceremony. It is my honor to deliver the vote of thanks on behalf of the organizing committee. First and foremost, I would like to extend our deepest gratitude to our esteemed Chief Guest, Dr. Prashant Bhatt, and our Pro Vice Chancellor, Dr. Sharad Kumar Rao. And their valuable insights have significantly contributed to the success of this event and provided us with much to think upon. And to our dedicated organizing committee and volunteers, thank you for your tireless effort and meticulous planning. Your hard work has been behind the scenes and ensured us to make this conference go smoothly. We will also like to extend our appreciation to our partners both within India and internationally, and also our District Healthcare Administration of Udupi, without whom this project couldn't have gone ahead. And a special thanks to our participants, poster presenters and attendees. Your presence is also enriching our discussions over here. I would like to thank the technical team from our AV department. Thank you for ensuring that our sessions run seamlessly. And I would like to thank the people who were not able to attend, like Major General Dr. Atul Kotwal sir, Dr. Neha, and they were supposed to be a part of our event but couldn't because of some unforeseen circumstances. Lastly, I would like to thank the venue staff for their excellent service and hospitality. In conclusion, thank you all for once again for your invaluable contribution, and let's have a great conference ahead of us today and tomorrow. Thank you.
Thank you, Aditya. We have come to the end of the inaugural ceremony. We will now proceed to the tea break and reassemble back in the hall by 10:50 a.m. for the next session. We request everyone to join us for the tea. Thank you.
Welcome back. I hope your coffee was strong and your curiosity stronger. We now dive into community engagement, the real heartbeat of implementation. Our first speaker is Dr. Anu Mary Uman, professor from CMC Vellore, talking about community engagement for cervical cancer elimination, experiences, barriers, and facilitators. The talks will be chaired by Dr. Sherian and Dr. Abhishek Kunwar. Sir, welcome you.
Thank you. So the first speaker is Dr. Anu Uman. Dr. Anu Uman is a professor of community medicine at the Community Medicine Department, CMC Vellore. She has been involved in managing a community-based breast and cervical cancer screening in the rural Vellore for last 10 years. She is currently also conducting implementation research on improving screening among vulnerable populations, with a special focus on tribal women as a part of a study being conducted in Tamil Nadu and Mizoram. That is called the SHECAN study, SHECAN study. I am also listening first time. Dr. Uman is also involved in primary and secondary level of care in rural and tribal areas and teaches public health and epidemiology in addition to research on NCDs. So I invite Dr. Anu Uman for her talk. Thank you.
Thank you, sir, for the introduction. Am I heard well? Yeah, thank you for the opportunity to present today. So as mentioned, I'm from CMC Vellore. And I just want to say what my perspective is, where I'm coming from. So since I work in a private charitable institution, so it's not the government perspective, it's from an NGO perspective. And I work at a secondary hospital level as a community medicine consultant, but I also work in primary care, which means we have outreach work in rural and tribal areas around Vellore. and also my experiences are based on the last 10 years of experiences in conducting community-based cervical and breast cancer screening in the areas around Vellore. And also another implementation research study similar to PRESCRIP-TEC but at a smaller level, which is called the She Can study, which is also funded by the GACD, and this is being done in Tamil Nadu and Mizoram. So this study had 3 parts, and we had finished the formative mixed methods stage where we tried to understand the context, and then we co-designed the intervention, and currently we are conducting an RCT, which is comparing community-based self-collection to facility-based self-collection. So my experiences are based on all these. So what do we mean by community mobilization or community engagement? It's basically about generating support for the women who need that service. So the women who need screening need support from the community so that they can participate, and there is it is sustained over time. So health systems or health services set up the screening, but people need to utilize it. So how do we mobilize community support for these women? So we need to engage communities so that they can overcome those barriers that they have to participate in screening or in follow-up. So who are these communities that we need to engage in? So it's not just the women who need the screening or the target group, but also their families. So the spouses, the children, as well as all the people who can influence the women in their decision to screen or to come for follow-up. So when we say community engagement, that means we have to think of engaging with all these people. And very often our engagement is limited just to the women who need the screening. And as I said, the reason is because women just have so many barriers, and to overcome all those barriers related to the test, about their own motivation for screening, or all the societal attitudes that go against participation, to overcome this, they need that community support. So when do we engage with the communities? Right at the beginning, ideally even when we are planning the program, whether it's program or research, at that time, when we set the agenda, as well as implementation. When we are carrying out the program, we may need to engage the communities, and later when we are trying to evaluate the program, we may need to again engage with communities to find relevant outcomes and to obtain feedback. So I just want to give some examples from our research. So at this stage, like similar to PRESCRIP-TEC, when we were writing the proposal for this GACD funding, we went to the community first to see whether cervical cancer was really a priority or not. Like, it was a priority for us because as healthcare professionals, we are seeing so many late stage cancers. But when we went to the community, especially to the tribal communities, we found that they're not really bothered. Like, they're not really wondering all the time, will I get this particular cancer, which is after all a rare disease. They have so many other common problems in their lives that they kept digressing to those problems. So when we say we are thinking about doing cervical cancer screening, but there are so many other things that you can do for us and not this. Whereas many other conditions, like when we go for diabetes, then everyone is aware and they all really want those services, they consider that a priority. But cancer is a rare disease, so it's very often not really a felt need of the people. They feel they don't really need it anyway. So that's the thing. So we feel that the cervical cancer and cervix is such a big problem, but for the people, there are just so many other problems. So we've actually felt a bit of a letdown at this planning stage, saying we are doing something that we know the community is not really interested in. So this is going to require a lot of motivation because they don't consider it as a need. So, and that's at the planning stage. Then when we are implementing, now how do we actually go about engaging communities? So there are of course multiple examples, and I've just put some references from different countries around the world. Different people have used different strategies, but I've mainly just looked at whether they were mass communication or whether they had some kind of interpersonal approach. So the mass communication, now that cannot happen in research projects, or it doesn't usually happen in research projects. it usually happens, it can happen if it's actually a national program or say a state level program where you can, that because everybody can actually have an opportunity to be benefited. Whereas in research projects, often we've selected very defined areas and we're not able to, example, offer HPV self-collection to the whole state or the whole district. So we often do not use these kinds of mass communication because it's not yet a program. But having said that, our current national program, it looks like we are not doing enough of the mass communication as has been done in many other countries. So the picture that I've put there is actually from Australia at a tram stop. So how they are advertising cervical screening self-collection in all public places. So behind buses, at public these kind of stops, etc. Because that we don't see so much in India. For even if it is just VIA or regular cancer screening, it's probably being underutilized. And but mass media, the disadvantage of course is that it may not work for people who have never screened, who have no motivation. They may need more interpersonal communication, especially when you talk about something totally novel like self-collection. So interpersonal communication, so it could be either at the individual level or it could be group level. So individual level communication, which is usually to the target women, that is usually through either door-to-door education or opportunistic screening if a person is coming to a facility and they get individual communication from the nurse or the doctor. The advantage of course is there's a lot of chance to clear doubts and give privacy for a woman to make decisions, and there's no need to wait to gather people in any meetings, etc. But it can take a long time. The disadvantage is it can take a long time and you don't get that advantage of group meetings, which is peer motivation, peer support. So there are examples, and I've put one study which was done by Dr. Basu's team where they had actually used door-to-door engagement to actually get women to screen. The other, which is group level education, is probably done much more commonly. In fact, there was one study that was from a review of studies from Latin America and Caribbean countries, where they said 85% of the countries had tried some form of group education to promote screening. And so when we say group education, it may be group education just for the women who are being screened, but also it could be group education to the whole community. As I said, we need the whole community to support the women who have to be screened. So their families, so men, the older women. And in our project, we actually also tried to engage the children. So school-age children, getting them to motivate their mothers to at least come for the meetings. Like, not necessarily that they have to know all the details, but basically getting the whole community to take responsibility for the women in their families. Like, all of you can motivate the women in your families to get screened. And group education, the big advantage for, especially in women who are never screened, is people get an opportunity to discuss together, clear doubts, and they see that this is an acceptable, the screening is acceptable to others in their community, and they may be more likely to take it up, and this reduces stigma as well. So group education has been used in many places and is found to be effective. Not only families, we also have to engage the other people who can influence the women. So again, in different projects around the world and in India, and what we have done is including people like religious leaders or local village leaders, etc., educating them first and getting them to support the screening in their community so that it is seen as something that is accepted. And there is visible support for the women who choose to screen. And also the community health workers, so they may be the government health workers, or if it's a private organization, they may have their own. So all the people who are known to the communities and who can really influence the people need to be engaged. Of course, this is not easy, and I think the main barrier is that it's always difficult to find these people. So what we have found is that now everywhere we go, people are working in the daytime. So how do you meet communities? How do you meet men? Because they are not available. So then we may sometimes have to have it at late night, and that becomes an issue as well, especially if they are remote locations. The key facilitator for these group meetings, and that has been reported all across the world, is partnership. So the government alone cannot really do this kind of intensive engagement. So they need to partner with NGOs, private institutions, communities, so that they use the fact that people trust these entities, and together they can actually spread the message better. And the other thing that can also be done is to engage with communities to help to design the materials for education, that they themselves can be part of the designing educational materials, and we have done this in our study with tribal women. Finally, another key importance when we engage with community is the messages that we use, especially that the messages that we spread should be such that we avoid stigma. So that the fact that HPV is a common infection, and we don't really focus on risk factors, but the fact that all women above a particular age need to be screened, and including messages for men, children as well, so that it's not just about women. So in summary, interpersonal communication is very effective, but it can be resource intensive, so it's good for the government to actually find local partners to deliver this better, and we may need to use a variety of flexible methods. And co-designing messages and materials with the communities may have better impact. Yeah, I just want to thank my own project team, which is from multiple institutions in India and elsewhere. Thank you.
Thank you, ma'am. I request sir to honor the speaker. Up next, we have Dr. Esmi, radiation oncologist from CFCHC, Tamil Nadu. I request Sherian sir to introduce the speaker.
Thank you. I think continuing on the theme of community engagement, I'm very pleased to introduce Dr. Esmi PO, radiation oncologist at Christian Hospital, Umbilical Dindigul. The secret is that as soon as I passed MD from CMC Vellore, I went to this Umbilical for a job. So I know that from that time onwards, and they've done excellent work, and Esmi has been there for many years now, and in addition to radiation oncology, she has done substantial work in cervical cancer screening, including working with IARC and WHO. So over to you, Dr. Esmi.
Very warm good morning to one and all gathered here. I take this privilege to thank the organizers for giving me this opportunity, and also congratulate them for taking up this new upscaling event for cervical cancer technology driven, which is new to me. So also I would like to thank them for the hospitality extended to me, and this time I would like to give my tribute, honorable tribute to late Dr. R. Shankaranarayanan, who was my mentor and advisor, and who had paved a way for me in the community preventive oncology section. And now he is no more, but many of you are familiar with him. And of course, he was a doyen in the field of cervical cancer elimination globally. So we all know so many facts about cervical cancer. It is the second leading cancer affecting women, and 23% of female cancers is constituted by cervical cancer. And we know 80% of this cancer is reported from middle and low income countries. And it is the long-term outcome of persistent high-risk human papillomavirus. And sub-Saharan African countries and Southeast Asia and Central and South America are having higher incidence. In India, we know the variation of the incidence from south to north and east to west. And Kerala, the southern extent, the incidence is very low. And also in Assam, Dibrugarh also the incidence is fairly very low. So we all know about the WHO elimination call. I need not go, but we know that pillars of elimination based on 90% vaccination, 70% screening, and 90% of treatment for pre as well as invasive cancers. And these facts about HPV also I need not tell, because we know hundreds of strains are there, but 14 are oncogenic, of which 16, 18 constitute 70%, whereas the rest together
constitute 90% of cancer, the cervical cancer. We have a lot of things in the armamentarium for screening, from conventional PAP to VIA-VD, liquid-based cytology, as well as the new star of this present day is the HPV DNA testing, which we talk more about it. But I feel still visual inspection using acetic acid and leukocidin have some influence in one-time screening for the ladies who had never come to the screening clinics, which we are doing we are just doing now also. Regarding HPV DNA testing, we know COBAS test is fully automated real-time PCR DNA amplification test approved by FDA in 2011, and the unique test design allowed that is 16-18 genotypes detection along with the other 12 high-risk genotypes. It is an objective test and reproducible and highly sensitive but costly for our setup is what I feel if there is no funding for this testing. And we know there should be a definite link between screening. Once you do the screening and diagnose, and if the treatment is not there, there is no success for the cervical cancer screening. And I would like to describe about from our experience. We had a cervical cancer screening program in 2000 in Amplique, based Dindigul district. So about 113 village panchayat were selected, of which half went for intervention and half for the control. And in the we offered the VIA through our health workers, as well, that is health workers include the nurses as well as the village health guides who were given good training by the trainers. And they could pick up the premalignant lesions, and they were taught to do the biopsies and again the treatment with the cryotherapy during those days. And LEAP and other things were done by the doctors. So we could see that with intervention, we could, the incidence of cervical cancer as well as the death from cervical cancer could be reduced. So on that background, I'm just talking from that background of that screening offered to the Dindigul district population, that general population. I just wanted to tell about the experience from how to go about this community-based screening. So this is not only done by community-based screening, but also in the hospital-based. So we have recruited staff, human resource, like we have the PI, co-PI, most of them were doctors, and also we have managers and supervisors, at the same time the health providers, mainly they were nurses as well as the nurses of different background, BSc as well as GNM, and also this multi-purpose health guides also were included in our team, along with the government, the PHC, VHNs also. So they are the people who know about the village situation, and we did the enumeration for all the areas which we are going to visit. So that is a huge effort, definitely. And before that, we have to have a meeting with the administrators of the village panchayat for the permission, and also from the Dindigul Health Department for their permission. So usually during this clinic day, before the setting up of the clinic, we do the mic announcement and pamphlet distribution. And mic announcement, we make it more attractive for the people to come and again participate. So then we do the enumeration of the households. That is individually we have to do. That is really a real big headache, because it takes time, because we know that panchayat will have many villages in each panchayat. So it may take time, and again I know some 1 month or so they may take to complete one panchayat. So it is time consuming, and all the health professionals only do the enumeration, and we have all the forms ready, and that is the socio-demographic forms as well as the individual forms, consent forms. All these has to be explained to this household. And in a house itself we have 1 or 2 clients for the screening. So convince them about all what we are going to do in the village is one big headache for the staff. But of course we have to meet them in the time when they are available in the house. That is again a big barrier. So usually many of our villagers will be daily wages going for their work. Morning hours may not be very free for them. So we have to organize our clinic in the evening sessions after their work. So 5 to 8 o'clock was the timing that we had adopted to meet most of the clients. So it is all really hard effort is what I have to tell, but it is possible. So then again the camp day, we organize the camp in a location close to their surroundings so that their accessibility will be better. But those people who are not able to attend, actually we organize camp in the hospital also. That timing of the hospital, usually 12 to 3. So we should be there, that as co-PI, we have to be there till the work is over. Similarly in the village, that is 5 to 7 or it may go even 8 to intervene these people. So it is all hard labor intensive. But the day of this clinic we have to makeshift arrangement is done in the in a place close to their accommodation. That is either panchayat office or in the school. A makeshift arrangement clinic will be done. And of course to attract people we do the puppet show or street play like that, and also give health education. How much of time we give health education, it is not going to have some effect on them, because I am doing this fortnightly screening clinic in my OPD and in my hospital. So we give a pre-test to them. So there is no knowledge. Most of our patients are illiterate or primary school education. So hard to understand what we are telling. What is the symptoms of cancer, cervical cancer, also they may not be doing. I involve my cancer ward patients as well as their attenders. So those people, the knowledge is very, very poor is what I have seen. And even after the pre-test, we give the health education, and after that we give the post-test. So even then, they may not be able to give the answers. So that is the literacy level that we are encountering. So we have to have different the setting of community-based education to these people. And nowadays I'm doing for the school students as well as college students as well as company people, like spinning mills are there around, milk companies. So there we go and give educations for these people so that some level of understanding will be there about cancer, its incidence, as well as the symptoms, where to go for treatment is also not, they are not very sure. So nowadays, government hospitals are providing good quality cancer treatment, but many of them are not able to understand and go there. So that is the situation about the health in our, among our low income people. So then we have to prepare all these. These are few shots from the cancer awareness program, and we have to include so many posters in and around our screening clinic so that they will be able to understand something through the pictures. So these are the few items which we keep. So this is the makeshift arrangement in a school for the screening clinic, and my staff interacting with the patients in the clients in the home, putting up the forms. Yeah, so there are a lot of barriers for the getting the people to for the screening. So that include mainly one is cost, because if the program is done under funding, there is no issue. But if it is not funded, then it is really cost, because the HPV DNA testing is costly. And usually what I do is via Willy, and if they are positive or doubtful, we advise them for the HPV DNA testing. And self-sampling also is helpful in for those who are having little hesitancy for coming to the clinic and doing. So then timing of the clinic is another thing that access many people, working women, when they need to come to the hospital OPD or the clinic may not be working. So that is one barrier we see. Then transportation for them to come to the clinic is also another difficulty. So inadequate clinic time, clinic hours, lack of time to get off from the work. Similarly, we know that there are people who are now educated people. They are working in different states. So when they come during the weekends or at holidays, we have to meet them in the clinic, and we have to open the clinic on those days and get the online booking for them. Then regarding the patients, we know that their knowledge is very poor, and many are frightened because they have, one thing is fear about the pain, and also to see the instruments like the speculum. They are not at all happy to see all those things. And again, the results of the test is one thing worrying them. So if it is positive, what we will do? So we used to tell them that nothing to worry if it is too early for you to, too early, and then there will be successful treatment, so no need to worry. So we have to take them to our side is what I see. And then embarrassment to expose, and also especially if there is male doctors, they will be really worried. So we have to take them to our side is what I have seen to overcome all these barriers. Then some individuals are really having lack of trust in the hospital health system because of their some bad experience they had some clinic setup. So we have to take all these things into account and take them to our side by our approach. And of course, some people think that there is nothing will happen because I have no symptoms, why I should screen. So that is mainly with the educated people. So when we offer this test to all our hospital staff itself, there is variation. They won't come, even the doctors or the high professions people, they won't come for screening at all. But only we insist on the low income people. So they tell that nothing will happen. When it comes, we will see. So that is the attitude. Then of course the false positive results. It is too embarrassing for them because we will be doing unnecessary treatment. Whereas false negative will definitely cause real problem because they delay in the treatment. So then cultural barriers, then lack of spouse support as well as the in-law support is big thing we see, because they look at these people with a suspicion. Something is wrong with you, that is why this vehicle is coming from the hospital and calling you for test. That is their attitude. So we have to get rid of all these belief among them and again take them to our side. And stigma, of course this HPV is related with the sexual transmission, so they feel bad about all these things. So literacy improvement, and again our attitudes, health providers' attitude should be very kind and gentle and again acceptable to them. Then of course the self-sampling HPV test will help us to take away their fear and again embarrassment, etc. Then language is another barrier which we see sometimes, because some immigrant workers coming from other states, for the sake of them, we used to have audio in their language and again allow them to hear about that and take out their worries and anxieties. So public and again private partnership is one thing, one way forward, because that will help us in many solving out this human resource limitations. Then of course it is free test. If we are giving means more takers will be there. So for that we need proper funding. So now my take home message is successful cervical cancer screening is possible in our country even though we have huge population and different barriers. Breaking the barriers by our means it will definitely improve the access as well as participation. Team should be dedicated and consistent in their work, and they should keep up the timing for the people whom we address. Then private-public partnership is the best model. Fund allocation from either funding agencies or CSR funding or from government health department is really of great support, because our program was totally funded by IARC when we did the screening program. Then of course with the adequate funding we can have timely supply of materials for the screening, and again all these things will be there with us. So of course screening and diagnosis should be accompanied by right treatment for elimination of cancer. In cancer, the word cancer, there is a can. Cancer is not a disease to be frightened. That is the message we have to give to the people whom we come across. Fight against it by all means. Never stop fighting.
Thank you very much, Dr. Rasmi. I will just take one comment. I think anybody has any burning question? Yes, please. Speak loud.
Yes, Esme ma'am is used their screening is based on VIA. So I wanted to ask, ma'am was talking about embarrassment. So did the women who came for VIA, did they express embarrassment?
Yes, to expose themselves.
Okay.
That is the main worry. And again about the procedure that we are giving now, that is why there's little bit of burning. So we have to convince them this is what we are going to do. We apply some chemicals, but it should not harm you. and it will be clearing your secretions and other things. So we take them to our side by convincing them. So a little bit of, then again speculum, seeing the speculum is also frightening for many people. So that is we come across.
Thank you. I think from both presentations, I think what we need to learn is that both of them are very accomplished researchers. The way they have gone into the community is with 3 doctors, 1 radiation oncologist, 1 community medicine professor, 3 more people, 4 more people, going in the night, going with van and everything. And after doing all those things, we are just saying in PHC you can do it. PHC, the doctor come at 10 o'clock, 200 people are standing there, the doctor will go back at 12 o'clock for private practice and nothing else is happening. So I'm saying we have this big divide between very organized, controlled, highly resourced, funded screening programs where great people are doing great work, there is no doubt. And you cannot immediately transfer that to a routine system. Routine system is 200 kilometers away from that. There is no semblance to what is happening in a PHC from what is happening in this. But these are important elements that if the government system wants to improve, they have to put in these people, they have to put in more public health people, more social workers, more facilities, nice room, better speculums, better people to stand, all that. So I think that is something really coming out. Thank you both very much. Thank you.
Thank you, ma'am. I request sir to hand out a token of appreciation for madam. Thank you, sir. Moving on to the next talk, we have Dr. Aarti P. Rao, Madam, Associate Professor and HOD, PSPH, Mahe, and Dr. Janine D. Ziu, who will give a virtual talk. I request Dr. Esmi and Dr. Manisha to share the talk. Dr. Manisha has completed her MBBS from Goa Medical College and an MS from Regional Institute of Medical Sciences, Imphal, and has performed various gynecological, oncological procedures like staging laparotomy, radical hysterectomies, and has conducted and performed several screening camps for cervical cancer with colposcopy, VIA, and treated the same. She has been involved in as training faculty in colposcopy workshops held in Chittaranjan National Cancer Institute. I request ma'am to introduce Dr. Aarti.
You can skip the time. I think we don't need the introduction for the crowd here. Will that be okay, Kirtana? Yeah, thank you. Yeah, for the sake of time, sorry. Yeah. So, good morning, everyone. Okay, so the content of my talk is somewhat related to this community engagement, and then I bring to table our experiences of the baseline survey even before the project kicked off. So we were funded in November of 2021. We were all celebrating, but then it went low-key for some time, and then we started gearing up with identifying the sites, preparing the tools, gathering up the research team, identifying the proper research team, orienting them, things and all. And then we had this, what I'm going to present to you today is about the baseline survey, what we did initially even before the implementation of the project, and it's a brief talk about that. And recently I got promoted to additional professor. Okay, so sorry, that's sort of a disclaimer. Okay, right. So I have titled my talk as Cervical Cancer Awareness and Decision Making Among Eligible Women in Indian Communities. This baseline survey was a combination of women, eligible women for the project, as well as the decision makers, because in the last 2 talks we heard that what is the influence they can have on the decision for uptake of cervical cancer screening. This is a disclaimer of sort that I'm not coming with all the results of the study because we are looking for a publication later on after that, but the salient features, whatever is there of this baseline survey is what I'm going to present in today's talk. So again, it's a lot of repetition. 4th leading cancer among women globally, 2nd in India, And literature has shown that poverty enhances the vulnerability for cervical cancer, and it has already been mentioned what are the various reasons hidden within the poverty which makes a woman vulnerable. High-risk HPV screening as a primary tool has already been recommended by the WHO, and this high-risk HPV with these components of cell swab, what I like to emphasize is this has the potential to reduce. So we discussed about the socio-economic barriers, cultural barriers, like women are not allowed to go to the health center, so if it is a cell swab at their home place, it can be addressed. Logistical barriers, access was again discussed in the previous two talks. So this has this potential, and that is why WHO recommended that this could be one of the, interventions to address this elimination goal for participation in the screening. So again, literature has proved that systematic reviews, meta-analysis in various sub-Saharan African nations, South American countries, and Southeast Asian countries, and Melanesia. Anybody knows where is Melanesia? This is right above New Zealand. It's good. Melanin is a pigment, so this is some sort of racial people or dark skin. I should not say that, I'm sorry for that. These are beautiful names. Melanesia, public health people, you need to know all this anyway. So what happens is uptake of screening, awareness, which is again dependent on the literacy, which again influences on the self-decision making, decision makers, and also healthcare seeking attitude from the family itself. So literature also says what are the facilitators for screening uptake? Increasing age, increasing age of the women. That means when we say age in terms of experience over the years, experience not self, might be looking at neighbors, might be looking at community. Today we see that cancer is like slowly engulfing us, right? We hear at least in a week we hear suddenly 2-3 people already, not to talk about people who are already working in cancer institutes, but in the local community what I'm talking about. Higher education among the women, again literacy influencing the self-care, adoption practices employed because it empowers a woman to go for self-screening, and higher wealth index of individual as well as the family. So what are the barriers and challenges? Long distances, lower awareness, financial dependence, living in rural areas, because as Cherian sir was also telling that accessibility is an issue. We might have all this, but then when the project transitions, what's left is what's there in the public sector, which is free, and a private sector but which comes with a payment. Religious, traditional, cultural factors, individual barriers. So this is all the general barriers which was told, but what interested me was this individual level, because it is your decision, your health, we heard it from Dr. Anu. So lack of trust and confidence in self, trust in the system, partner support, approval for decision making, and awareness of screening relevance among decision makers. So this is some of the things. So like we were armed with all this literature when we started this project. We didn't have to delve much into it because literature says which is there. In India, when we did a global survey of literature of all these things, as I told you already, there are many we didn't come across an umbrella review, but we had a lot of reviews which has gone through various studies that is published, and this is here to say what is applicable in Sub-Saharan Africa, South America, it's applicable in our societies also. So we embarked on this PRESCRIP-TEC project. So PRESCRIP-TEC is prevention, screening, innovative projects towards elimination of cervical cancer. So what we wanted to do through this particular project is to test the feasibility. So we all heard this 90-70-90 strategy. So how feasible it is to implement this project across the sectors in India. So this was the mainstay theme for this particular project. So the other thing, aim of this project was to make available the high-risk HPV, So we all know that nearly 80% of the cases of cervical cancer is due to the high-risk HPV strains, that is HPV 16 and 18. And it also investigates AI. So Dr. Ketan had already had the, IPR on this particular AI that was developed. And then we wanted to implement at a larger scale, which could serve as a decision support system. In India has got an exemplary way of having these community health workers, ASHA workers, and this A&M staff training, especially after the National Rural Health Mission, which has become the National Health Mission. So when we have this excellent system, so can we help them take on the spot decision with the help of this AI? So feasibility as a decision support system for visual inspection with thyroid acid. The previous question was, is there any embarrassment for VIA? So with this embarrassment, if we empower them, the chances of detection or suspicion becomes higher. So that is what we wanted to do. So even before we embarked on this journey, we did a baseline survey in the LMICs with the research objectives is first to see, baseline survey is where there is an opportunistic screening that is already there. We have the national program for NCDs. It was previously called as NPCDCS, but now it has been renamed as National Program for NCDs, which is available, made available on paper, executed in some centers and definitely not in most of the centers across the country. Okay, so opportunistic screening is maybe by chance people want to go, they want to get themselves tested, or they could be motivated by these community health workers, they go and they want to get tested. So but at least is it there, is it available? So awareness and uptake of cervical cancer screening so far among eligible women in urban and rural settings across India. Personal characteristics and autonomy of women towards uptake of cervical cancer screening. First thing is, are they participating? And if they are participating, what are their characteristics, factors? Because we are embarking on a project, we wanted to highlight on that and work more towards those things in our respective settings. So, coming to the methods of this baseline survey, in India, across the 7 centers, we have involved rural women, urban poor and transactional sex workers across the settings. The age is in line with the national program guidelines between 30 to 65 years and HRHPV self-test to be made available at the various healthcare facilities. And this is basically a household survey. And the 7 centers across India was the rural areas of Udupi where Mahe and Dharmasthala Manjunatheshwara College of Ayurveda, they have worked on these women. Urban slums in TMC Mumbai and TMC Kolkata. Rural areas of Kolkata but through CNCI Kolkata. Then hilly areas through Sikkim Manipal University. And sex workers where SGMC partnered with Swasti to work with these women. So the criteria for these eligible women who were involved were age, as mentioned previously, they have to be permanent residents in the study area, mobile population, difficult to go back again for them, not pregnant at the time of the project, not screened in the immediate past, adequate cognitive abilities to respond and answer to the questions and qualitative, quantitative, sometimes we have to even go dig deeper. So we thought that as a criteria because one of the outcomes of this we were planning was a policy recommendation to the country. Decision makers were also identified from the same household. We adopted in India convenience sampling across the centers, convenience like one after the other. Decision makers were interviewed from the same household identified by the women. Male decision makers spotted by these women were either a husband, son, father, father-in-law, but the commonest female decision makers were mothers and mother-in-laws, even if they were the decision makers in the family. We adopted this AWACANS tool, that is African Women Awareness on Cancer. This has been tried and tested in areas of Africa and found that it is very valid in identifying this awareness component among the eligible women, and this was not previously tested in any setting in India. The broad domains in this tool were socio-demographic details, breast and cervical cancer symptom awareness, risk factor awareness, lay beliefs, anticipated help-seeking behavior, and barriers to seeking care. This is untouched AWACAN questionnaire that is available in the public domain. So through this project, we adapted this for our study settings, and then we picked up only the cervical cancer questions. The modified tool was also adopted for the decision makers. It was critically reviewed by the research team in each context for compatibility, because sometimes when I go for these international conferences, I tell that India itself is a continent. The diversity and the people which they have. Sometimes like it is one country could be one state in our country. So that's the expanse of our situation. Adapted to local context, translated, pilot tested and validated, reverse translated also, because languages, again women have to understand what we want to ask them. And it was a mix of open, closed and multiple choice questions, and total questions for the women and decision makers. We can't keep it too long because people have to answer. 2 more minutes? 5 minutes, okay, right. 53, and it was translated across these languages. So the AWACAN tool which we adopted had 5 questions on socio-demographics, 5 questions on cervical cancer, and 1 question on household decision making. The questions related to cervical cancer were as follows: risk factors, symptoms, lay beliefs, confidence in appraisal, help-seeking behaviors, and barriers to health care. The knowledge scores, we had 1 for yes, 0 for no, and we had a cumulative score of knowledge which between 0 to 11 based on the number of questions, and 0 to 12 for all the symptoms of cervical cancer. We have trained, as a research assistants, were screened, trained for informed consent and administer survey. And the research team was constantly checking about the data comprehensiveness and accuracy and supervised. And the data collection period across India was between August and December of 2022. Descriptive analysis for socio-demographics, screening responses, composite scores. The difference between cumulative and composite is cumulative is just added, and composite is sometimes you have to skip logic. Like if yes, you go to questions. If no, you go. So when you calculate the scores, that is called as a composite score, which was also calculated. And then the median was taken based on the distribution, and we have done associations to see what are the factors. Coming to the results, in MAHE, we have screened 1,000 women and 950 decision makers. The median age of the women was 40 years. All the women were married, 35% urban, 65% rural women. Only 5% of the women, 50 out of 1,000 had ever participated in cervical cancer screening before. 33 women were screened less than 5 years back. 38% of them had ever heard of cervical cancer, very poor indices. Median composite score on knowledge was 2 out of, so the range we said was 1 to 11. And look at the median with the interquartile range of 1 to 5. And median composite score on knowledge of symptoms. So risk factors and symptoms. So first of all is hearing of cervical cancer, and then among those who heard also, this was the level of knowledge of the risk factors and symptoms. So I had highlighted this, anyway it's okay. So the age group we can see maximum was between 30 to 39 years, primary school education, and never screened for cervical cancer. And most of them, it was partnered with women, but husbands were the decision makers. And 53.2% of the women had never heard about it. This graph shows the awareness of cervical cancer between urban and rural. So across the various variables about the risk factors, urban women seem to, in view of time, I'm just tracing. So the message is urban women had a better knowledge of the risk factors compared to the rural women. Cervical cancer symptoms, some of the areas like unexplained weight loss, like persistent pelvic pain, rural women seem to excel better than urban women, but the result awareness of cancer symptoms was comparable between rural and urban women. 97.4% of the women visited healthcare facility in case of symptoms. 14.3% were confident in recognizing the symptoms of cancer. Younger women with a higher level of education, these were the association results. Younger women with higher level of education living in urban areas were more confident in identifying cervical cancer symptoms with a p-value less than 0.001. Better chance of risk factors and symptoms had higher chance of participation in the screening. Those who had better knowledge of risk factors and symptoms had a higher chance. Composite scores of risk factor awareness and cervical cancer symptoms were not found to be significantly associated with the social factors. We don't know whether it's because of the sample size, but these are the results of the baseline survey. And the most common barrier, because we had an open question also, lack of money for transport, lack of money for payment of fees in the private sector. These were the main deterrents. And this is a distribution of the healthcare decision making. 28% of women took the decisions themselves, and most of these were from the urban areas, where 46% of them said jointly. We don't know whether there was a power quotient playing, because when we went to these houses, it was family members being present at the time of survey. So if you see, like comparing to the knowledge of the HPV as a risk factor, 17.2% of the women were aware of the risk factor, whereas the male decision makers 10% and female decision makers 19.5%. Coming to the knowledge of cervical cancer symptoms, among the women, 33.7% guess that it could be, the symptom could be longer menstruation duration. 30.4% of the male decision makers said it could be unexplained weight loss, and 45% of the female decision makers suggested that it could be intermenstrual bleeding, bleeding in between the periods where cancer can be suspicious. So
you can see cervical cancer screening review. As I said, there are layering within and categories of high risk, medium risk and low risk detection. Okay, here we can is a 16-18 comprise, attribute towards say 70% of the cervical cancers in the, in the cervical cancer in the making.
some additional genotypes of middle risk genotypes like 31, 33, 52, 58. Okay, they also contribute. If together, nearly 90% of the cervical cancer contribution comes from these other genotypes also. So we can see the highest risk group here, the medium risk group here, and the lower risk group. Okay, and these have important implications in the formulation of the HPV vaccines too. So if you take a worldwide assessment and meta-analysis assessment also, we understand that 60% of the cumulative contribution from the HPV types towards cervical cancers comes from 16, 10%, another 10% by 18, and then we can see the segregation of the contribution by the rest of the genotype. So it's important. HPV genotyping is taking precedence now in terms of the development of the HPV DNA detection. Previously, we had HPV DNA test, okay, which could tell us in qualitative measures whether it was positive or negative. Positive meant that it was positive for any of the 14 or 15 oncotypes, okay. So herein we could not measure, okay. Herein came the possibility that you could be positive for any other lower, any other oncogenic types, okay, which may not have relevance when we see the contribution of each of the genotypes, okay. If it is 16 and 18, okay, it is considered very high risk, and the proportion, and the attributable fraction in terms of it being converted to over a period of time in futuristic possibilities to pre-cancer or cancer is highest with 16-18 and lowest with others. So there lies the significance of qualitative test of HPV DNA detection, which are telling you just a positive or a negative, versus HPV genotyping now, which is taking significance and precedence. Okay, now if we have HPV genotyping, now whether we can genotype everything, no, probably, and it would be quite expensive. So the genotyping, today we are saying we can do some limited genotyping and extended genotyping. Limited genotyping because wherein we are sure that 16-18 contributes to 70% of the cervical cancers. It would be a good idea to understand amongst the HPV DNA detection test, okay, if it is 16-18 or any others, okay. So there are many of the HPV validation tests which are on the horizon now, okay, which are looking at 16-18, at times 45 or 16-18, and they will tell you about others. When it tells you 16-18, we are definitely sure that this, women, or the positive test, if it is for 16 and 18, it needs to be taken up for further follow-up, and the urgency of the follow-up and the protocol development for such kind of genotyping, whether it is partial, limited genotyping or extended genotyping. Okay, so here we can understand the HPV genotyping for this stratification. It will contribute extensively so that we can bring down the false positivity rates and unnecessary investigations, okay, by the women. If that genotype, if you are able to pinpoint the genotype, okay, we know the risk stratification, wherein we can see here HPV 16, you can see it has the highest risk in terms of CIN3 or worse lesion. If you come to 31, 18 and 33, it is intermediate to high, and others you can see moderate risk and lowest risk, okay. So the significance of genotyping, adopting tests, okay, for programmatic implementation, if you are able to identify 16-18 genotypes, okay, that would be of more relevance and significance, by way of which we can avoid unnecessary false positive and unnecessary burden of further investigations onto the health system also. So HPV genotype specific risk for cervical cancer has also been provided, okay, as mentioned earlier. This is just giving you an extension in terms of the color coded for 3 years risk of CIN2+, okay, by the HPV genotypes, okay, just providing you the significance of the genotype testing. Some key data on HPV and HPV related cancers for India. So here we can see overall crude incidence rate of HPV related cancers. So it's just not about cervical cancers, but others also, other types of cancers due to HPV. Of course, cervical cancer contributes to nearly 18 to 19% of the overall contribution from the HPV related cancers. Here you can see the burden of the cervical cancer in terms of the incidence and mortality, and then as said earlier, the burden of cervical HPV infection in India in terms of the routinely done, how much is the burden in normal cytology? You can see it's 5%. In low-grade cervical lesion, the burden of HPV 16 and 18 prevalence is around 28%. In high-grade lesion, the burden of HPV 16 and 80 is more than 60%. That is how we attribute, okay, the high-risk genotypes towards the measure of cervical cancers. Again, these are graphical representations of the various grades of HPV DNA detection, oncogenic types amongst the various grades of severity from cytology, high grade to cervical cancers, and we can see that the contribution of cervical cancer by the HPV 16 genotype, okay, is nearly to the tune of 70% and 18 to the tune of 13 to 14%. So coming to the type of HPV DNA detection, as I said, we could have qualitative or we can have genotyping for that matter. The government of India is looking at HPV genotyping as one of, the device, indigenous testing technology which is being tested and validated in the country is looking at nearly 8 genotypes, okay, for the country implementation program in the future. So currently we have VIA as the primary cancer screening test, okay, which needs to be probably scaled up, okay, to molecular testing, because it becomes much more easier in terms of adoption, scalability. But of course, okay, there are challenges in terms of if the test is positive, okay, what is the pathway or what is the way forward, okay, because as I said, if we are transgressing to HPV DNA detection molecular technology, this talks about why we should be transgressing is currently cervical cancer screening rates are low. There are challenges with VIA implementation, and if we are, the challenges of program implementation are varied, and in any program to be effective in terms of the screening method, the screening tool is just one of the aspects, okay. There are many other things in terms of making a program effective and successful. So these are the various components, and HPV DNA detection probably could be a more fitting technology, okay, if we are supposed to be considering other barriers and challenges for introduction. So is it time to transition to HPV based primary screening in India? There are challenges, okay, because it's a highly molecular test, molecular setups are going to be required, okay. We have to understand how we are going to, how we are going to pool samples, okay, establishment of centralized laboratories, etc. Getting back to the women again as the HPV positive test, and knowing that, okay, high false positivity rate, because HPV infection per se is not going to lend itself to any cervical cancer lesion for that matter. So triaging of primary HPV based screening technology is going to be of utmost importance, and thereby herein lies the skills of probably VIA based screening, wherein HPV positives could be offered the triage by a real-time test like VIA. Of course, there are various other alternatives in terms of either VIA or cytology or colposcopy. Colposcopy is, hard to come by because it's going to be mainly delivered by the gynecologist. Cytology is more or less well established within the system, at least in terms of its availability. And VIA, because, okay, for the last 5 to 6 years, okay, VIA has been the primary primary screening which has been as per the operational guideline, and many of the capacity building training exercises has happened, okay. So VIA could be one of the triaging tests for HPV DNA detection, okay. But the current HPV DNA test of course are expensive and requires molecular setup, and interpretation needs 7 hours. So we need something of the kind, okay, wherein we could have some, point of care testing wherein we are able to detect HPV DNA positive or negative test within an hour or something like that, or the earliest possible. So that point of care testing or point of care delivery of the program could be something. And these are some of the strategies or effective sustainable screening modalities, okay, if HPV is adopted or taken up as a primary screening modality, and because triaging would be something of a necessity, okay, we'll have to look at various triaging solutions or strategies which could be more effectively implemented in the context of our country, rather than thinking about, high grade technologies or higher innovations which may not be affordable. So then comes the evidence of self-collected vaginal samples. There is good amount of evidence for the devices and storage mediums also which are effective. Urine self-collection is something which has been researched on and is giving promising results again. So whether yes, is it time to transition? But are we ready is something which is equally important. Readiness of our healthcare system in adaptation of HPV-based DNA detection as a primary screening modality. So there are program challenges, test costs, logistics around the test, okay, and public health infrastructure readiness for HPV testing is important. There are, the time is very short, but these are all the materials, logistic challenges of the health system and overall planning organization for the implementation of the program at the population level. So there are test costs, there are program costs, okay, and triaging solutions which needs to be provided. And triaging solutions and HPV DNA detection by genotyping will probably offer some optimal risk stratification, which could be more relevant to the country context and for the program also. So it's important that we have program readiness, effective referral linkages, and logistic around this test for implementation. We could adopt resource stratified guidelines also for the country, which is diverse in its context, and this is what the lifetime risk of cervical cancer and optimal age for cervical cancer screening. If we introduce VIA as a lifetime screen, as a screening test, the lifetime risk of cervical cancer, if it is done once or if it is done twice in a lifetime, okay, this is what the solution lies. And HPV DNA has promising, promising results in terms of once or twice in a lifetime solution. So I end my talk here. So reaching the last mile is equally important, and the project like this with HPV self-sampling and point of care availability of screening modalities could probably help us reach the last mile. Thank you for the patient hearing.
Thank you, ma'am, for that insightful talk on HPV screening and its role in prevention and early detection of cervical cancer. Are we having questions?
Ma'am, after this session.
Thank you.
I request Ranjita ma'am to honor the speaker. Next up, we have Dr. Premalata, Professor Head from the Department of Gynec Oncology, St. John's Medical College. I request Mingma ma'am to introduce the speaker.
Good afternoon. I would like to introduce Dr. Premalata T.S., Professor and Head of Gynecological Oncology, practices at St. John's Hospital. She has advanced training as super specialist in cancer. She is a surgical oncologist with over 25 years of experience and trained at DNB New Delhi. Currently heads the Department of Gynecologic Oncology Surgery Department at St. John's Oncology Hospital, Bangalore. So she is super specialized and treats different gynecologic cancers including cervical cancer, ovarian and uterine cancer, and has published and mentored multiple research studies on conditions of female genital tract including ovarian and cervical cancer topics. I would like to invite ma'am to kindly start her session.
Yeah, good morning. I think, excuse me for my bad voice. I just recently recovered from an infection. Yeah, at the outset, I thank the organizers for giving me this opportunity. This is a quick technical slide because I'll be presenting the data from the PRESCRIP-TEC study from all over India. All these matters have been already spoken. HPV is the most common transmitted infection, and we've heard from Dr. Sharmila Pimple that it's only 20% which persists. But if you see at any given time, there is the incidence of HPV is around 6.6 in the general population, and the commonest being the 16 and 18. Let us look at what our study shows. This is known to everybody. I'll quickly move on to the methodology, how we did in our study. The aims and objectives were many, but this is one of the findings, what it is there. So these were the institutes, various study sites which were involved in the study. So which has covered rural, urban, hilly region, as well as high-risk population. The methodology were, it was a community-based cross-sectional study in eligible women with the age group of 30 to 55 years. So this has well covered the age group of what the WHO has said for tooth screening, that is between 35 years and 45 years. So this is well covered. And the inclusion criteria were only the age as well as residing in the local community. The exclusion being already known HPV positive, pregnant women or women with symptoms of cervical cancer or diagnosed cancer, and also especially women we have excluded because there is a lot of tools on questionnaires which they will not be able to answer. So it's a self-sampling rather than most of the studies wherein it is a physician-collected sampling. Here it's a self-sampling with flock-Q coupon dry swabs. And the screening setup is camp-based or mobile unit-based and health center-based approaches. And as soon as the samples were collected, it was labeled and dispatched to the respective centers, and majority of the time taken were 24 to 48 hours. And in the centers, it was put it into the preservative medium and tested at a later time. The testing platform being, the molecular testing platform is COBAS 4800 and the Gene Expert system. We know that COBAS is validated for self-HPV, whereas the Gene Expert HPV is not validated for self-swab. The results are also slightly different. It will come because COBAS has got partial genotyping, which comes as 16 separate, 18 and then the other high risk, whereas the Gene Expert gives 16 separate and 18 bar 45 and the other comes as a pooled result. So these are the distributions of the numbers from the various centers. Coming to the socio-demographic characteristics of the study population, what you can see here, well representation from the hilly region to urban to community to the high-risk population. If you can see here, this is the point. The mouse I have to use. Okay, this I can use it, yeah? Doesn't have that. Okay, so the positivity in the hilly setting was almost around 16.1, whereas the highest was in the high risk population. Here WISM is women in sex work we have written, but this also has covered a small number of women with HIV positivity. So the positivity was highest in this high risk population, and next highest was in the hilly region, rural being the least. As far as the age group are concerned, around 8.2% in the highest was in the younger age group, that is between 30 to 39 years, then is the 40 to 49, the least being in the 50 to 55. As far as the education status, if you can look here, the highest has been in the higher education. I think this is moving so quickly. The education level, the higher education, the test results are more positive, secondary education and higher education. Occupation, yes, employed people had a higher HPV incidence, prevalence than the unemployed people. And as far as socio-demographic features are concerned, it was around highest among the high socioeconomic. Moving on to the next characteristics, religion, yes, Hinduism were more represented in this sample, and the positivity was highest among Christianity here, but this is all the univariate analysis at about 12.7%, the least in Islam. And for marital status, currently married, it was least, with married or divorced and widowed had higher population around 12.9. Age at marriage, yes, lesser age, less than 20, that less than 18 and 18 to 20 had a higher prevalence of HPV positivity. As far as parity is concerned, nulliparous had higher things, but nulliparous people we have included mainly in our this high risk population. There were quite a few with nulliparous. Those are women with high risk behavior. And at age at first delivery, yes, once again it has shown at younger age at first delivery, less than 18 has higher prevalence of HPV infection. Coming to the distribution of high risk HPV genotypes, this is a sharp contrast from what we have heard from the earlier studies or whatever it is being published in the textbooks. So we have this other high risk HPV types being represented to 60%, then the HPV 16 is only around 20%. Then we have these mixed infections. Yes, we cannot take, because these are two different studies, mixed infection 16 and 18 and 16/18/45, because of the various test differences in the testing methodology. There were lesser numbers, but the highest being the other high risk population. The same is being represented here, this yellow being representing the OHR, that is the other high risk group. And the next highest is HPV 16. This is a very different thing what we are finding in this present study. So even if you look, because incidence, prevalence as well as the incidence of cervical cancer, yes, it is different, because this is only, as we said, all these HPV will not turn into a cervical cancer. So even if I have looked into the HPV data in this study here, which was published in the 2023 fact sheet, a normal cytology, also HPV 16 is the highest with normal cytology, and even in low-grade infections or high-grade infections and cervical cancer, HPV 16 was being the highest, which was shown in all the earlier studies. This was already shown by Dr. Sharmila Pimple here. We see that the risk categorization depending upon the tier system of highest risk, middle risk and low risk. So this is the 16 being the highest risk, and the HPV 16 related virus that is represented in the green, this is the moderate risk group. So we cannot differentiate it from our study whether it is from the moderate risk or from the other low carcinogenic risk, because this lies the importance of doing an extended genotyping. And even the management changes depending on what is the thing. This is the guideline which is given for clinical management of cell-collected vaginal swabs, whereas the management guidelines are slightly different when you see only 16/18 or the other high risk, the second tier group and the third tier group. Once again emphasizing the need for an extended genotyping so that we can save our resources. This is a busy slide which I have summarized here. So this is an association here, it is a univariate association which is shown. The highest positivity is in women with sex work and the HPV, that is the high risk population. Almost close hilly region also showing the same incidence, whereas the least lowest in the rural population. As far as age is concerned, the lesser age, the higher incidence. Education, secondary education has seen to the highest positivity rate. As far as occupation is concerned, employed women have showed double the infection rate versus the homemakers. And socioeconomic factors, yes, highest in the younger, and it's curves down. The other association, yes, religion, Christianity did show a highest with minority groups, the next highest. This is a univariate, once again I'm telling you. And previously married and never married did show an association. Early age at marriage showed an association. Parity and age at first delivery showed an association. This is almost similar. You can see this report of human papilloma virus, whereas the Muslim countries like Islam, with that Pakistan and Iran have shown very low cervical cancer and HPV positivity. This is very important, the adjusted risks. This is a multivariate analysis. Here, the reference range for the setting was taken with high risk population. So here what you can see is women with rural, hilly region women almost had equal risk as high risk population. That is a geographic setting. Women residing in rural areas had 81% lower risk when compared to high risk HPV. The rural areas had 81% lower risk and urban population had 72% lower risk, whereas women from hilly region showed no difference when compared to the high risk population. As far as marital status, then widow or separated or divorced women had highest risk of HPV infection. This is a multivariate analysis showing the odds here. Religion was compared with Islam as a reference. Hindu women had 75% higher odds of higher HPV infection than Muslim women, while Christianity and other religions were no significant difference. And the other predictors like including age and education, occupation did not show much statistical significance in a multivariate analysis. To summarize, HPV infection differed sharply with highest in the high-risk population and the hilly region. But of course, the invalid results were also quite high in this. I can speak from our center, these invalid results, when we said the reason for the highest invalid was from the St. John site. What we had done is we have taken the samples from the women during their working hours. These are women with sexual activity in between their work. So the collection probably with married and never married women, significant HR-HPV infection compared with currently married. Early marriage showed a higher incidence and nulliparate women had higher infection compared to multiparous women. So future thoughts, higher risk population should be prioritized for screening. Vaccine coverage should include other high-risk genotypes and extended genotyping testing instead of partial genotyping for triage can be modified so that we can modify our resource according to the genotype. With this I conclude. Thanks.
Thank you, ma'am. Two sessions are open for questions.
One small observation. That HPV 16 per se, only as a single genotype, was very significantly lower compared to other high risk. But when we club the combined infection, 16 with something else, 16 with
even
another,
then it is still
little
lesser.
lesser, but it went little higher.
Around
Like,
40 were there with the combined infections.
but
In
it was
spite
still
of
lesser.
that, it is still much less.
But it is not that it's that low. But it not as a single infection, it was very low. But when when we combined everything, 16 with so many, and if we compare with other high risk, it was little close to that other high risk.
No, it did not go beyond 30 because
that was on the highest.
Yes,
other
highest
high
was
risk only
30,
was.
yes.
No, but like, I mean, how we have collapsed into
Thank you, ma'am. I think ma'am has very nicely summarized a lot of data and tried to make it within 10 minutes. And more importantly, I think some future work has also evolved from ma'am's presentation, where she is advocating that extensive genotyping, or actually genotyping profiling of each of these cases, have become very important, because the vaccination is only covering few of the genotypes, but the risk is by and large still out there, because earlier, if you look at our literature in the past 2 to 3 decades, most of the testing was done for 16 and 18 only. That's why it was only reported that these were the most common genotypes. Thank you, ma'am. Any questions for the first session?
I think you can hear me. Just one question. You've used the flock swabs. I just want to know, was there any experience in PRESCRIP-TEC of having fungus on those swabs?
Yeah, we had experience of only 2 swabs which had fungus on this, and which we have discarded. Maybe the reason is, no, it is not kept immediately, there is moisture which has gone into that, or maybe if there is a delay in delivery to the collection center, because there is a time which requires for the fungus to grow as such, because we did have 2 swabs which grew fungus.
Dr. Which one did you use?
No, so because we've also used the flock swabs, but we've had a lot of discussion with that company, because our virologists were not happy. Like, I think what you said, you discarded it, right?
Yes, we never
You didn't
tested.
test it, but the companies actually say that you can test it because it doesn't interfere with the testing. But of course, our labs are not happy to take fungus affected. So it's been a big discussion with the Copan company. So that's why I was interested to know.
Even blood,
how you did it.
when it is totally soaked with blood, our lab was not happy. But as you said, company says whatever is there, it should pick up HPV. That's
Yes,
what
higher
version from
chances
the
of-
company.
Higher chance of it becoming an invalid test if there's too much of
Blood
blood cells.
yes, yes.
That definitely will happen.
Yes.
So like in KIFID, the machine automatically will read it as an error or an invalid test. So we have to avoid it, but
if sometimes a woman is diabetic and coexistent vaginal infections, because when they do the cell swab, unless it is done by a healthcare provider, carefully only touching the cervix. But if it is a cell swab, in your case I think they have done cell swab, it's a vaginal infection. And that's the reason I think the company says that it won't affect the viral load.
I think it was not really well, just like they think it was mucor or aspergillus, not a vaginal infection, it might be candidiasis.
It was a very nice talk and comprehensively you covered the interview. But I had a few questions. Like you told that there was an association between, I am from community medicine and I have a center for community oncology. So I was interested to know that like there is an association between high socioeconomic status and employed women with high risk HPV infection. So how can we explain that? Because always the cervical cancer was thought to be.
That is the very good finding.
Okay. This is only infection doesn't mean it will transform the survey. They are at risk because exposure probably is more. That is what this is the finding from our study. That is okay. Maybe they have more communicate. The homemakers might not. This is what I'm inferring. Maybe they have more opportunities to socialize. And things could be. I really don't know. We need to study in these studies.
Or is it like related to, because they are working and they are not, like they may not have facilities to use washrooms during their menstruation or anything like that? Whether is it going to affect that?
Actually, like I mean, the data needs to be relooked from various angles because the testing platforms were different. Okay, the way we have grouped probably. Okay, like I mean, this is just the initial presentation, but the grouping or clubbing of the data. Okay, and I mean how earlier investigations have earlier evidences. I mean in terms of single infection and 16 with something in terms of 16 related infection being of the same phenotype, etc. So this needs to be segregated and stratified, and we'll have to do probably multiple permutations and combinations before we arrive at a particular analysis. So this is just an initial face value of what we look at from the data perspective.
So one thing, because I'm from public health and you are from community medicine, and I was talking to Dr. Vinci also. For me, like I'm yet to see this data, so I'm exposed to this analysis. There are many statistically significant associations which has to be carefully interpreted. I saw that several of the social factors for these women who are exposed to the cell scopes, especially in version of genotypes, because here one compartment is the women, their social this one, the positivity of the test, and if it's positive, the serotype. So this is a very complex analysis, and if we say that there is a very significant p-value, I saw on the table that many p-values was less than 0.001, which is a very high chance of closer to truth, even though the sample size was less. In fact, SGMC, I think they have done 1,500. So if you do a pooled analysis also, we have to interpret cautiously, because many of the things what she said was in contrast to the general belief of systematic review and meta-analysis. So we will have to relook into the data and then...
The other thing is your sampling method. You said purposive sampling. So the idea of applying most of these tests which you have used, the assumption is it is randomly selected. So you may have to look into the kind of tests you have done to arrive at your results.
These are results from all over India, not just...
So, and we also know that the HPV genotypes have a geographical variation too. So that also we will, I'm sure when we are doing an in-depth analysis.
But her question of highly educated from high social profile, and if you're saying that the p-value is less than 0.001, it has to be very carefully interpreted. We'll look into the analysis.
I think the morning sir also had spoken about the social vaccine or whatever. So it's contrary to whatever is known in literature.
I also had one more question for the PRESCRIP team, not only to speakers, like whether there were any challenges due to self-sampling method which was...
Yeah, we'll be discussing in the afternoon, that is the next session.
But she might not be there.
She might not be there.
If time permits, otherwise it's okay. I just had one more question for the previous speaker, Shabila madam, that for HPV, what you presented, ma'am, it was very informative, but I also, as I'm a coordinator for Center for Community Oncology, I have been debating to use HPV test as a screening tool. As you mentioned, that just because a woman is positive for HPV, we cannot label her as HPV positive, because many other studies have shown that where woman is told that you are HPV positive, they were very hesitant to go and tell that to their family, because they say that it's a sexually transmitted infection and she is positive for that, so that might impact negatively. So that is one more challenge which we have. Apart from that, if she is HPV positive for 16 or 18, in our basic setup with low resource settings, how, like you said, that triage of with the VIA. But even for VIA, she has to come again, second visit. But our major this thing was to finish everything in one visit. That was actually
exactly. So HPV primary screening lend itself to lot many protocols. Okay, depending upon, I mean, the protocols also have to be decided upon resource setting. Okay, like the southern of India may be more resourceful in terms of whether it is screen and treat immediately, or have various layered kind of a thing. One set of solution, okay, is not going to be a solution for the entire country. In fact, okay, every region probably, every state, depending upon their resources and training capabilities and potential, have to choose probably what could be the triage. And because screen and treat for HPV positive means that so much of resources, healthcare resources are going to be required to, what are you going to treat for? there is no lesion out there. This probably HPV positive is going to be like, I mean, transient and go away. Okay, so triaging is utmost important for an HPV positive screening test for that matter. VIA, which is real time, wherein we see there is a lesion or no lesion. Okay, screen and treat makes much more sense. Okay, I mean, wherein though I mean you could be treating much more than what could be realistic, but still, but for HPV, I mean positivity or HPV primary screening, I think screen treat measures are not. So the protocols are going to be differing, and we'll have to use contextually actually what could be. So for example, in Maharashtra, I would say, I mean pap cytology is something which is, I mean, you do not have to train and retrain people. It is available at the primary care at the district level. So like, I mean, maybe triaging by cytology, which is there within the resource setting, may not be like, I mean, it may not be an evidence-based protocol, but it is available. You can triage with pap cytology. So HPV as a primary screening test has its own challenges, but genotyping, if it is introduced in the primary settings, okay, will avoid much of this, high false positivity rate, because we'll be picking only 16-18, and 16-18, if it is positive, by evidence-based, like I mean, protocols and by the scientific evidence, 16-18 are the ones which needs to be followed up anyway, and the referral mechanisms and pathway could be much more structured and established with genotyping in place.
Thank you, ma'am. So, still the dilemma continues.
Yes.
Because in our public health system, as Dr. Archie may be knowing, that they are depending on medical colleges even for VIA, because their healthcare personnel are not, all of them are not trained, and then they don't have the system of referral care pathway and all, because our hospital is the one where they have to be referred to finally.
We have some medical officers in that also. I'm just wanting to know if they want to say anything regarding this.
I think they are giving their presentations and shared experience.
So that is the situation, because they don't have the infrastructure, they don't have the resources.
So
it is always like public
situation, I mean, in terms of the public healthcare system, this is similar and constant across all states, barring a few, okay, which have made some special efforts in terms of establishing the mid-level opportunities for, diagnostic confirmation.
So in our district, it's always like a public-private partnership model is followed since many years, and that is working well with VIA and pap smear. But HPV we could do only when we had research funds from ICMR or those things. That those years only we could do HPV testing. Otherwise, it is.
So despite Government of India having, it has validated a screening test, okay, to be deployed, but the deployment will take another, I do not know, maybe a decade before it is rolled out into the screening program.
One is the testing results and data. The second thing is, one is the testing results, second thing is data. Madam is from NCDIR. The disparities we have in the data collection and what do you call that harvesting of the data, coding of the data, which is so very important for the informatics department, which informs our future research. That also is a challenge.
It's more or less standardized, Dr. Vinci will, there are standardized, protocols by way of which IARC selects on the basis of the quality of the data actually. So it's quite standardized and quality assured.
We have a lag in, like we be presenting data from maybe 5 years earlier. The reason is because of the quality of it.
Right.
The time it takes to clean out, there are actually 4 parameters at least that we need to look into when we are looking at cancer-related surveillance data, like from the registry. So that takes a lot of time. So data quality definitely we need to look into before we actually do any analysis and assume or interpret the results which come out of those analyses.
The cancer registries have been the most oldest actually in terms of good data capture mechanisms, and they have been more standardized due to the interventions of IARC and IARC based protocols actually. But for rest of the beyond cancer, other registries have to still match up to the standards of data capture mechanisms.
Thank you. you to both the speakers, Dr.
Please come on stage.
Thank you, ma'am. I request Dr. Mingma to honor the speaker. Thank you, ma'am. Now we have two virtual recorded talks, which we had missed earlier. Who is a consultant researcher from the Female Cancer Foundation.
To speak at your conference and to share some of the findings from Uganda, Bangladesh and Slovakia. My name is Marlita Dervouw. I'm a gynecologist and working for the Female Cancer Foundation and Leiden University Medical Center in the Netherlands. I will share some findings of the PRESCRIP-TEC project, and I will not elaborate further on the research design of the study because you have heard more about this in the conference previously. But what I do want to highlight is the difference in screening strategy that we use in the different countries. Here you see the overview of the screening protocol of the PRESCRIP-TEC project, and there's a slight difference between the strategy in Uganda, in Bangladesh and in Slovakia. In Bangladesh, all HPV positive women were invited for VIA triage, and if positive they were treated, similar like in your setting. In Uganda, all HPV positive women came for VIA, but this was used as assessment for eligibility for thermal ablation. So also VIA negative women were treated, which meant that all HPV positive women received thermal ablation if they were eligible. And finally, in Slovakia, the strategy was slightly different again. Women came for HPV testing, but then went for pap smears. And unfortunately, we don't have the results of those pap smears due to data regulation, so I can't share the results from Slovakia on the pap smear results. So the objectives of this talk will be to discuss the difference in the HPV prevalence and genotype distribution, with a main focus on Bangladesh and Uganda, and also to assess the adherence to triage and treatment in these settings, and the lessons we can learn from that compared to your setting in India. This is a picture from Uganda, where women were invited by village health workers who came door to door to invite women to participate and hand them the cell swab. This procedure was followed in Uganda and was also followed in Bangladesh. The testing, however, looked a little bit different, the setting of it. Both used the Gene Expert machine, which had 4 modules in each of the locations. And in Bangladesh, the machine was located on a ship, which you see on the left, which is visiting the most remote parts in the north. In the south, it was positioned in a hospital. And in Uganda, we set up a laboratory in a rural village, so we could come close to the women with our laboratory testing. VIA triage was done using the artificial intelligence developed by MAE, and women were offered ablative treatment or referral. What I want to share with you is the HPV test results. And first I want to look at Bangladesh. I want to highlight, and let me use the pointer, I want to highlight the overall HPV positivity rate, which was surprisingly low. We know cervical cancer is common in Bangladesh, but the HPV prevalence was low, with 2.1%. Furthermore, it was interesting that 1/3 of them was positive for HPV 16, and HPV others were also very common. And with others, we mean other types than 16, 18, and 45. Down here, you see the results of the triage. and out of the women who attended triage, 42 were found to be VIA positive. Then, if we look at the numbers of Uganda, we see a big difference, because the overall HPV positivity rate was 25.5%. HPV 16 was found in 10.7% of the women, so was less common than in Bangladesh. HPV other was more common with 56.9%. And multiple HPV infections also we found much more frequent in Uganda with 23.1%. The overall VIA positivity rate, however, of the women who came for VIA was 14%. So there's quite some differences between the two countries. For Slovakia, the HPV positivity rate was a bit over 5%, but as I mentioned previously, unfortunately, I don't have the pap smear results for Slovakia. Overall, I think we can say that between Bangladesh and Uganda, we see a difference in the prevalence, a low prevalence of HPV in Bangladesh, a high prevalence of high-risk HPV in Uganda, and also a difference in geographic variation. And we know that is recorded previously worldwide, but it's good to know it from our settings in this study as well. And the screening strategies can be adjusted accordingly. Furthermore, I think it's very interesting that invalid and error results were quite low in our project. We only had 1 to 2% invalids and 2 to 3% errors with the gene expert, which showed that the screening and the sampling strategy, testing strategy worked well, and also that self-sampling was very feasible, that we could explain it well to the women. And something that we should learn is that adherence to the VIA triage can be improved, and the adherence to ablative treatment was really good. So overall, if you look at the targets that we were evaluating, that 70% of the women should be screened with a high-performance test, and that 90% of women with precancerous lesions should receive treatment. Within PRESCRIP-TEC in Uganda and in Bangladesh, we found that the self-sampling reached over 90% uptake. So self-sampling was much more preferred than clinician sampling in Uganda and Bangladesh. The uptake of VIA was below 90%, but still good with around 70% uptake. The uptake of ablative treatment again was really high, above 90%, and overall we referred 1 to 2% of the women with suspected cancer. So very interesting results, which would not have been possible without all these partners. So I would once more like to thank Mai for the invitation to share these findings with you today, and also all the partners for the collaboration in the PRESCRIP-TEC project. And I wish you a very nice conference.
First of all, thank you very much for the invitation to present during the conference on the results in CC. First of all, thank you very much for the invitation to present during the conference on the results in CC awareness studies conducted within the PRESCRIP-TEC project. During this presentation, I will mainly focus on the results from studies conducted in Bangladesh and Uganda. So my name is Janine de Zeeuw, and I'm working as a postdoc researcher at the University Medical Center in the Netherlands. To start with, the key barriers to cervical cancer screening. I think that we all know that despite all initiatives and activities, the key barrier to cervical cancer screening remains to be awareness. And up to now, also, the awareness-raising activities that were undertaken mainly have focused on women solely. So before the implementation of the activities within the PRESCRIP-TEC project, we conducted a baseline study that in the end allowed us to map women's and also household decision makers' awareness of cervical cancer, screening history, and the awareness screening gap in the PRESCRIP-TEC implementation countries. We've used the Abacan instrument to measure cervical cancer awareness that focuses on risk factor and symptom knowledge. So although I said I would mainly focus on Bangladesh and Uganda, in these two slides I've included the data from India and Slovakia as well, as it also is in the current manuscript in writing. So if you look at the visual on the slide, you will see that the different awareness indicators per country are different. And you see that the indicator has ever heard about cervical cancer has scored the highest in all the 4 countries. However, we also see that there is cross-country differences for all the 4 indicators. So when we look at this visual, in which you will see the awareness screening gap, you see also the different results for the 4 different countries. But first of all, to give you a little bit of help to understand the figure, on the x-axis you see women's lay cervical cancer awareness, and on the y-axis you see women's autonomy in decision making. And the bubble size represents the lifetime screening prevalence. So what we see that is for Bangladesh and for Uganda, the women's but also the decision makers' awareness of cervical cancer was high, but lifetime screening was low. And what we also see that for Bangladesh, the decision autonomy for women was very low. So in here you see on the slide some more activities that were undertaken on the culturally tailored awareness-raising activities that were implemented in Uganda and Bangladesh. And for the study I'm presenting here, we have evaluated the intervention that utilized both mass media but also community health workers-led outreach, and as I said, really tailored to the context of both countries. And the aim of this intervention was to improve cervical cancer awareness among both females and male household decision makers. So in here on the figure, the forest plot, you see the association between post-intervention status and cervical cancer awareness outcomes, and then for females and males. So what we see is that compared to the pre-intervention group, post-intervention women had significantly higher odds of scoring high on both risk factor and also symptom knowledge, after adjusting for country, age, education, marital status, women's health decision-making status, and prior cervical cancer screening history. Among male household decision makers, post-intervention men had significantly higher odds of scoring high on both risk factor and symptom knowledge, compared to their intervention counterparts, also after adjusting for country, age, education, and marital status. So to conclude, it's crucial to implement culturally tailored interventions consisting of the various components and awareness-raising activities. And these activities should include the focus on household decision makers as well. Thank you very much for your attention.
I thank Dr. Yanin and Dr. Malyek, who couldn't be here live with us due to the time zone differences. With this, we conclude our morning session. Please join us for lunch and a walkthrough to the exhibition area. I request all the delegates presenting posters to be present for the poster presentation, which will happen during the lunch break. We'll commence the afternoon session at 2 p.m. in OBGYN and Course Director in the Fellowship of Gynec Oncology, KMC Manipal. Madam has an observership at Gillette Center for Gynecological Oncology, Massachusetts General Hospital, Harvard University. Madam has the CamTech India Innovation Award, H 2020 DBT funded PRESCRIP-TEC project. Madam is the clinical lead PI. She is also the code developer of the Sakhi Manipal device. Madam has 60 plus index journal publications and presentations at national and international conferences, and she is loved by her patients and her postgraduates. I request the moderators. Dr. Kirtana Madam is the principal investigator and the director of MSIS Manipal. Now introducing the panelists, Dr. Premalata, Professor and Head, Department of Gynae Onco, St. John's Medical College. Dr. Sonia Matai, Consultant Preventive Oncologist, TMC, Calcutta. Dr. Prasanna Mitra, Professor and Head in the Department of Community Medicine, KMC, Mangalore. Dr. Mamata KV, Principal and Professor, SDM, Udyavara, Udupi. Dr. Mingma, Professor and HOD, Biochemistry, SMU, Sikkim. Dr. Abhishek Kunwar, Team Lead, NCDs and Comorbidities, National Professional Officer. Mr. Harisha BS, Director of Swasti, Bangalore. Dr. Anu Mary Omen, Professor, CMC, Vellore. Dr. Aarti P. Rao, HOD and Associate Professor, Department of Global Public Health Policy and Governance. Dr. Sharmila Pimple, Professor and Head, Department of Preventive Oncology, TMC, Mumbai. Dr. Manisha Varnekar, Specialist, Grade 2, SG, Gynae Onco, Chittaranjan National Cancer Institute. A warm welcome to all the panelists. Dr. Vidya Ballal is Professor Vidya Ballal is here in place of Dr. Mamata. A warm welcome to all of you.
Good afternoon, everyone. Now we are going to have this panel discussion with the title Voices from the Field. So we are going to have so many voices of different types. We have had this project running in multiple centers, and in each of the centers we have had different types of different kinds of populations. So some are rural, some are urban slums, some high-risk population. So we have had a lot of diverse kind of population that we work with. Not just that, the settings were also very diverse. So it's important that we bring in that diversity and voices from all these diverse settings, like what each one of us through this project we have understood, and what is it that we have to share. What are those nice findings that we have? So, I mean, that is the focus of this particular panel discussion. This is majorly categorized into three parts. One is community mobilization and awareness. Second would be the HPV self-test is the second topic. The third one is about VAI and on-site treatment or referral. So we will start with the community mobilization and awareness, and probably I will probably say some people, because I know through which center has something to say, but I welcome the others also to bring in your inputs to this discussion. So first, as we started, we went for approvals from the government or from whoever. So there were approvals to be taken, right? So we had SDMC went for the high-risk population. That was a different kind of challenge there. different kind of approval maybe, or your experience of getting approval may have been different. Maybe some of us like Mahe and SDM, we went through the Udupi district healthcare department, so we had a different experience. So I would rather probably first like to hear from Mumbai. So it was an urban slum population, and you have had experience in the field. You have been running some screening camps, and this was one addition to whatever you did. So hopefully that was a slightly easier approval. So I don't know. I want to hear from you.
So
on
when
that.
it comes to approvals for research studies, okay, it's a different ball game against that of some of the service programs being provided. Now, I mean, going into the community per se, I mean, requires that, I mean, we, some stakeholders, okay, which we, engage with, and our, sheer out of our previous, collaborative studies, etc., okay, going to the communities was not a challenge by itself. I mean, we had a very well trained staff, okay, who were doing it for 10, 20 years and all that. But I mean that you cannot translate this into some public health settings or something like that. But coming to approvals from, important stakeholders, okay, at the public health system levels, etc., okay. So definitely, as a country, we are not attuned towards collaborative research, okay, wherein the public health system could participate as researchers or co-investigators into the project. So there is a lot of, shakiness and, some kind of a suspicion, okay, in terms of being exposed from within the system. Okay, so this was a real challenge in terms of getting, stakeholder interviews from key, key stakeholders for that matter, and approval system becomes a very complicated thing wherein, they would ask for a small size population, okay, going to the commissioner level and coming down to those kind of things would take years probably. So these are, in terms of the research proposal, I would say that the public health system level challenges are more than being, coming to community level stakeholders and engaging with them for implementation of the programs. So that I would say that was a major challenge for us. Being a recognized tertiary cancer institute also, but being exposed, okay, to what we are doing and the weaknesses, okay, in terms of not wanting to actually share any kind of a data and not wanting to have an engagement for a research project was a major challenge.
Can Sikkim add some inputs on this? Mobilization also you can add along with the government approvals.
So for us, because Sikkim Manipal University is a public-private partnership model with the government of Sikkim, so the paper approvals were very smooth and it was easy. Also, the community mobilization through our networked PhDs and sub-centers was easy because again our community department is actively engaged in many of the national health programs, so that was easy. In terms of community mobilization, there was a variation in East because East is where the capital is, and also it's much more urban than the West and the North. So in terms of West and North, I think the project team did face some challenges in terms of mobilization for the fact that although we have 100% penetration in terms of health service and care delivery, even in most of the remote locations, but the access or the convenience for the participants to come to the nearby clinic is physically very challenging for the terrain itself, for the time it takes and the distance that they have to cover. And also I think prioritization of self-care and self-health, which I think most of our talks today has brought out, is still not priority, however educated or however aware we are. That being said, we did find that participation was much more, they were much more receptive of the efforts and they did participate. Only the follow-up, where they had to come to the clinic if they were positive, that is a place where we had challenge.
Yeah. When we visited Sikkim, I felt during our discussion what we understand is that in Sikkim there has been lot of government sponsored activities, and people are more aware about what they get, what government policies are there for them, the programs. They are more benefited. So I saw there was a little difference in the way the Sikkim population accepted it with more readiness in comparison with our center or other centers, probably because there is more government program which is almost
So
already
penetration is really good, and also the sense of their right in terms of health, education.
Yeah.
The community is very aware of it. So, and also maybe because we are a very research naive community, let's say. So for them it was one of the programs where they would participate, and I think the vaccination program, success of the vaccination program itself speaks a lot for community participation.
Can CNCI, Manisha, could you please add to that? This was a village leader led mobilization. So could you bring in that difference?
So thank you so much. So first of all, if I stick with the government approval, like the approval is always not very straightforward. So it's a very important and essential part as far as the research and the project is concerned. But yeah, it went very smooth from our side. And I think we have to be that's always multiple times we'll be having to run here and there for the approval, multiple signs, signatures, all those stuff. But I think with the proactiveness, the participation, and the importance of the project, what exactly the objectives, we have to explain them. I think then they understand the importance of this project and the impact on the society. With that, then the approval becomes easy. Secondly, the mobilization. Since we are already involved in many screening projects since many years, and we have very well trained staff who are working at the outreach camps and the ground zero level. So the thing is that with that we had the village leaders, specifically the health workers like ASHA workers, who had an active role in mobilization and identification of the subject for the screening. So I think that made the vital and the crucial role in our project, because that made, and in fact our project, our site had 2,000 candidates for the screening, because it was easier for us to mobilize and get screened, and specifically the self-sampling. I think it was very much acceptable from our side. There was no issue. And when you had a visit at a site, you remember, I think they were so proactive and very much compliable with the testing, and we were very much happy, especially very thankful to our very active health workers who are well trained, and especially with the help of ASHA workers and the team leaders and the NGOs and the village, the stakeholders and all. So with that, the project very successful. That's the take from CNCI.
So when we see the interviews, transcripts of the interviews from CNCI population, the village leader could play an important role, because of the village leader could influence the men who were the decision makers in that rural population. So men were the deciders making the decisions. They would not allow the women to go. So they would even say, if you don't go, you just go, you don't come back. To that extent is what I see in the interview. But I think the village leader could play a very important role there to influence the men to bring their wives or women to this. So I think that village leader had played a very important role, and they could easily do it because of that, is what I understand from the transcripts.
That's the trust we gain, the trust is very important while conducting such programs.
Yeah, when it comes to Mahe, Hey, chair, you have the chair, please come.
Thank you, Kirtana. So, like for us in Manipal, as far as the government permissions was concerned, it was not such an easy way, like Mingma said about Sikkim. We did have I wouldn't say challenges, but we were sort of expecting actually what could be that. That the reason is because like lot of research would be with a population of I think 1.3 million. Cervical 1.1, it slightly increased because we didn't have the census in 2021. So we have marginally increased. But then there is so much of, this is a research institution for the last 7 decades in this area. And so many research projects and also population also, we were told that it's going to be a little weary and it could be challenging and it could be like going back again and all those things. As far as at the health unit level, we were fortunate that the officer then was cooperative and then we were able to get, but we were also mindful of this. But what was a startling revelation personally for me when I went to the field was COVID really helped us. People were more health conscious. When we, during the baseline survey and during this was when we asked the women, because if you do one HRHPV, it might be free now. It is because of the project and self-sampling and all, even though they were a little bit hesitant. When we asked them, like, will you repeat it after 5 years? They said, yes, willingly. They said they will, even if it is a cost on themselves, because COVID has made the people realize the importance of looking after themselves and taking care of their health. These were some experiences for us from this.
Good afternoon, everyone. Well, for PRESCRIP-TEC, I may be a little outlier because directly I was not involved in the project. However, I come from KMC Mangalore, where we have one of the longest standing public-private partnership in the country. We have a tie-up with the government from the day one of our existence. So, where as far as the permissions are concerned, we didn't have, any because we have had similar projects where we carried out to screen for CA cervix and other malignancies as well. Maybe a decade ago and a couple of years ago. So permission, of course, the time, I think Madam from Sikkim also mentioned that time is one of the factors. I think that same holds good here. And of late, what has happened is many of the responsibilities have been shifted to the state. So they are they anticipate approval from the state and especially NCDs, because of late we are having a trouble with one of our projects right now. So there are challenges, but then overall they are very cooperative. That way, absolutely. But one thing is, what I would like to mention here is about the motivation level of the community as such, and women in particular. What happens is, one is the domestic factors, like ma'am mentioned, that the decision makers in the family might not allow them to go and seek healthcare as and when they want, where they want. Another issue is that inherent fear what we have seen in most of the times, that what if it comes positive, then who will go for the treatment, management, and who will pay for it? Because the moment they hear the word cancer, then it's like, they feel the sky fell loose on them, and a lot of emotional turmoils and lot of other unexplainable factors. So fearing that, people don't take up. And similarly, we have had, after my colleagues are here, what we have noted is there is a severe lack of motivation, because especially when we go for a camp approach, even with the stakeholders, even with their people who actually influence that region, even with their presence, the health-seeking behavior itself is, I think, is yet to change. And that too is a district like Dakshina Kannada, where we say, like Udupi, literate, and people are aware, people are conscious, and absolutely no dearth for information, because we have WhatsApp, Google, and whatnot. So I think we still have that challenge of motivation, which has to get engaged right from the grassroots level. But then we have some positives, because we have, in addition to ASHA workers, we have another cadre of workers, community health officers, CHOs, and now they have been given additional responsibility of the implementation of Griha Arogya scheme, which mainly focus on other NCDs, of course. But then community engagement, I see a positive trend there, but I think we still have a long way to go.
Can we have SJMC talk about their mobilization, and of course maybe Harish can also join. So yeah, can you bring in, because that gives a different perspective altogether.
So as far as the clearances are concerned, with the ethics committee, and that is itself a big challenge at John's. Yes, of course, 2 and 4 too many times we had to go, and then the clearance was happened. The next was to approach the HIV positive patients. We have to get a clearance from KSAP. So we didn't want to approach the KSAP, neither wanted to approach, only we took in walking patients to the OPD department, because in an earlier study what we found was, they said publication is not permitted, that we will decide at the end. but permission can be given, and they have specification which centers to go. So with all this, we didn't want to take up through the ART centers. And as far as the thing, we had outsourced, I mean, we had subcontract with the Swasti organization. And what I can say, it was really, really a wonderful organization, a well-versed organization. We did not have the problem of we ourselves going into the community. It was all totally taken care by the organization. In fact, they are the ones who mobilized the crowd. I think we can hear more from Mr. Harish.
Yeah, just to give a history of our community, since many of them are not get a chance to expose to our understanding. I mean, sex work is there as a profession, it's there for centuries, but we started working with them when HIV came to India in 1986. So then when we discovered them and started working with them as part of our national NACP, National AIDS Control Program, NACO has started working with them, and there is a systematic program over a period from 19 decades to till now. In every district and in every state, there is a state control organizations that exist under NACO. And in every district, one or the other organization implementing the targeted intervention program. That is not only for female sex workers, it's also there for other sexual minorities and injecting drug users and truckers. Because of that program, today we have a very, even though sex workers are very scattered, unlike in Mumbai or Kolkata, so very scattered community. There's the one challenge for the mobilization. The second challenge is stigma and discrimination, since none of the health services are they are accessing easily from either public or the other services. There's also hesitance to approach. And the third one is about as a workers, sex work is considered as workers and they're always busy earning money. So getting their time for any of these facilities is another challenge. As we are working with community organizations, because if you look at today, there are 500 plus community organizations were started by sex workers for the sex workers. So with their support, now as Pramita madam said that it's easily done. If you have do it 15 years ago, this is not the scenario or situation. Today we are able to do it better. One is for that 20 years of work that we have been doing. Secondly, the COVID. Now people, including sex workers, are very conscious about health and they listen, they're willing to give time. And these are the certain factors that helps to mobilize the community. Yeah, I want to stop here. If anything, I will come in later.
Yeah, okay. One thing I would like to add, not just from this research perspective, okay, because everything has to have implications in terms of adaptation to the public health program. So I'll just quote two things. One is when we say community mobilization, okay, apart from our own center experiences, which are unique in themselves because, we have been doing this. One is research exhaustion, as some of you said. The information education communication platform, okay, in terms of the messaging, etc. Now we have diverse experiences, but the messaging and the content of the messaging, whether it will create fear, stigma or no, okay. So behavioral change communication also has to be addressed. It's not anything informal. I think it's a very formal kind of a thing which has to be adopted, because one instance is when 20 years back when we started in Ratnagiri districts of Maharashtra, okay, that time even BI adaptation was something new to the government of India. So when we started talking about risk factors to the women, okay, as part of IEC communication, that who are at risk of getting cervical cancer, and when we talk about multiple sexual partners, etc. Okay, so whether this kind of a communication has to be there, because over a period of time we saw women segregating themselves. We do not belong to this kind of women, okay, who should be taking cervical cancer screening. We realized it only with a big backlash on us in terms of the kind of communication messaging, because even village heads and village health leaders started dissociating from that we do not want you to be creating this kind of an environment in the village. We brought out the message, okay? The message has to be that every woman needs to be screened for cervical, and we took out HPV out of that communication skill, messaging, okay? So I think that's very pertinent as to what we talk and how we talk to the community. I think that's an important
very
message.
next question that we
Yeah,
are
yeah. So that was a very interesting thing, and we share the same experience, I think, across. And that brings me to the next point, which is to Sonia. How do we communicate the HPV positive result, which leads to probably, how do you communicate? It's a sensitive matter because of the same reason.
Actually, when we went out into the community, we talked about every woman being screened. From this age to this age, you need to get regular screening done so that we can pick up the infection and then proceed to finding out what needs to be done. So, because it was post-COVID, that was a very good talking point because we brought out the comparison between COVID virus and the HPV virus. We said it's as common as that. And it's a common viral infection which will go away. So that was the talking point. So it was not difficult to tell them that this is a very common infection. If you have it, it doesn't mean you have cancer. But this is a potential viral infection which can lead to cancer. And if you are not detected, unless we do a test, like until you do a COVID test, you do not know whether you have COVID or not. You can have flu-like symptoms. So a similar way we talked to them and brought that out. So they were not fearful about coming and getting themselves tested. And especially for the fact that it was a self-testing, it became even more easier to tell them because we said when you do a COVID test, you have to just put a swab into the nose. So if you have to do a cervical cancer screening test, you need to put a swab into the vaginal neck. And then it was so easy to explain to them. So we did regular sessions with the community healthcare workers. Like when we did our mobilization, the blueprint was to go house to house. But we saw that it failed because we were not able to get enough people, community health workers, to go into the large community to actually propagate that whole thing. So we immediately dropped having that as only the medium to go through. We picked up other things now. So we picked up other stakeholders and immediately started working with them. So we picked up the ward councillors, we picked up the schools, we picked up NGOs, we picked up the local clubs, and then we talked. So we went and did awareness programs first, and the next day, or we put in a day for the screening, so that it was more impactful. Because if you go and talk to them and tell them come for screening immediately, they would not be more receptive to it. So that is what we did. So we were able to then achieve the kind of uptake and coverage that we required. We can't calculate the coverage because we couldn't make count those numbers and get the denominator. But the uptake was very good because we had only funding for 1,000, but we had more than that, people approaching us to say that when are you going to do the next camps so that we can get ourselves tested.
Yeah, one more point to whatever the same experience that we have had as Dr. Sharmila told. We too, we went with all enthusiastically giving them awareness sessions, and we listed all the high risk factors, this, that and all that. And when they were reported as HPV positive, it is very difficult to face them. They look at one or two of them asked also, how did I get it?
Yes.
So that causes lot of family interpersonal disharmony. Yes. So after that we changed our total awareness, whatever slides we changed, and we changed that. We kept it. We made it very subtle that multiple sexual partners or whatever it is that went much down in the list, and we just said hygiene and this. I don't know whether it is the right way to communicate. That's what we wanted to ask this.
I think it's fair enough. There is nothing right or wrong about the thing. The important message which has to go is the significance of having the behavioral change. Of seeking services rather than instilling fear. Probably.
Yes. So that's very important. I think we should not be, as researchers, we should also think of the implications of what our actions.
Yeah, the them that if you test positive, the first thing was a disclaimer that you do not have cancer. It just says that you
Yes,
have this
yes.
infection. The other thing was we had the person who was responsible for telling them the positivity, that they are positive, actually counsel them
Yes.
during the time that they actually disclosed the test result to them. So after disclosing the test result, they had enough time to ask questions. So the follow-up to coming for the VIA was much better also because they were not averse to coming to it. So that kind of open communication should be there. It should be more transparent. I think from the beginning you have to set that platform so that that fear is not instilled.
Yes. And one more. Next thing is about our protocol, where we adopted self-swab as the primary screening method, going in line with the WHO recommendation, where they said you do high-risk HPV testing as the primary screening measure, and also followed by one of the triage testing. So that's why we adopted that, we followed that. But WHO probably recommended HPV self-swab, whatever, HPV testing. Definitely it is a very sensitive test, and probably it's not that it is easy to do. You have to do either clinical testing or self-swab testing. But WHO has proposed that probably one of the points was that women have hesitancy to undergo genital examination if it is done by the clinician testing, like the way we do pap smear or VIA. So is it that women are really hesitant to undergo clinical examination? What is your observation through the project? We have had mixed observations, but I think from your end also we would like to know that.
Maybe from our experience, I would say that the trust factor in the doctor was more. So they said that we don't have a problem whether it's a self-swab or a physician collected. So it depends on the relationship of the community with their respective health care system that is there. So that is also there because if you had seen our poster, it said the health system trust factor was very, very important. So if you've seen that, our community actually trusts the doctors that are there in their respective areas. So it was not basically the coming to the clinic, but I think the stigma attached to it. When you say a cervical cancer screening, the stigma attached to it that it is sexually transmitted, and then they come to the, or if you go to the community, because one of the things was going to the house to house, no? The women in our area, which was the urban slum area, they live in a community where there are just rooms, right? Everybody knows who's going there for what. So if I'm going to this, to a particular home and saying that self-swab, everyone else knows that what is the self-swab for. So because you've done the awareness thing. So, they have that hesitancy there. So they preferred coming to the healthcare center or the club or wherever we did this screening instead of doing it at home. But in the village area, they preferred it that we would come to their home because they had individual houses. But in the urban slum area, they were a little bit shy or embarrassed for the fact that, everyone knows why the test is being done.
Can I?
Yes.
So in one of the my observation would be like, see, let's also agree upon one fact that such an exercise has not been done at all for any disease so far. India being the capital for communicable as well as non-communicable disease. I understand the stigma part, but when we asked the women, we gave them a choice. Of course, most of ours was like bring it to the healthcare facility. After they came to the healthcare facility, they were given again a choice that for feasibility, logistical reasons also, they were brought to the health facility because hand washing, sterilization, and all these reasons. But what I observed when we asked them that would you prefer to do by yourself, they were like, how can you ask me this question? Because the reason is there is this sort of a cultural conditioning in our societies where tests are never taken to their doorstep. That is one thing we need to, that is also data for us. Like, of course, COVID was done and then that swabbing was done and all those things. They would have got the swab. But how many tests have been done at the doorsteps of women for any disease? Whether it is men or women or whatever it is. So when we asked them that would you prefer to do yourself at your home, they used to look at us, what sort of a question is this, So that is what I personally felt in that. But when we reiterated that, it was a lead question, it was sort of a bias, we went to see this is going to help you. We're inciting ideas and getting answers from them. But my personal observation is, this exercise has not been done in any communities in our country, whether rural, urban, or also.
So you mean they wanted
So
to...
I will substantiate this fact with our experience, both from the urban as well as the rural. Okay, so uptake, I mean by inviting them to a common facility for self-sampling was much more than the household thing, okay? Because I mean, there were multiple reasons and factors for, I mean, having some kind of a resistance in the household in terms of other members listening to it, other members being there, and women being embarrassed to listen to this in a single context, whereas she's with other members and other, I mean, peers of her own age group, okay, which is understanding and conforming to the facts, okay, whereas she's listening to it herself. Second is acceptance, one thing, okay, but going back to the women if positive, okay. So now, I mean, going back to it is either telephonic counseling or maybe household visits by the ASHA workers whom we are engaging with, or the community health workers, okay. So like, I mean, a woman, a healthcare professional, a healthcare worker visiting any household in the urban slums or rural slums, okay, was a no-no. Okay, they did not appreciate you visiting the house again, because that house, again, same like COVID, okay, you get differentiated, okay, that there is something there, okay, as to why the healthcare worker visited it, okay. Now this, like, I mean, a research mode wherein, I mean, we are trying to, I mean, go to the community and we are talking about follow-ups and compliance to follow-up and things like that. Okay, where do we stand here? Like, we had to change the strategy here, wherein we talked about a common point, okay, wherein the women would come and we would take her to the health facility.
And the confidence that there is somebody observing and guiding me during the process of taking the
versus that of, suppose, if I take the context of an ASHA worker who is otherwise dealing with any other diseases, who is a, I mean, regular visitor to the households, will not create this kind of a situation, okay. So in a way, we are isolating when we are, I mean, treating disease in silos, or, I mean, considering, I mean, the context of, I mean, approaching the community in silos for a particular disease, conflict will be created. Whereas if it is integrated with other healthcare issues, probably this issue may not arise. But we are facing this.
Yes. And when we integrate, they have to spend...
Yeah, because it is for many other
yes,
things, many other contexts. It cannot be singly isolated as, this is for cancer. Okay, I think we are creating more issues by, I mean, having disease screening in silos.
Yeah.
One of my biggest motivation to be working in HPV, I'm sure people are asking why a biochemist is sitting here. But past 10 years, what we are trying to do is, we know amongst in this room also, how many of us, proactively go and want to get a pelvic examination and get a cervical smear. As much as possible, we'll postpone it. And we are talking about the most educated lot in the country, correct? Because of the culture and the belief and the practice and our behavioral, let's say, persona, correct? So past 10 years, why we've been looking for an alternative sample as a biologist to see a simpler sampling method where a woman doesn't have to undergo pelvic examination, because we have to understand pelvic examination is linked with, I mean, the whole cervical cancer is linked with a lot of, belief about ourselves, no, about our health. And also it's a very private thing for many people. So embarrassment level at community level is very high. Many of us talk about it, many of us don't talk about it, and many of us walk away from it. So this is very prevalent in the community, and this is why in Sikkim we started in 2015 only looking for alternative sample. So, I think Pesona, one of our project co-investigators, we had already found her. She's a gynecologist. Most of us know her here. So in her practice also, we find there's a lot of hesitation only to just get a pap smear. Although pap smear was one of the national programs, Sikkim uptake was very low. So then we realized there's a hesitancy and embarrassment level is very high. Even in educated, although when we comparatively we can say the urban were more receptive than the rural, But then when we go into the community, when we start from our project associates themselves only talking about it, we need to, train them enough to be able to be confident to talk to people who anyways are very embarrassed about this. And I think most of our data has shown that there's a lot of embarrassment, and that's why the receptiveness to self-sampling was very high. And most of them liked it because it was convenient. Yes, there was a hesitation in terms of when they compare it with physician or a healthcare visitor versus themselves doing it. So this is in part.
The responses were a little diverse because depending on the setup and depending on the on their whatever culture and so many other
So I
things.
think maintaining confidentiality in some ways in HPV screening programs has to be addressed at a much larger level.
Yes.
Okay?
Yes. Let us move on to the next question. So that is, it's very important. Actually, we collected the swabs and we had a lot of invalid reports. And as we assessed, maybe it is not a complete evaluation, but overall, when we looked into why did we get, who didn't get invalid reports, there were centers who didn't get invalid reports. There were centers who got a lot of invalid reports, and we looked into the way they collected the samples. That also mattered to a great extent. Mumbai and CNCA had 0 invalids. TMC Kolkata had 1 invalid, and other centers had quite good number of invalid reports. And when we looked into the details of the collection of the samples, I think I will continue here because we are short of time. We observed that in TMCK, you monitor, you can tell how was it collecting. Were you there in the room?
We were there in the room. But
yeah.
we gave them very specific instruction.
Yes.
That they had to hold it at a certain point.
Yes, all that everybody told.
We had a staff nurse, the nurse who sat there, and when they gave took the sample, she supervised.
She supervised, yes. Our center, what we did is we kept a screen and stood behind the screen. We didn't see how they are, where they are inserting and all that, whether they are positioning rightly or not. We were from behind the screen, we used to give little directions, instructions. We also didn't do home-based. We called them to the centers and did. But we had some invalids. I'm not saying that is the only reason for invalids. There are many reasons. There is maybe many of them had bloody. Our center, we observed that it is because of the blood which smeared the swabs. And there are, I think, CNCA had different observations, not CNCA, our Dr. Premlata had an observation which she mentioned in today's morning talk, that they had used lubricants. Probably that is the reason why they had invalids, and you had communicated, and then in the next subsequent tests, they reduced the invalid. Yes, unique. Yes, yes. Separate. Yes, yes. Yeah. Yeah. So these are the certain observations regarding the. Yeah.
I also want to ask that if they were not supervised in this unique population, would they have had the fear of it coming positive and did not do the test correctly?
That is also, they had, 1 or 2 they had.
Initially, I think we had a meet when the women and the counselors were called for some of the organization meeting. That was the time that we addressed them. And what we could see is everybody were openly willing for the test, and they didn't have hesitancy. They had so many questions being asked in the open platform. That was a crowd of around more than 100 people. So I didn't feel any hesitancy. So initially we had trained the counselors, and the counselors in turn have helped the women to administer the sample. The first 200 set of sample which we collected was in your office, that space, and it was supervised by the counselors. So that was a time we never had a single invalid report, and we were quite very happy. We advertised so much. This self-swab is supposed to be a very good thing, and it is almost equivalent. But the subsequent samples, when we said, it was as per the council, when we started getting these invalid reports, we just called in a meeting, and a brainstorming meeting was happened, and all the counselors came to a hospital. That was the time a few people started telling that the second batch of test was done at the workplace. So at the workplace, in between the office or the regular work, the activities, they were collecting the sample, and that is the
That is the
time that
reason,
we
yeah.
had to wait a longer time.
Dr. Anu, would like to have your expert comments on this, how to collect the cell swabs? Did you encounter like in this kind of invalid reports, that kind of problems?
So in our project, actually, it has been completely unsupervised. We never stood outside or did anything. Maybe there are 2 or 3 people who wanted like help, and for those people, somebody actually like one person like somebody just stood and watched. But generally, I think has been completely unsupervised, and we have had invalids, and we've gone back and asked them again, and what we felt is they never inserted at all. Like that's the reason, but it's not been, I think, out of 600, maybe 10, like not a big number. But
Because ours is a diverse population, maybe that's why we had at different centers, it was different.
So we also had tribal people as well,
Yeah.
but no, we didn't
They
have,
also-
so that's what our problem was, more of fungus than rather than the
Yeah.
invalids.
One more important thing, because gene expert is not validated for
Self-
vaginal swab. So we in fact called the company people, and they say they have that certain number of cell sample. Is it all?
But I
valid
think
in the
of late,
or in
even
the
that
cohort?
is certified. Gene expert also is certified, I think, of late, no?
It's not certified for cell swab.
If there is any requirement for validation for the self sampling, probably not. It's a validated platform. Okay, that's enough for any kind of device to be used for collection. Okay, so that should not stand ground.
No, actually,
Are in the gene expert, maybe they have certain cell count for a pickup or something.
no,
Because
the
all invalids
centers
are
are
mainly
using
from gene
COPAS.
expert.
We have COPAS.
In terms of the equipment and validation, we look at the sample type. So if it is validated for cervical sample, irrespective of how it is collected,
how it is collected.
because we are just looking at the nuclear material.
Yeah.
So it has been validated for cervical cells. If it is validated for oral cells or not validated, then it matters. But here it is validated for cervical cells.
Yes.
It doesn't matter how it was collected. As long as there are cells, it should be able to give us a positive and negative.
Yeah.
I share an experience actually when we started our cell sampling back in during COVID times, it was to the help of ASHA workers. Then eventually we started giving a project, the outreach camp. We got the experience for our health workers, and when they told them how to just take the sample, we got the women wherein they put the swab in the nose because they got the example of COVID, so they thought this swab has to be put in the nose, and then after that, we started doing changes our protocol. Like during our awareness program session, we showed the PPT. In fact, I shared the PPT also, how to take the self-sampling on the stool and thigh, all the stuff. And our health worker is present at that time. She will show them, she will come out, and then the patient or the candidate will take her. But every candidate was shown how to actually take the swab. And then the health worker will stay outside. There is a room with the parda and all, the screen, and the patient or the woman will take the swab. Then we got the proper
Yeah. Thank you, Dr. Monisha. In Sikkim, we had the problem of the test platform. So they were trying to, equipment was the problem. So we were thinking of converting the CBNet platform or the other COVID-related gene expert platforms for use. Finally, I think you could find a platform, or was it converted?
Numbers.
Yeah.
So that also invalidates the run.
Yeah, we'll skip this thing now. We'll let him.
The only thing was, I think 2 patients, like when we were talking about the cells correction, although they were explained, we expect that when I explain it to you, you understand it 100% and you went forward. But we know that is not true. So 2 patients reported pain, which shouldn't have been the case. 2 participants, and then they were again re-counseled, and the images were shown on how to correctly collect it, and they were able to do that, and they didn't experience pain. This was only 2 reports of pain because of maybe some what we call it lost in translation. The information was lost in translation. What
Yeah. So let us now move on to the brief discussion on VAI field activity. Our third activity in the field was triaging. That is, after for the HPV cell swab positive women, we invited them whichever way. Different centers did in different way. Most of us did it at a community center. So there, VAI triaging was done. And I wanted to ask, it was, I think we probably don't have much time to discuss now. How did I think they will, now in the next sessions also we'll be having that discussion. I just would like to know, is it good to show the cervical image to the participants once we have done the VAI, showing them that, see, this is the photo of your cervix, this is normal, this is a photo of your cervix, there is some small things, it's just the superficial change, something like that. Is it better to discuss that way? And
So we did that actually.
yes.
Okay, because we are able to convince them more
Yes,
easily
yes.
as to what is it? Because she doesn't have pain, she doesn't have anything. We all know this. The resistance for participation is also by the family. You do not have anything. There are no symptom signs. Why are you doing that? So this is a convincing methodology in terms of whoever is coming.
And education also.
Yes,
And she
okay,
will
as to
also go
why
and
you would
communicate the
be, because
same.
we had to tell there and there that you would be needing further colposcopy
Yes.
and guided biopsy and treatment probably. Okay, so this was the modality which we adopted actually to show them.
Yeah.
And of course, VI with AI assisted things was a welcome this thing for our public health participants, not the ASHA workers because they are not expected to do that, but the healthcare workers training program that we took. Okay, because this is for them it is very convenient rather than going through VI training. Again and again. Okay, there is some supported decision making tool. Okay, which they were very, of course, comfortable and very happy to
Thank you.
have that.
And one last question, I think we are nearing the time. So we wanted some suggestions on the AI device. I think I want to ask Dr. Vidya Ballar madam, and also madam's experience on AI. They are from Ayurveda Medical College, and they were very actively involved in this project. And lot of AI activity they have done, also capacity building activity they were involved. So,
Thank you, madam. Actually, since we are from this field, we believe what we see. Maybe this will be a supporting factor. It is a supporting factor. I won't say it is not a supporting factor, but accepting it, rather we believe what we see. And maybe with experience or maybe with the time that goes on, we will accept it also. We won't say no to it. But our experience, we have experience otherwise also. Without the AI also, we do it in our hospitals. So with that also, we have got good responses. We have done every year. We do actually under Mamata Madam's guidance. We do it every year.
Yes.
So every year February we do it. We make a camp of at least 1 week.
Your
Camp we do.
experience with the capacity building activity, like
Okay.
how the healthcare workers.
Okay, we had good response.
To
We
learn.
had a response more better than the ASHA workers. We had the SKRDP people. They were more supportive for us. They brought in lots of people for us rather than the ASHA workers. So we had more help from those people, and all of them were cooperative. It's not, but there with the people, with the ladies as such, we had some problems. Some ladies were also commenting that why do we have to do this now? We have already passed everything. We have already got. See, now here in our population, we have people who marry their daughters off, and they have their own grandchildren. So they at a particular age, they think they are old enough. They do not have to do all this. So that
Still
was
not, still not convinced that they require
that was one thing that we faced in many of our camps. Thank you, madam.
So may I now, yes, Dr. Abhishek.
Thank you. Actually, I'm observer here. No, but listening to, sitting from here and listening to all the activities which are being done under this implementation research is very, very insightful. Only I have a couple of points which I can share with my experience, and maybe suggestion may not be. Because we are discussing what we are discussing here in terms of HPV testing in terms of the field in the community or the primary or secondary care or the referral mechanism. So I think, yeah, I agree that most important part is the how we can move in the integrated approach, because same ASHA has to do the multiple work. We have seen in many, I've been involved in immunization, vaccine preventable diseases, non-NCDs starting from hypertension, diabetes. A lot of success are being done. But you have to build the community level engagement from the ASHA. We have to see the work of the ASHA, that we have to learn the field, that what actually ASHA does, what are the incentives they are getting. Maybe the hypertension they are getting incentive for the follow-up diabetes, but cervical cancer no incentives. I'm giving these examples, but we have to learn and we have to document those the critical points where we are going to engage with the community. If you go for research mode, you will get permissions because you want the permission to get in, and once you have permission, you have a mandate to do that. But when you come out of the research, I think it will not be sustained. So the whole idea is to make it sustainable within the system. So if you don't make it sustainable within the system, so things will be fizzle out after the research. So there are multiple research going on. This is a very insightful. Actually, I am getting a lot of learnings from the HPV because I have been not very good advocate about the HPV. Also, WHO promotes that because we don't have evidence. I don't go to the minister. I don't go to the policy makers without evidence. Evidence in the Indian context, not evidence in the some other context which is not applicable in India. So any context which has to be replicable, has to be implemented in India, has to be done in India, has to be very cost effective, operationally feasible within the system, and sustainable and scalable. So that is why one message I want to give you. But thank you for this good learning, and I am taking this learning with me. Lot of things, really lot of insightful learnings, and I will be there in session tomorrow also. But I look forward to learn from this study and with all the experts sitting here. Thank you very much.
Just one thing as a public health person. So one thing ASHA always contests is that any new thing that trickles from the top, ASHA is overloaded. So she is the easy, convenient option to deliver at the grassroots level for community work. So in this way, ASHA's, when I personally interacted with them, what they said was, this sort of a, propaganda about HRHPV, we welcome it because the onus is not on us. The self-swab has to be, this could sound a little lighter, but something to be taken seriously. Self-swab has to be done by the women. All we have to do is give an additional information to them. Whereas the AA part has to be done by the staff nurses who are there in the centers. All we have to do is roll out the information, so which is very much welcome to us. I thought this is also very significant as far as the program point of view is concerned. Thank you.
I wanted to share this because what I realize is in this panel, most are from higher centers or states where cancer treatment is part of the system. When we come from a state like Sikkim, we don't have a cancer treatment system. It is evolving, it is developing. So now when we were, I think the project staff was communicating even the screening positive result, it becomes a little overwhelming for the participant because when we say high risk, it's very common to think that, okay, I am going to get the disease. But now, what am I going to do after that? So there's a lot of counseling involved for them to come and get themselves further examined. To do that, then there is, they have this, okay, I have to get a second opinion, So there's going to be an overwhelming scrambling of the person who tests positive because now I know that if I am high risk and if I test positive for the further test and if I have cancer, then it's a whole lot of effort for me to get treatment because I have to go out of state. So these are also some things that I thought I should share here because that is not a problem that most face, but it is a problem with small states like ours.
Yeah, I think we would conclude this panel discussion. Thanks for all the inputs, very valuable inputs. We have a lot more things to discuss, but there is no much time. I think we will keep discussing over the next 1.5 days. Thank you so much. Just give it a token of appreciation. May I now request Dr. Bensi to hand over the token of appreciation.
Moving on to the next session, let's listen to some perspectives of healthcare providers and screened women regarding innovative screening methods. I request Dr. Anu Mary to chair this session. We have Dr. Ganesh Bhatt, MBBS and DNB. Sir has finished his MBBS from Hassan Institute of Medical Sciences and in the past and has done his DNB from Narayana Hrudayalaya, Bangalore. In the past, he has held positions as a medical officer at PHC Edu, Administrative Medical Officer, PHC Kapu. Welcome you, sir.
Dignitaries on the dais and off the dais. So today I have been given a topic of healthcare providers' perspective in 5 minutes. So as healthcare providers' perspective, I'll just talk out of the box for 1 or 2 minutes. We had a sanitary napkin distribution program for adolescent females. So everybody, even public sector people and private people have educated everyone, educated every adolescent, and some were funded also to be distributed. So it went on well. So they made an incinerator available in every college or schools where adolescent females are there. Now, so as a government person, I should not tell that. Is it sustainable? No. Next. And they have launched a pilot project called Maitri, distributing menstrual cups in, I think, pilot district nearby Dakshin Kannada. Sir might be aware. Oh, he went out. Okay. So they have launched the pilot project and they started distributing menstrual cups, and so initially it had hurdles because unmarried females were reluctant to use. Then with little motivation it started crawling, and now it is delayed milestones. So no, I just want to tell whatever Dr. Sir has also told and Dr. Cherian told, whatever is in study mode cannot be directly projected to public health because it has too many factors. And first thing, when any program comes to our health center, it is like first staff will think, oh, it is an extra burden. Who will do? Next, when they know its importance, they will have some amount of service mentality. Before knowing the stuff, the first thing they will have is someone extra responsibility has come. KMC people don't have any other work. They will get permission from above and come to our health center. So I gave example of Maitri and HPV. I have to share our experience here. So we had very good experience. I was charge of PHC Kiramanjeshwara. Initially they took as a pilot area. So initially they moved to every field level to educate stakeholders. So it was good initial education. Then they mobilized them to the primary health center. It was also easy for healthcare staff. If all those responsibilities were shifted to healthcare staff, it was not that feasible. Initial response from public was not that good. First camp when we took, I think madam was there only, was teaching. It was like school kids. One teacher is teaching school kids what is HPV DNA, why we have to do, how we have to, what is important of cancer cervix. Once few people came, got educated, tested themselves, then they went and told in public. So then second and third camps were more successful than the initial camp. So it was motivation and education from word of mouth. So initially in corporate world, how it happens, I don't know. But in peripheries, how a patient has more doctors, doctors has more patients is by word of mouth only. It is not marketing. So this is also happened like the second and third camp, more people turned up. After they stopped that study, few were asking in field, when will they come again? We missed those 3 sessions. So we didn't have answer because fund has ended, study was ended. Okay. Next, and the communication of results. So it was good. HPV, we had given official mail IDs. I also was a physician, so I knew how to communicate HPV results. The people will accept precancerous lesion, but they won't accept infection. That is what I have learned. You tell you might get cancer, some skin changes is there, you might get cancer in 10 years. They won't fear, they will like, okay, what I should do? You get treatment, go. You have infection, it can turn to cancer. They are not ready to accept. That is what I have learned. I think same might be everyone's perspective also. So this is regarding HPV self-testing. So self-testing, they are not reluctant. I think people are okay because of prior communication. It is like 30 batch of people will come, they had a classroom hall, so they will teach. So once they have knowledge, they are ready to do test. Result communication was through proper channel and selected. They had one more point is free treatment. Next. So that one more advantage. HPV positive will call and tell, onchur treatment HRI veko. Next is free. Then it is okay. Okay. So 2 things were there. Infection they are not ready to digest. And free treatment was one more thing. Next is VIA-AI. VIA, I think sir might agree, it is age-old concept. The senior ANMs who will be retiring or retired had their VIA texts in their study material and they had to do initially. But how it was implemented is really question mark. And when they came for VIA-AI training, staff were telling to me it is really eye-opener because they have never had a hands-on experience. And it is just like a physician now graduating without vaginal surgery exposure. Many of them, my friends are only there. They will be graduating, they have VH course schedule, but they will not be very confident enough to do vaginal hysterectomy. So and again, this VIA also was like that only. They knew concept, VIA is there, we have to do. But how to prepare glacial acetic acid, what is important of freshly prepared. how much time we have to give. It was good refresher and good training for them. Then AI added on to that. It is like, I just want to tell you, if you don't know driving at all, you won't purchase self-driven car. Will you? No, I am just asking. It is like, we cannot trust entirely on self-driven car. We should have some confidence. If it is not driving properly, I will be able to drive. So that is, even though if VIA AI was implemented and it is very good, AI is very good, but staff won't be confident without knowing basics. It is like they should be educated properly. That is what like next challenge is. I think I am over. You are not.
No, sir, you can continue.
You can continue. So then, my time is over, I thought. Okay. Final question is how to implement it at field level. So field level is, we have to have more staff dedicated towards it. Sir told so many programs. When Sir joined, it will be 10 or 15 programs. Now it is 53, 54 programs in national programs, and every national program is mandatory and it is tracked on statistics. Quality is measured on quantity. So everyone understands what is happening at what will happen if one more program gets added without adequate infrastructure and staff pattern. And data is key. Future is in data. But when we don't strengthen our data tracking system, and what is the use of collecting data? If our data is not capable enough to change the future, then collecting data for numbers is not at all useful. Referral and what next? And healthcare staff are blind towards it. We have KMC Manipal in Udupi. That's all. KMC Manipal in Udupi. Initially, before this project, HPV DNA or VIAI, how people used to refer. I think tomorrow's session, panel discussion will have these talks. Sir, here I cannot talk much, I think. But what is the problem? Cancer cervix screening was merely happening and even with pre-malignant lesion or early cancer, some private fellow or somebody would have diagnosed. And in public sector, referral, hierarchy of referral, you see next treatment is here, go to that center, that doctor will see. It is it is very hazy. And with now ABRK, we are planning ABRK referral will give, you go to that center. So public sector we have to strengthen more, and our staff should be confident of referring. This is problem, you go there, they will sort out. And finally what public wants? Public wants some fellow, it is not doctor. It is already deprofessionalized. They don't want any doctor or some with some degrees. They don't want a good person to examine or test them and tell, you do this, you are free. It is nothing. ಹೆಚ್ಚಿನ ಜನ ಪೇಷಂಟ್ ಬರೋದು ಅಂತ ಹೇಳಿ ನಿಂಗೆ ಎಂತ ತೊಂದರೆ ಇಲ್ಲ ಹೋಗ ಅಂತ ಹೇಳಿಸ್ಕೊಂಡ್ ಬರೋದು. ಕನ್ನಡದಲ್ಲಿ I talked in Kannada because that is how we feel. Like many people will come for getting those words from a professional's mouth. So they don't want so many confusing pedigree charts or something. They want some proper track where this you do, it is cured, or you don't have anything, you go home. Or now we will imagine we will implement HPV DNA, we will utilize all funds like how we have invested in TB program for CB night. So we will invest for HPV DNA. HPV DNA is very sensitive, very much, and I think it is not much specific as per my knowledge. And next, after if it turns out to be HPV positive, then what? It is a question mark. Now, so we KMC people are treating it for free. They will do colposcopy, they will do colposcopy guided biopsy. Then they will declare what it is. It is precancerous or you are cured. But that referral and tracking system we should improve. And HPV test, even if we implement, then collection and transport is a question mark. Anyway, we cannot keep in peripheries. Collection and transport we have to sort out. RI is a very great program. If we are a government fellow and if we have to raise our collars with one program, what we should be? RI, routine immunization. Even one fellow with Mercedes car will bring child for immunization to primary health center. Why? Because cold chain and they know vaccine is good in government sector only. Because we have ILR and deep freezer at every center. And no private practitioner or pediatrician can keep that. Everybody will keep in fridge only. Yeah, I know. That's what I'm trying to tell you. So, where it lies, it is in investment. Investment, no? Every PHC we are giving ILR, deep freezer, it is a huge investment. If we invest and infrastructure and healthcare staff also you have to provide, then only this vision of 90, 70, 90 and 4 for SDG goals, I think we can achieve. I don't think by 2030 or at least by 2050. So VIAI can be a game changer than HPV DNA. That's what I feel. I am talking out of the topic which is given to me, I think. Age-old method with great sensitivity. Thank you very much for the bell. AA cuts its subjective variability. Strengthening referral system is a challenge. I thank for everyone for this opportunity and thank you.
Thank you, sir. I request Madam to honor the speaker. Up next, we have Dr. Rajeshwari, Medical Officer from the Primary Health Center, Kedur. Madam finished her primary education at Sagar and MBBS from JSS Medical College, Mysore. Madam joined the government service in 1996 and has worked at various health facilities at Sagar, Bidalkattir and Belway. Welcome, ma'am.
వాటర్ పట్టుగా పిల్లలు కాకుండా వాటర్ బాటిల్ ఐక్య పక్క
Good afternoon, everybody. Respected dignitaries on the dais and off the dais, and my dear colleagues. I would like to share the women's perspective on HPV self-test and VIAI done at PHC Belway, where I was working the last couple of months back. Here, the first, when we came to know that, so the district health office, we came to know that this project is being taken up. And even Belway PHC was selected, area was selected there. And a PRESCRIP-TEC team came and briefed about that, what they are going to do and what about the project, everything. But the one thing, as Dr. Ganesh Bhatt said, staff or the health care providers at the PHC Bidalkattir sorry, Belway, were anxious whether our women will take up this, accept this test, because it's a self-test, HPV. So ours is a very rural area, this is. So we were not sure whether they will accept this test. But because we had hurdles there also, as we know, the rural women don't have the concept of regular health checkups. Because they might be having reasons for that. If they find out what will be the next, if they have some problem, what will be the next, the financial burden it might be. So that, and they report to the facility only when they have the problems or the serious symptoms which they have. So that was one of the hurdles we had. And one more was the shyness there. They won't report for all this. When white discharge, they very hesitantly they come and report. So one more thing. And traveling to the health facility is also a problem in that area. So these were a few of the hurdles where we found out, and even the team found out that. So finally the team went with our Ashas to house, creating awareness about the simple screening test where they themselves can test. So, but as Asha said, they are reluctant. The women are reluctant to come. So further the team, second or third time they went, and then finally they agreed, okay, we'll come and accept the test as such. But even we had a doubt whether they will be able to know the technique and have the test done. So, but I think the women are smarter now. So they came. They were taught early as a batch of 30. They were selected, and they came to know how the technique works and all, and then they did it. But when the first few women, when they got done, so then I was asking how did you feel like? They were telling like, how we don't know whether the technique is the way we collecting the sample was correct. And will it be helpful in finding the results as such? And one few needed the assistance also. And few were asking why you all won't do the test. Why the healthcare provider are not doing the test and only we have to take the sample as such, one of these. And then we explained what was the, how was the test is going on, everything, and then they found out it was okay. But when they received their results, the reports to them, then they were really happy because a simple test without much of discomfort, much of pain, at the test was at their doorstep. Like in the nearby facility, they could get it done. So that where they were really happy. So as that word went from mouth to mouth, and people, women from the other area also were asking for the test. The demand raised in that way. So in that way, even women at the rural area can also be taught about how to do a test and all. And one more thing is the next is our VIA, using our AI device. All the staff, our PHC staff were trained in doing this VIA procedure. Even they had seen it previously when they went for other trainings, they had actually gone. But we never implemented, we wanted to implement at the field level. We knew what it is and all that. But we didn't go one step further to tell the women about that. But again, the same hurdles as to shyness and VIA, they might feel discomfort. So again, we created awareness from at all the stages in our Gram Sabha, ARS meetings as such, or self-help group meetings, Ashas, Anganwadis meetings. All we sent the messages, and then when these Ashas and Anganwadis got tested, they were, and few women whom we knew at the facility very well, and repeatedly they come to the hospital as such. So when they got tested, when the VIA procedure was done, that they were the real ambassadors, I feel. They went on saying that this test is going, taken up at Belway PHC. Please go, and this is a simple test. And then we had to arrange a camp weekly as such. And that is very little bit tough for us because we would be calling these ladies, women, and then they, and we would be able to do the test because of the other programs or other meetings and all. So we fixed our attend. I mean, at Belway, I fixed it on Thursday afternoon, so that at least 5 to 10 ladies I have to test on that day. And we listed also who are all coming for the next session and all. And so that testing was going on, and they were really happy with that. And 2 were positive. VIA was positive, and Dr. Shamala madam had treated there itself, and they were really, really grateful for that whole team as such. And even I am now at Kedur, even now they ask, can I get a test done and all. So I asked my staff there, okay, call them and tell the medical officer and then go with the test, because all of them are trained and they can use the AI device also very efficiently now, create an ID and take that assistance and give the report as such. And so the women are very happy with that testing, I feel. And this can be, according to me, can be implemented as a simple, because it's a simple non-invasive technique. And one more thing is, they can see the picture. I wish to show them the picture, because they won't know what's being done. So with the AI device, we used to show them before and after the procedure as such, and they used to be very happy. Okay, this is what they have done and all. So in that way, if we show the the photo as such, they'll be really happy with that, and more women are accepting the procedure as such, I feel. So in the, women's perspective, really it is helpful, I feel. So again, I'll conclude here, and I thank for this opportunity, and also I thank the PRESCRIP-TEC project team and Dr. Shamla madam also for giving me this opportunity and to work with the team as such. Thanks a lot.
Thank you very much, ma'am. I request Anu madam to honor the speaker. Next up, we have Ms. Jocelyn, Project Associate and Research Fellow from the PRESCRIP-TEC team, to talk on the uptake and adherence to HPV self-testing and AI-assisted VIA, insights from women and stakeholders. Welcome, ma'am.
Good afternoon to everyone. I came prepared to talk so many things, but before me, we got a very good speakers. So they have covered most of the aspect which I plan to speak. And I'm very happy that they came here and they expressed themselves what they have to tell. So what is uptake and adherence? So we always think uptake and adherence in terms of numbers. When we joined, when we were in project, I thought uptake and adherence always means by number. But later I understood that yes, uptake and adherence is also mean by their perspective, their views. Why is this uptake is happening in India? Why is the uptake is happening in this center, and why in SJMC it is different? So that's why we were very curious of this uptake. So background, I think morning onwards we are hearing about this. That is, yes, the screening rate of India. In some of the aspect, they are saying that yes, there is a very good number of screening. We are doing opportunistic screening, but the numbers are not added up in the National Health and Family Health Survey. They are telling that it is only, still it is 2.2 to 1.7 in rural and urban. Maybe in new updates we may get that screening is in India is increased. So, so my scope of this presentation is I wanted to tell about insights of uptake and adherence of HPV self-testing in AI-assisted VIA and to explore the women experience. So this is a methodology. As everyone in the team is now, we are seeing only PRESCRIP-TEC members. So the age group we identified was 30 to 55 years. So in the study, and it was a cross-sectional. So overall, we plan to recruit 7,500. So this is uptake by number. We can see by numbers. This is our uptake. Center-wise, we could see that we have achieved. We have screened 70% of whatever WHO goal we were planning to achieve. 70% uptake by center. How many we mobilized and how many we offered a HPV self-test. Yes, we have heard just now hurdles what we faced. Same hurdles I think has been already explored in our voice in the field. Yes, each center has faced a hurdle to mobilize these number of women, to bring them, to make them undergo this test. But once we mobilize certain number of women, we could later we saw that numbers were increasing. Later they wanted to do the test, but yes, we have a little shortage. We have a designated numbers we couldn't provide to them. But yes, as you can see by the numbers, majority of them collected the test by themselves. So they prefer to collect the test by themselves. As by we were offering them that if you need help, we will provide, but they said we will do by ourselves. So we wanted to explore why did they came for the test? What reasons made them come for the test? That was very curious. We and my team and all PRESCRIP-TEC team were very curious, like why and what. So we could see the demographic features of women, like demographic characteristic of women. So in our study, majority belonged to age group of 30 to 49. So all were in the age group of 30 to 49, and education was below primary and very less graduates. Majority of them were homemakers because majority of them belong to rural population were high in our study, and low socioeconomic group belongs to. So most of them were married because we had a criteria to recruit. So that's why currently married women, and very few of them knew about cervical cancer screening test. So here it is, why women attended testing. So this was a question added, like why did you came for the test? What motivated you to come for the test? So we asked them like, which factor you feel which influenced you to come for the test. So we asked them certain questions. So according to that, they have said that free test is because the test was given free to them. So that is the first and foremost factor for coming for the test. So you were giving the test free, so we are coming for the test. And one more is, we asked like, because you feel that the test is more accurate as compared to the other test, but they said no, we don't bother about it. As by the result, we can see that very few of them said that oneness means yes. So they said, most of them said no. So they said that no, we don't bother about whether the test is accurate or how good the result it is giving. You're giving us the test, it is free test, we know that that test will be good enough. We trust the trust in the healthcare provider is in the certain, as it is rural area, so they trust the healthcare provider, whoever giving the test to them. So why women attended testing? Some more, we ask them like self-performed test, because you're performing test on your own. Is it that matters to you the most to come for the test? That is also when we did when we asked them, they said no, we did not come here because it is a self-performed test. We came here, the majority of them said that no, we didn't, that is not the reason for us to come for the test because it is a self-performed test. But we have seen in the high-risk group that they have a almost like similar answer. Some of them, yes, they have come for the, most of them have come for the, because it is a self-performed test, as, there is a contrast inference from the other centers. Then majority of them we can see health provider advice. Someone came to them and someone gave awareness to them. Someone told them that there is a test. So that's why they came for the test. This is one more factor was explored. So they said that majority of them said yes, that is a reason why we have come for the test, especially from the rural areas. But if we see from a hilly region, urban slum and high-risk groups, women did not get influence from the healthcare provider, means the not healthcare provider, the mobilizer person. So they did not get that much influence. But in the rural area, they got influenced by the person who were mobilizing them or giving advice to them. So we have heard from morning onwards, and we have heard from the many of the studies that women preferred home testing. Like they prefer home testing because it is in their it gives more privacy to them and all certain things. Even foreign studies have quoted this. But in our study, we started with home testing before this cam-based or before mobile cam-based or whatever. We started with home-based testing, but when we went to home, women were refusing us. They were refusing to undergo the test. They were telling, no, this is our place is not sufficient for us to do the test. How many times we explained to them, we went to their home to collect a sample, but they were telling no. The same expression we received from other centers also. So that's why we move on to a mobile clinic or community based. So even in this data, we feel that when we ask them, before, even after, when we ask them which site you prefer to undergo the test, they said that majority of them said that they prefer at clinic as compared to more than home. But except urban slum, who almost like 50%, they said that yes, we prefer 50% of the population, they prefer home-based also, because the one more category, they were working women. The urban slum people were working women, so that's why they said that, because the timing when we used to go to them to give a test, it was not matching. So that's why those people prefer home-based testing. If you give it at the home, we will do a test and we will give it to you. So they wanted to do the test, but some of them did not get the opportunity to do the test. So next one is perspective. Like we have saw the numbers, why, when, also we went to explore more by doing an interview. We met those women who undergone the self-swab test. We asked them, like, what is your opinion about it? So when we asked them certain questions, we came to know that some of the women have a desire to know their health status. They wanted to come here and see what happened. And some because of fear of cancer they have come. And mostly they have come, most of the women who come for this HPV self-testing or came for the camp, they all are the other one have a history or the family history of cancer or exposure or somewhere. That's what. Majority of the women, whoever were there in the interview, have a family history or friends history of someone or the other person with a cancer related. So next one, nearby camp. Wherever we organize this mobile camp or whatever, we try to organize it near to their home. All the testing lab centers, we tried that. We try to give this facility near to their home, because that's what we explored earlier, surveying the centers from the women perspective. They said to us that if you give us the test near to our home, we will be ready to do it. We cannot travel so far to do a test. So nearby camp, dose-step screening, and free of cost test. Yes, even during interviews, they told that because the test was free, we could tell to others also that you go for testing because the test is free. And no travel or waiting time because it was near to home. And even some of the centers where we did test from Mahe, what happened was the primary health facility was far from their village area. So we have to give transport facility also for them. Otherwise, they said we cannot come, we cannot afford to pay 300 rupees just to undergo a HPV self-testing procedure. So then we have to arrange for a mass vehicle for them to come and attend a screening camp. Then group participation. They wanted to participate in a group. Alone means I'm not going to come for the test. But if you're asking my friend, if she come, I'll come along with it. So that was the expression we received. Next, ASHA and health worker influence. Yes, we have seen this. It's not only ASHA and health worker, even the person who went and told them to come for the test. So they have very good influence on them. They have a very good trust system along with them. And one more thing which most of them women said, that good explanation and clear explanation helped us to come for the test. If we explain them what test it is, not too much also. So when we explain them, clear explanation, we'll give it to them. They said we will come for the test. And family and social contest. Yes, recently sir said that yes, because women came for the test because others have, the women who undergone a test, she went and referred her friend, her family member. So because of that, yes, even in interviews we found out that the main one more factor was someone has referred her. She did not come for the test at once we informed her. Yes. So that's what. And next one about VIA adherence. So the procedure. We received 597 HPV positives across all the centers. We could mobilize 354 women to come for VIA activity. We see that different rates in different health centers. So why this adherence rate is very less is because of when they came to know that they were HPV positive, and later when we call them for VIA, they feel that we are calling them for some more bigger test. So they didn't wanted to come for the test, some of the women. So they refused. But majority of them who when we explained to them, when we counseled them, they have attended the test. Some of them we couldn't mobilize. So these are the numbers who we couldn't mobilize. And these are the VIA positives which we received. And we have tried to do a treatment to most of the women, eligible women. Who are not eligible, we have to refer them. And we try to follow up them also while referral. Even it was not there in the project, we tried to follow up them even during the referral. So we have did our part. The next one is Saki device, women perspective. Yes, we have heard from stakeholder perspective, we have heard from women, whatever ma'am said, yes. Because after doing the test, they were happy. First women, when we asked them, they liked about HPV self-testing. But later they loved most about VIA testing was immediate result, quick result they receive, and they'll see the images on spot, and the treatment is provided on spot. So immediate treatment and immediate, visualization of what problem is there in the cervix, help them to identify, so we gave the treatment. So they had a very good positive experience of VIAI procedure. Whoever have undergone. Yeah, certain member of the women said that yes, pain was there because of speculum insertion in certain centers. In every centers it will be there surely. But they said that yes, more than pain, we were happy that now we are negatives. Or even if we are positive, we have been treated or we have been referred and you are following up our referral. So this is what. So they were afraid of scanning, but they felt okay and they were comfortable because we were following them up. So that was the advantages of Saki. What they felt was it was a quick result, less pain and not less pain. But certain member of women said that they did not feel pain at all. Then help detect problems early. So device should be, yes. And one more thing here is the trust in a healthcare provider, whoever it is, a nurse, a doctor, whatever. They were trusting those physician. I trust the doctor, whatever he says, whatever he do. So they were ready to accept whatever the healthcare provider was offering them. Some said that yes, taking picture felt strange because they felt it is something. But after they saw their cervix only picture was captured, they were okay. We showed them dummy pictures. They were happy. Okay, then they agreed to give a consent. So we received positive attitude and recommendation. So the takeaway message is, we know that yes, HPV self-testing is feasible option because it's easy to do test. But the cost is also one more factor, whether we'll be able to provide each and every one because still women are calling us and asking us, will you be able to provide, but we cannot. But we tell them, like, we can offer you VIA test or VIA test. We can provide you and we can see, follow it up. So we have to think again, yes, HPV is good, gold standard, but we have to think again that what can be done at this moment to screen those women who are waiting to get screened and tested. So thank you for giving the time to talk.
Thank you, ma'am. Next we have with us Dr. John Black, medical doctor and informatician, Uganda Cancer Institute, will be presenting a presentation virtually. There seems to be some technical difficulties. With this, we come to the end of this session. We are open for discussion.
Thank you to the. Can you hear me? Yeah, that was really insightful. The perspectives from both health providers and from the women. And just to summarize, I think what we were hearing is that self-collection was definitely acceptable to the women and the providers. But I think there was this concern that Dr. Ganesh had raised. Is it going to be sustainable beyond research projects? And for that to be so, the government has to really invest into the personnel, the infrastructure, into the assays, so that it becomes sustainable. Otherwise, it's just going to remain as research projects. And the other thing was about the acceptability of the VIA AI. And again, as Dr. Ganesh said, it's quite acceptable to the nurses and the providers who are going to do it. But it shouldn't take away the fact that they still need to know the basics of VIA. That we don't just say that they don't need to know anything anymore. They still need to know that. And the same thing from the patient side as well. While they are happy with the VIA AI and the ability to see the image, they also need reassurance that someone is going to look at it and interpret that correctly. So yes, but the feeling that what you've communicated is that it's acceptable both by providers as well as by the people. Any questions from the audience? I suppose most of you are from the project itself, but are there people who are not from the, Dr. Esme, do you want to?
I just wanted to see the VIA image that they can show.
Do you have an image of the VIA? Yeah. I have in my. And maybe related to that also, maybe I'm not aware, but is there evidence that is published about what is the sensitivity and specificity as a triage test, and also whether you're recommending it as a primary screening test?
Yes, actually in this we have used, in this project it was a triage test. But beyond that also, as a part of capacity building activity, we use it as a primary screening as well. So it's not published yet. Initially, as the device was being developed, it showed very high sensitivity because it was in the what is that, our device, the laboratory setting. So it was in the range of 90s. Yeah, the whatever accuracy, whatever you say, sensitivity, specificity, and all that. But when we used some images from outside of our laboratory setting, not the images captured by the device itself, it fell down to a smaller extent. And in the field, when too many people are using the device, it is all the more down. So we still have to work on how to make it function a little more, like to improve its accuracy or whatever in the diverse settings. So that aspect has to be addressed. Maybe the mucus and so many things matter when you take the images. So the person who takes the image, how the person focuses or whatever the quality of the images, many things matter when we use this VIA as a device for the AI.
I suppose like nationally people would be wanting to see that data,
yes,
of the accuracy as a triage before we could recommend as
yes,
to scale
this
up.
project we are validating data as well. Yeah. Yeah.
Even in the project, so initially when the PhD, when it was done as a PhD project, it was a controlled setup like the hospital. Where, previously when the AI was developed, it was a control setting where women coming to the hospital
Community only we went.
We
Captured
went to
200 images.
Okay. But even after that, this one, ma'am, the field specificity was higher than sensitivity, which is also very important when it comes to cancer screening. But of course, it requires a testing on larger sample size and further interpretation. I think they will do it. We are yet in the process
And
of
basically the problem is the ground truth also. So best ground truth is histopathology. And where do we take biopsies for negative, which are VA negative? We don't take biopsy. Not only that, we have a lot of innumerable number of biopsies report, biopsy proven images. It's very difficult. So only we are also proposing to have some, like together we can have that kind of data set where we have biopsy proven cases. We have to start doing that now at least to improvise on this aspect of
And I think that are we waiting for that picture?
Yeah, he's I think you got that.
Yeah, I think you may be aware that there is some other AI study, the PAVE study, if you're aware of that, right? That they are looking at using colposcopy along with the extended genotyping results. And then, I mean, if later on people may want to compare this kind of technology versus having that information combines with the extended genotyping. So if you had extended genotyping in addition to your VIA AI, whether that would improve the results.
Yeah,
Doctor also provided immediate treatment is what some stakeholders told.
Yes.
So what was that?
Yes, in the project, we, as a triaging method, we did that VAA. We went to the field and did the speculum examination, VAA testing, and captured the image and we reported. It was not AI-based decision. AI was for our validation purpose, but clinician diagnosis and whichever, like we identified the eligible lesions. There is criteria to segregate images as eligible lesions, images eligible or whatever the problems, VAA positivity, eligible for on-site treatment, and some of the VAA positivity will be little higher grade positivity or extensive lesion which is not eligible for on-site treatment. So that like that we categorize the positive images, and those who were eligible we gave the on-site treatment using thermocoagulator. So that was also, it is available. For the project we acquired for that through the project.
Just to add to that, for the project, in the project setting, the decision for treatment was with the gynecologist or the physician who was there.
Clinician.
It was not based on the AI interpretation.
AI is basically for capacity building in terms of sending them to the higher center. And ultimately expert validation is required for treatment as such. It cannot be done at the ground staff, but then referral purposes and capacity building purposes.
And I think I just wanted to ask related to that. So you had referred to the ones who were ineligible for ablation. What was the compliance, if they needed LEAP, or what did you do for them, and did they actually go for that third visit?
They were brought to the tertiary care center. We kept some project fund for that purpose also. Exact number I think we have to project.
We did it in our center. We did it for two patients. We did that. So we kind of kept a little bit of funding aside because we knew that a small margin of patients would require that. So we kind of factored it into the budget.
One excision.
We had one excision procedure. 4 were referred to us to the hospital, where we had to, for one of them we had to do the.
I did notice that when you put your numbers, Jocelyn, you had said, like say for example 5 had the VIA AI. Okay, but 0 were treated, so that's why.
Eligible only I mentioned over there, and eligible lesions and eligible treated. Yeah. No, I did not add because I kept for uptake. What happened in our side, there was 2 women. After even they were eligible for lesion at the center, we said to them like we'll do a thermo here, but they wanted to come at the hospital and do the thermocoagulation. So there were 2 cases who were eligible but came to the.
Sometimes like it's wrong to do in a project like that, but see, women are more informed. That particular woman was more informed. So I had to tell that there is something called as colposcopy, which is the actual track. Colposcopy, biopsy, proving and all that. So I don't know, maybe as if when you...
So protocol wise, there is a protocol that you can do if it's eligible at the site outside the hospital, you can do thermocoagulation without a colposcopy.
Yeah.
But if you feel that
Correct.
doesn't fit into the
Person was
criteria,
well
then you
informed,
have to...
And she should not later question to me that you didn't inform the other option.
She wanted
colposcopy.
She wanted
to
it's
come
always
to the
patient's choice.
center.
We don't go with what.
Yeah, that's what. So
No, but irrespective of additional additional investigations or as far as we are completing the protocol in terms
wherever
of the
it is.
treatment, it should be
yes,
fine.
wherever it is done, it is fine.
So legally and ethically, you are
Correct. Correct.
There's nothing wrong, but for patient satisfaction, you can always do it otherwise.
Yeah. Dr. Esme.
This is the via image. Before.
Next.
This is
Left
after.
side. Left side. Left
This
hand.
is before. Yeah, and this is after.
After coagulation.
No, after acetic acid. After application of acetic acid. Sorry, it become habit for us before and after.
I don't have any more.
I have shown one.
It has just one.
I have more. I can show, but
There are certain images which are little bad because of the position where difference. This is a good one if you see. There are certain other set of images which is anatomically their position bad. So even if we try to capture them, we couldn't. So there are in certain time we got a blur image also because of excessive secretion. We try to remove it, but there were so many secretions. So we have to do different, because these things we experienced when we were doing capacity building activity.
So this is the image of the cervix. Then your AI report, what will that look like?
It tells it there also.
You can just say it like it just says.
Yes. It just show, like when we press the process button, it directly gives us it is positive or negative.
It comes as a green color if it is normal or negative, and it comes a red color if it's positive. So the icon comes out like that.
The entire device probably we should show. Tomorrow we also keeping one. Yeah, we wanted to keep one station
there so that we can show with the mannequin how to do the procedure. Tomorrow surely we'll keep it.
If there are no other questions, should we end?
We'll show it tomorrow. We'll bring that.
Yeah, we'll bring the device and we will show it here outside. So
And
we'll
it will
keep
not
our
take long
exhibition
because
kind of.
everybody knows here. You can just get the device and show.
Yeah, if there are no more questions, maybe we can end this session. Thank you to the speakers again.
Thank you, ma'am. Coming to the final session of today, I invite Dr. Chaitra Rao to chair the session. So Dr. Chaitra madam is a additional professor . Dr. Chaitra ma'am is an additional professor from the Department of Community Medicine at KMC Manipal. Madam works in community health programs and analytics research projects and is in charge of the Alavur Rural Maternity and Child Welfare Home. Madam trains faculty members of KMC in research methodology, epidemiology and biostatistics. Her areas of interest include maternal and child health, adolescent health, non-communicable diseases, research methodology. Welcome, ma'am. Coming to the first speaker, we have Dr. Pragna Sharma, Medical Officer from the Primary Health Center at Avarse, Udupi Taluk. Madam has completed her MBBS from Father Muller's Medical College and MD Community Medicine in SDM Dharwad. Madam has worked as an assistant and associate professor at Kanasur Medical College for 4.5 years, and for the last 3 years has been working at Avarse.
Hello, good evening everyone. I'm here to talk about my experience while using the AI tool. I think most of the discussion has been done, everyone has discussed everything. Only thing left for me is to tell what I experienced while using the AI tool. So I'll be very frank with my experience. AI is a very good thing which has been invading almost every field, even health profession now. But there are pros and cons. So what I felt here in while using AI was, the main goal of using this tool was to make sure that from periphery, from the lowest level, people come for screening and they will be referred to the higher center. Because obviously, when we tell you go for cancer screening, which is not like we are diagnosing or they don't have any symptoms as such. So we are telling a healthy person who feels that he's healthy, telling a healthy person go get a test done, spend so much money and come back. The two from my area to going to Manipal is like really far. So this AI tool, what we are trying, the team was trying to do is making sure people from periphery are happy to get tested and go, and further referral can be done. I don't know, as my colleagues were mentioning about motivation, I think the least motivated area is mine. I don't know, people were not very happy to come forward and get tested. How much ever you tell them that, okay, get screened, you are going to get screened for cancer. Later I stopped telling about cancer. I started telling that it's like a ulcer. Like how we have a mouth ulcer, we'll have an ulcer in the mouth of the cervix, and how mouth ulcer can lead to oral cancer later. Similarly, the ulcer in the cervix can lead to cancer. So I tried explaining in such a simple way. Still people were like not very interested. Finally, what I started doing was, I started doing VIA on patients who are coming for copper T insertion, copper T removal, and copper T follow-up. And ultimately, it was very few people who were actually motivated for VIA and came forward to get tested. And who came were very happy with whatever was happening. So I think it's a good initiative, but we have a long, very long way to go. It's the tool is good, everything is good, but once we start using it, how many people are going to come forward and how successful it will be? So it's a very long way. Okay, fine. We did VIA testing and patients are positive. Now what next? So where to refer the patient? What will be, as I think the discussion was going on, whether to do thermocoagulation or whether to do colposcopy, whether it's free of cost. As we have been telling about free of cost. If it is free of cost, people are happy. I recently sent a patient with VIA positive. She actually had to spend a little money. Obviously from periphery, when they go there, spending so much money is not very convenient for them. They were not very happy with it. When they came back, and Indian mentality is like, we did 5,000, we spent 5,000 rupees for MRI, and it came negative, everything was fine. We simply wasted 5,000. That's how it is like this even here. When they get tested and everything is fine, you're fine, you can go. I spent so much money and nothing is there. So this is how they feel. So that's how I think my area it was like that. So coming to the AI tool as such, it will be very helpful. The tool which was given to me, I think it was the most preliminary set. And I think a lot of updation was needed. I think we had a discussion about that, what more need to be done more, what updation has to be needed. First thing was accuracy. As I think ma'am was discussing, what is the sensitivity, specificity, it was very low, ma'am. As ma'am told, when we went to periphery and got it tested, most of them were shown as positive. So then we had to based on my experience, my expertise, as thinking that I am an expert, that I used to tell, okay, this is positive, I think this has to be referred, and this is negative, this might be needing follow-up. So it was my expertise. The AI tool as such was not very helpful. Maybe during updation, better updation would be very helpful for the staff. So if it is to be taken to the sub-center level, PHC is fine. Yeah, I think the next step is to take it to the sub-center level where PHCOs, the sisters, can do the testing. If that is to be done, this tool will be very helpful for them. Doing a test, if it's positive, referring them, it will be really helpful. But another problem is in sub-center level, a single person cannot do this test. I think someone has to be doing the VIA testing. Another one should be coming with the camera there, because focusing is needed. Holding a gloves, we cannot do the focusing thing and everything, so it was difficult. So we need a minimum of 2 people to do this testing. And I think Jocelyn ma'am spoke about the acceptability of the camera. Many people, after explaining, they were happy and everything. They were happy in front of us. Once they went to field, they were like asking sisters again and again, why was the photo taken? Like, what is the use of the taking photo? Like, they can hear the clicking sound, and they were not very comfortable about getting the photo of their private part. And being a female and also female staff, it was fine. A male doctor coming and doing, I think it will be still worse. Or a male nurse or a CHO. Like, I have 3 CHOs, out of which 2 are male. So one male is really interested in doing, but he is not allowed inside anytime. Only I think when the Manipal team came, they had PGs, male PGs, and also some females were okay with him coming, and he did 2-3 procedures. But after that, I could never let him inside the labor room and make him do the test. So yeah, doing practically speaking, we need staff, and again the staff should be female in the periphery. So yeah, well, it's very useful. It's going to be very helpful, but it's a long way, and there are many practical issues which has to be addressed. So if these are addressed, I think in future it will be really helpful. A lot of one more thing I want to tell was there was glaring. While taking the photo, there was a torch which will be on while taking the photo. I think the speculum, the light used to fall on the speculum and used to get glare. I don't know whether it was because of that it was giving a false positive report. Or whether it's the tool itself was not very accurate. I don't know what it was. I felt it was because of the glare. The photo, we can feel that it is white, there is a white patch there, but when we see it personally, we know what we see and we can give a judgment. So that another thing I felt was, I don't know how to correct it, because we have to use a speculum, we need a light to see the cervix, so how it is to be corrected has to be thought of. So apart from this, my whole team is very, very happy with this VIA program. I don't know about the AI tool, but they are happy that we are able to do VIA in the periphery. We are able to test our females, whoever are interested, few are interested, we are able to do the testing and give them the report. And like if further treatment is needed, we are referring them and they are getting it done. So whoever it is, it might be 1 or 2 patients, they are getting actually useful. It is useful for them. So I would like to end my talk. Thank you.
Thank you, ma'am. I request madam to honor the speaker. Next we have Dr. Shamala madam talking about empowering frontline workers, outcomes of capacity building and task shifting in AI assisted VIA.
Capacity building was one of the major aspects of our PRESCRIP-TEC project, especially PRESCRIP-TEC India project. This was actually in the design that, when we designed the project or when we planned the project with the international partners, this was not there. But through TBT, when we got the fund, then we included this as a part of the project as per the suggestions by the advisors. So this is a very major and very useful activity that we have conducted. The objective is very simple: to build the capacity in the community healthcare providers in performing VIA AI screening. So the activity workflow, in the beginning, as a part of capacity building activity, we identified the centers where we wanted to do this activity. So we went ahead with the very enthusiastic Dr. Rajeshwari, Dr. Prajna, and these were the medical officers, and Dr. Ganesh. They were the ones who very proactive, and they really provided us the field to work. So we went to those centers with this capacity building activity as well. And we identified the women who would do the capacity building activity, not women, sorry, healthcare workers, providers, and also we designed the activity. So initially, as a part of this activity, the workflow is like this. We collected the baseline data, that is the social baseline data about the providers, that is the people, the healthcare providers who are going to be trained. Socio-demographic information and pre-test knowledge questionnaires were administered, and we trained them using the mannequin. So we took the mannequin and the devices and also speculum and all that, and we trained them using the mannequin and made them practice on the mannequin. And the next session was with the actual on the patients or on the women who came for screening. We conducted we made them sit to do the procedure, and we did actual hand holding and made them do the procedure on 3 to 4 subjects in that first setting itself or first session itself. So that was the training that went on, and again similar 2 or 3 such sessions happened in the centers, and then on we did some monitored screening. We made them do and we monitored, and after that they have done quite a few independent screening, and now later we also evaluated them in between at 3-month and 6-month intervals. So some of the centers we have completed the activity, and some centers we are yet to complete the activity. We are through the activity still. So these are the trainees, that is the medical officers, auxiliary nurse midwives, community healthcare officers or community health officers. The trainers or assessors were us only, that is obstetrics and gynecology faculty and postgraduates who went from KMC Manipal, and also our SDM Udyavara. They are also obstetrician gynecologists and they are faculty. And also it mainly happened in the Mahe and one more center. They did capacity building activity.
We did it.
Mumbai, yes. Mumbai. I don't have the details of Mumbai, I think, here. So mainly I'll be speaking on capacity building activity at our center only, right? Yeah. So, and also we did their skill assessment, baseline assessment, then periodic assessment, and it was a structured assessment having some 36 questions addressing different aspects of this capacity building. And it was in the scale of 1 to 5. 1 is poor performance and the 5 is the best performance, like that. And we taught them infection controllers, antisepsis, asepsis, speculum insertion, VAA procedure, the steps of VAA procedure, using AI for the image capture as well, mainly for the image capture. But this AI, if not as a decision making device as of now, it is very useful. That's what everybody has found as a device to capture the image. And this captured image is going to give, like we are showing to the patients, that is going to help us give confidence to the patients. And also this can be shared with the experts, so that way also it can be useful. And also we are going to make this AI more robust in the future. Okay, so this is what we have trained them with. And the training sessions, as this is repetition actually, in the first visit it was orientation, initial knowledge and skill assessment and mannequin based training. And in the subsequent visits we did this hands-on VAA, AI, actual hand holding kind of training. And periodically we did the 3-month follow-up and competency evaluation, and the last assessment after 6 months of initial training, and encourage independent continued screening activity. The screen subjects were the women who got screened were high-risk HPV positive women after self-swab testing under the PRESCRIP-TEC project. The project patients only, either they are now having their triaging test, or the ones who had the triage test declared negative but already 1 year over, and now we are supposed to keep them on the track. Some screening has to be done for them because they are HPV positive. The first year after the diagnosis, the review screening, the next year screening, who came for that screening were the subjects for this capacity building activity. Also, out of the project, that is not not as per the protocol, the women who are motivated to undergo some screening, and what we offered to them was VAA AI primary screening, for the cervical epithelial changes. So these were the observations. Sorry, this is very crowded, so I had to put it like this. This is the socio-demographic and professional characteristics of the of the women, of the healthcare providers. So average age is this, and majority of them were nursing, from the nursing background, very obviously, or doctors, nursing from the nursing background and doctors. And CHOs were more in number, and then the public healthcare officers, medical officers, staff nurses. And we conducted it in the sub-centers as well as the primary health centers. In Avarse, Belve, Korgi and Maravanti, these were the centers where we had this capacity building activity. They were, what is this, heard, yes. 96% of them were aware of cervical cancer because they are healthcare providers. Only half of them or less than half of them had a screening training previously. Type of prior training was 50%. That is, some of them were they knew about pap smear, 50%, 50% of them knew about VIA. Of those who knew about it, who were trained with screening. Then the prior knowledge, how they acquired this knowledge is here. And whether they performed screening before this training, none of them except one had performed screening before the training. Majority of them had not performed any screening activity before the training. But they were all very willing. 100% of them were willing to screen women using VIA AI. And they were all. So this is the summary of total healthcare providers, 28 of them. As Sir and Madam mentioned, 4 of them were male healthcare providers, so they could not participate later on. So later on, it was only 24 who completed the skill training. There were 3 hands-on training camps, followed by attended by approximately 40 subjects who underwent screening, and each of the healthcare providers almost did 3 to 5 procedures per camp, and 3 hands-on sessions and post-training, and then 3 months, and at 6 months we did the assessments. And now Avarse and Belve centers are actively performing independent VIA AI. We are very proud to say that. And these are the 2 centers. They have performed this many procedures independently, and they have also referred some of the women whom they diagnosed as VIA positive. Women referred were 4, right? Yeah. And this is continuing. Their whatever management, referral and management is continuing. Change in knowledge. Okay, now it is about their knowledge scores and what is the difference that we could make by our capacity building activity. They were the 28 or 24 of them who entered into this activity. The pre-training knowledge score was something 16, and post-training score was 25. I think this training score was after 3 months. Knowledge score.
This is
Immediate. Okay, that was significant improvement immediately, definitely, obviously. And that was the immediate one. Huh? Okay. Now, after 3 months, after 3 months, it was 24 in the beginning, right? 25 it was post-training. Immediately after the training, 25. And 3 months later, they had forgotten. It came down to 14. Less than what they knew before. Initially it was 16, right? 16 or whatever you said. And there were 28 women, now 28, here 24. Yeah. Now in the next, maybe that calculation, whatever it is, it had come down. Okay. From 25, after 3 months, they had forgotten. So knowledge score had come down in the 3-month follow-up. And so this is how 15, 25 or 27, and again 3-month follow-up. This is the same, right? Yeah, knowledge score. It again started picking up. So it emphasizes that we need to keep refreshing their knowledge. Yeah. And this is about the skills course. Again, here it is little bit like that only. In the first visit, the first case, the score was 3.1. The second visit last case, 3.6. And okay, same 3.1. Second, what is this? Visit 2. Sorry. What is this? Center. Skill test, okay. Visit 1 first case is 3.1. Visit 1 first case is 3.6. Last case. Yeah, when they did 3-4 cases, last case it improved. But again, when it came to the visit 2, the skill had come down. They had forgotten the steps. So it came down to a 3.1 again. Again, it went up by the time by the end of the day. And like that, it was like this, going up and down. So again, it says that we need to do this skill training periodically, and refreshing courses are definitely required. Again, by visit 3, it had baseline itself was little better, 4.1. Then visit 3 last case was 4.2. That is how we could achieve this whatever the capacity. So the challenges was that where that majority were not trained in VAA or speculum examination also using Casco speculum. So we had to teach even that to ensure, because majority of them were community health officers who are very young team. To ensure participation by MOs, ANMs, CHOs, PCHOs amid their varied responsibilities. Okay, so we went with the team and they were so busy that day with the audit work and all that. Very obvious, it's very important for them. So it happens sometimes. So it is it's little difficult to coordinate all that, but still effort is required, and I feel it is useful doing this kind of capacity building activities. The training produced a substantial immediate improvement in cognitive knowledge, but partial knowledge loss occurred over the time. Periodic refresher training and sustained mentorship to maintain competence among rural primary level providers is important. Mannequin training and approximately 6 to 8 handholding sessions and thereon periodic refresher sessions ensured skill retainable acquisition or retainable skill acquisition. Okay, thank you.
Thank you, ma'am. The session is now open for discussion.
Thank you, ma'am. Because you're on stage, I think I will start with you. Thank you for sharing the findings of the study. I think, as you have rightly pointed out, whenever we do such capacity building initiatives, we must also understand it is the same CHOs, it is the same ASHA and ANM, and everybody wants to go to the grassroots level and train them, right? Because we feel at a tertiary care level, it is not possible to identify and screen and treat everyone. So we should get the response from the community. So the easiest solution everybody feels is go train the grassroots level workers. I think if you talk to them in person, you will realize that they have so many capacity building awareness sessions. Everyone is trying to train them. So it is like information overload. Like how we have, information overload, they have training overload. So it is, very natural for them to feel overburdened. So somewhere I think we should all, speak to each other, whether one training module can give different competencies. And it is all in the same checklist and in the same order. We do have a NCD program under which they're again supposed to document the details. There is an app, they're supposed to upload the details. So somewhere if we can integrate those things, so one visit, rarely we have seen that it is sustainable. So the only way it can be, sustainable, it has to be reinforced, as you have rightly said. But then that important point that people do not come for follow-up. So how will they remember? If there is a regular flow of patients who are coming for regular screening. So every day if the ANM is able to do 1 or 2 smears, 1 or 2 VIA, she will become an expert. Now she gets trained today and the next VIA she is doing after 3 months. I think it is very natural. You know, even a medical graduate will find it very difficult to remember something that they have not learned, they are not doing on a daily basis. So that is the biggest challenge. What Dr. Pragna said, I think that acceptability and making that, you know, person come for screening is the biggest challenge. And I must tell you, our say is not the problem. It is the problem everywhere. So you don't have to feel bad about your our say center. You know, it is universal. You go to any center, I don't think, you will ever get more than 30% attendance at any screening camp. You know, we should acknowledge that. So whatever level of community activities we do, it's very hard. So I think there are more challenges. So having a tool for early diagnosis, having a tool which is AI embedded is good. But then in addition to improving the accuracy of the tool, I think we should also simultaneously address how we make people come to the centers for screening. And here we have a very literate population. So illiteracy and ignorance is not a problem. So, you know, we always put it on people not aware, they do not identify the challenges. Here we have very good literacy levels and awareness. In spite of that, we have challenges. So acceptability is very difficult. So even for cervical cancer, I think she rightly pointed out, taking an image is not acceptable. So it is AI, it is generative AI, it can be anything. But taking a picture is not acceptable. So we have a long way to go. And you know, everybody would be worried in an era when you feel that there is a lot of data leaks. You're talking about big institutions where data leaks are happening. People are very much scared about, you know, privacy and confidentiality. I think you're taking a picture is very, very, you know, hard thing for them to accept. So these are some, I think, very relevant challenges she has told. So we have to work hand in hand. I'm not saying that it is not possible, but we should not compare ourselves with the Western world. We have to address it differently. I think I would say that we just need to address it differently and then take it forward. Thank you. Yeah.
So another thing with what Pragna said, speculum. For example, now in our country, there is home delivery has come to a standstill. I can say that much. Over the years since the pre-independence era, home deliveries have come to a standstill, and most are facility-based delivery. And maybe after the delivery, they never go to the hospital unless and until they are sick. Similar to what you said, nobody does VIA, and it's not a reinforcement process. So perhaps that is one of the reasons compared to other countries where annual checkup is a must. It's a do or die situation for have your insurance, which is a part of your assessment and all, which is not existent. So suddenly after a 20-year gap of completing your obstetric career and now coming to gynec career and speculum, this is the challenge, perhaps the reason that they're so hesitant for a speculum examination, especially for this. That's my thought, but then I thought that this could contribute. So whether it comes to the head workforce or from the women, and we speak of literacy. We speak of literacy and literate women in our district, but still, as it was another part of the discussion, how many of the literate women themselves get a pap smear done annually?
Totally agree, ma'am. As ma'am said, here we have preventive health checkups in our institution. So we offer this as a package, as a preventive health checkup. So people do come without symptoms to get screened. As part of the package, we have a pap smear. So women who come will say we will get the ECG, we'll get the echo because we're very worried about our heart, and if our heart is working well, my liver is doing good, my kidney is doing good, but I will skip the pap smear. It's part of the package, they've paid for it, but they would rather skip, some of them, would prefer to do that. So I totally agree with what madam is telling, that hesitancy is still there because there are no symptoms, so why should I get screened? So I think it's very natural, so it takes time for us to address that. Madam, you had a question.
Yeah, so I'll again reinforce the same fact, okay, that literacy actually has a different connotation when it comes to accepting some of the screening, modalities, okay, which are stigmatized. Okay, even today, okay, nobody would want to undertake a COVID test again. If it is not mandatory, nobody wants to take it. And I will reinforce the same thing. Okay, today in the Department of Preventive Oncology at Tata Memorial Hospital, we are looking at reach out to the women staff within the institution. It will be shameful on a part of a tertiary cancer institute wherein the staff is not aware, sensitized, okay, about undertaking cervical cancer screening as an elimination drive. We tried that, okay. Impact, people do not want to take up the test, okay, within the same institution. It has to be anonymized, okay. You have a employee identity number, okay. It reflects on the system. Everybody knows if it is going to be a PAP positive or an HPV positive. Nobody wants to take it up, okay. So we have to be sensitized about all issues. So is it an issue of literacy? Is it an issue of availability? Is it an issue of affordability? What is it?
So acceptability, I think that is the key challenge.
Exactly. Okay. So now, we have to be advanced enough in our thought process as to what are we looking at. Okay. And the challenges are different from illiterate to availability to affordability and things like that. Another thing, great on their part, and in terms of public health system, okay, having good engagement with the tertiary setup, okay, but it's not always true.
Yes.
It is contextual, wherein as an institute, you have a very good rapport and engagement with the public health department, and you are supportive of each other's activity. But if you want to translate this into any kind of a learning, engagement or teaching training engagement, we did it, okay?
Yes.
But we were not able to, because they were not doing it, okay? Training is one thing, okay, we did it, okay? But because they were not doing it. They were not doing it. And if they were not doing it, it's all of us know there are other challenges in terms of what they are, what they should be able to do. So, I would appreciate their efforts, but I don't think this kind of an exercise would be, we should be able to translate it into the otherwise public health system actually. So, that's my take on that.
Definitely, ma'am. From project mode to, a program mode is a long way.
It's a long way.
So, that support is required.
Yeah.
In a project mode, we always have funds. And here, at least for us, affordability and accessibility is not a concern in this part.
Right.
Because our, access to the tertiary care facility is very good.
Actually.
And even the institution has certain funds to take care of, in case they are positive and further management is required. So there are funds available. But it is not true in most of other places. So it just stops at screening, and referral is a big challenge.
Referral would
and
be
that follow-up cost is something that families cannot bear for themselves.
Yeah.
So they would rather not get screened. So from project to program, I think we have a long way to go. But unless we show it in project, I don't think the program will take it. So I think we begin somewhere.
Yeah.
So we begin here
So
and we
another,
define the process.
issue, this is not, we have to compare some of the programs, okay? Why a particular program was successful. As Dr. Bhatt rightly mentioned, okay, one of the most successful program of the for the country is the National Immunization Program. Lot of funding and equipment, things initially came from the World Bank and other sources to establish the program. But one thing we'll have to realize, and that is what the effort is also, anything which is in a campaign mode and one time. We have seen this through various, from public health perspective, okay, because we are public health programmers and implementers, okay. So anything which is, required a one-time effort, okay, it is doable probably. Immunization is a one-time effort, okay, and we do not have to call recall mechanism. Wherever, the system requires call recall mechanisms, probably, they are very intensive on the system, and, acceptability and implementation always faces challenge, okay, over a period of time. So that's, we'll have to accept this because cervical cancer screening is something. Okay, so probably, if an effort is made for HPV vaccination, it would be successful. Would you not know? And the screening efforts, which cannot be cut down. Definitely, screening has to continue. But the burden in terms of the program would come down substantially if it is one-time HPV vaccination, and maybe once or twice in a lifetime screening would make life more acceptable.
Definitely, ma'am. That is true. In addition, because we require this privacy settings for the testing, all that adds to that burden of the screening, especially cervical cancer screening. You need to have a setup. Immunization, I can do it in any room. In the sub-center, in one room, I can do the immunization. But I cannot do the screening, where, as she rightly said, we need 2 people for that. So the A&M single-handedly will still manage that immunization for 80-100 children. But this is something that she cannot do. She has to ensure that there is enough lighting, you have enough space, enough confidentiality that is maintained. So those are challenges. So yes, we have a long way to go, but I think we make the first steps. Unless we take the first step, we will not move forward. So in that direction, I think very good efforts from the team. So any questions from the audience? Anybody wants to contribute?
I don't know, should I ask this or not? I was trained under Dr. Shakuntala Balika for colposcopy. She had told one story. One very educated, ma'am was telling literacy, education and acceptance. This side story I remembered. She was some CEO of some company. She had done HPV testing. After 10 years of marriage, that test had become positive. Next day she had come to madam and she was asking, how did this virus got into my cervix? Did anybody face this? Then their marriage broke.
That's what we are also seeing. See, after that, even in my clinic, I am not promoting HPV testing that much actually. I should not say that having done this project. But I would rather prefer to screen the cervix than do HPV testing, if you ask me. Because to face them is very difficult.
Because our societies are different, culturally differently wired than the high income countries.
The expression on the face, very difficult to face them.
That's why that time I told, they can accept cancer, they cannot accept infection.
Infection, yeah, because it has...
They will fight then and there only, how it came, why it came. When that credibility of marriage is questioned, they will go towards some other end.
No, very true. We cannot take this as trivial experiences. No, these are impacting lives, socio-economic fabric, okay, cultural, marital fabric, okay. So somewhere down the line, okay, this could be the reason for not acceptance of HPV-based primary screening also. Today we are saying it's VIA, okay, tomorrow it could be something else due to varied reasons which are unfathomable unless and until some epidemiological investigation in terms of behavioral change, okay, behavioral aspects is digged into.
Because in medicine, for us, it is first do no harm.
Yeah.
So we wouldn't want marriages to break just because we are doing some screening activity, right? Marital disharmony, and then you are discredited as a physician in the society because anybody who comes to you gets screen positive. So that's not a way forward. So we would rather.
I would like to bring out one perspective. I think we are beating around the bush.
Okay.
So I feel that we have to be very transparent about these things. And we have to change the society's thinking of it. We can't keep saying that this is an issue or this is a stigma. We have to work out solutions to this.
Agreed.
Every time we come to every forum, this is the same thing that is being beaten up, but nobody is coming up with solutions for this. We can't say that we're not going to be saying this. Social media is changing, children are changing. We can't say anymore that our children are not sexually active by the age of 12. We should not be. We have to face certain facts. We have to talk about it. We have to destigmatize the whole issue. So we can't be saying we're going to take first steps. We have to be move forward. I've been hearing this for the last 10 years. We cannot beat around the bush. We have to take positive steps forward. And we have to address these cultural issues, and we need to find out ways of how to be able to change that mindset. We're keeping on saying on the same mindset. We need to change that. It's a matter of will.
I think in urban population these
So
days,
probably our, generations would catch up with this kind of a thing when we say, the urban metropolitan, population versus that of, rural population to semi-urban and things like that. So, we would take a long time before this transition of mindset in terms of acceptance of premarital sex, which is which is there in the society. Okay,
Yes, but that should
cultural
not be the
acceptance
talking
of
point.
and it becoming a normative phenomenon. Currently, it is not normative for our population to accept premarital sex or multiple sexual partners after
Yes.
marriage. In
So-
their societies, this is very much acceptable. Okay,
So what
we
I'm
will
saying
take a long
is
time before this kind of an acceptance.
What I am trying to say is that your storyline should change. Your storyline should not be sexually active. Your storyline should be cervical cancer, HPV virus is a common
prevention.
infection. And it is an infection that leads to cancer. So your storyline should not start with sexual activity. That's where we start.
I totally agree, and I don't think we start like that. So as
But
you
very often that is what is propagated. So whenever we do the training, we need to also actively tell our staff or tell the people that this is not the storyline you start with. We know that this is the science behind it, this is the physiology behind it, but we need to change the storyline when we tell it to somebody else.
Because
when
happens a lot, despite you training, telling them only like keeping it aside and telling them that HPV infection is, that's what we also tell. 20 to 30 years, it's very common. 80% of the women, if we do, that's why we don't test. It is there. It is there
But
like
ma'am,
any other fungal infection.
Earlier
any
also
infection.
menstrual
social media. That's the problem.
menstrual periods were always a hush hush. Now we are trying to make it a normal thing. So we have to move towards
Yeah, it
making
will
this
change
also
over
as
time,
an
but not
educational
so.
thing to empower people to take care of their own health. I can't keep hiding it.
well, I think this change we are seeing actually, we are going for school health programs, school in the sense adolescent or college, and they are very, very open.
Yes.
And we do get college girls coming to us with the HPV report, very frankly. And they are not, they come with their friends and they're
For them, it is easy to accept. This generation.
So generation we are seeing a difference because we do get in a month maybe 4 or 5 I keep seeing people coming with the reports and they are quite open with it.
So now, now the generation is very much far from. I have a son, just a personal experience. My son is 10 years old, just cut the cake, and now he's 11. He's asking me, ma'am, he called me Mai, when I'm getting my HPV vaccine. And next, my daughter, I'm 9 years old now.
At all. That is not a
No,
problem.
so
Very
this
easy
is
to
the thing.
manage.
This is the social media. Like the kids are, without the
problem is
the education is so
women who
far.
get screened
So
by
I
us
think
now.
I think as a health worker, as a clinician, we have to tell the women, especially whom we are screening, we should tell the importance of the cervical cancer, not the just what Dr. Sonia is want to tell. Let's just beat around the bush. The stigma. We have to wipe it out.
I know that when we worked on our IEC material, okay, the first risk factor was multiple partners. My patient came and told me, ki, ma'am, in this there is a whole lot written over there about HPV virus and everything. But she said that everybody in the family looks at me differently because I'm HPV positive. Okay, so she said in that, can you add another thing that says that it is very common? I realized that in translation of that whole thing, that one sentence was not there. So we went back and we changed it because that feedback came from her. So we have to be able to address it. We cannot, if we don't address it, then it is not going to solve this problem. Every time they're going to come here and say, let's take the first step. We shouldn't be taking first steps now. It's more than I would say 10 years since, yes, we are practicing now, but we've heard this long before also.
I totally agree with you. I think what Madam is telling is the age group that Madam is saying in her OPD is different.
It should be contextual.
Yes.
We need to do that.
Yes.
But we should no longer be saying that we are not going to be addressed directly. We
No,
need to
it
address
is-
head
yes.
on, But we need to be able to do it and start making those efforts.
As Madam said, we go for school health programs, we go for adolescent health programs. I think they're very open. You know, girls know about it. We talk about menstrual hygiene. There are even some schools which say, we actually ask them if the boys also want to be part of the menstrual health, awareness that we do. But so that, the boys always feel, why are the girls only taken to one classroom? What are they being talked about? What is happening in that room? So there are some schools which says, okay, let's have a session together. So we are talking about menstrual health. So those things are happening. So as Madam said, it's probably easier to talk to the younger generation about HPV and screening and cancer rather than to the middle-aged population right now that we have.
30 to 49, certain age group, it is little difficult.
That will always be there because our literacy rate.
That is the problem. If it was limited and if AI was only coming from the clinician who is treating the patient, we would have less problems. The problem is AI is everywhere, so they're getting multiple sources of information, which probably is not true. And, tackling that misinformation is more of a problem than giving them the right information.
I just want to share actually very similar to what all of you have been saying. And we also realized we took away the sexual transmission completely from all our, the information sheet. But what happened is a couple of our own project staff, and one of them was highly educated, turned out to be positive. And that became a big problem for that person to accept. I mean, we were not talking about sexual transmission at all. And like Sonia said, we were only saying it's, common. But you can't hide that from the very educated people who are obviously going to be able to find out, even if you don't say it. So then I actually contacted different experts around the world, and we had partners in IR, Dr. Basu, everyone, and said, how do I deal with this situation? Because I don't know what to tell that person. That person very convinced that this could not have happened through a sexual transmission. And if we say that, that person is like, again, marriage can break, etc. So then they all discuss, and what they told me to say is that there is a very small percentage that it is not sexually transmitted, and we have to say that to that person to reassure that person. I mean, I don't know what's that percentage, but they said
They say 95% sexual chances.
What I usually, when I counsel them is, HPV infection is transmitted by skin to skin and mucous contact. Okay, whether you have a single partner or multiple partner, you are at a risk of having HPV infection. But this infection is a common infection which will go away in more than 95% of it. There's a small percentage for various other factors will have persistent infection, and they will then lead to increased risk of developing cervical cancer. So we have to talk about it.
Yeah,
No,
but
so
we did one initiative actually. It was Kirtana ma'am's idea that to give cell swab test to our staff from our Mahe staff. She wanted to give this cell swab opportunity to Mahe staff. So what did we do is, under her guidance, we went and just without telling it is sexually transmitted or anything, we just gave a basic explanation. It's a self-test. You can screen for cervical cancer. So they were happy. So many registered. We got the names. So we said, okay, we got registered. We thought burden should, even they are like working staffs, working like professors or someone. We thought like it should not burden them. What we do during the end of their, we have a Mahe Medicare. So which ends in the month of March. So we approached them in the month of February so that they can utilize the fund whatever remain in the Medicare. So what did we do? They registered. Once we educated so many members, I think more than 30 members, they registered. So when we actually has to go to deduct that amount, and when we have to give them the swab, no one was there to collect the swab over there. Like we went to so many things we did. We told them like, you just collect and give it to us. We'll come and collect from your place and we'll give. Even we belong to a same Mahe campus also. very few of them came forward.
Similar to Dr. Sharmila's experience.
Very
We tried
few
to
of
screen
them. Some of them still holds the swab in their hand because they paid for it. It was deducted from their Medicare. It is paid. They are telling it is there in my hand. Some of them I known people only. So it is like that. Like they scroll through the Google. They something. They feel if I test, it indicates that me or my husband. Someone is thinking that. So
it is a cultural issue
It
to
is a
some
cultural
extent,
issue,
and
we have to
we have to
start
accept
addressing
it.
because we have, see, when you're doing for vaccination, and when we have women who are coming in the older age bracket who are asking for vaccination and they don't want to get screened, how are you going to explain to them? You have to explain.
We have to explain.
You have to explain.
We
So
are
when
trying to be one
because
of
when
them
we're
to do.
explaining about screening, then we have parents also coming in
So
asking
probably
me,
like,
does
I
my
mean-
child need to get the HPV test done first before I vaccinate them? Then what do you tell them? If you're going to be telling them different stories, you will then how will the person trust what you're saying? Because they'll read something else, you're saying something else.
Ma'am,
And
actually-
you know it is like, so you have to make those things very clear. Your basics have to be straightforward, and you have to know how to deliver it depending on the context, the person you're talking to, and how you're going to do it. But you cannot do a wishy-washy thing. You have to be very
Ma'am,
clear.
actually speaking, in my area, I've never ever spoken about sexual transmission, never told them about HPV infection. I just wanted to screen them whether they're positive for VIA or not. I just wanted to screen them, and I just wanted to tell them what I am trying to do. Just see, there is a ulcer or a wound. So I have never, while talking also, giving them education, I tell them there is a chance of getting a cervical cancer if you have a wound. Ulcer, as I told, like I tell, like how mouth ulcer, how does mouth ulcer come? We don't know. It may be heat or anything. So I'm in my area, and I'm sure in my area they don't go and see Google. And still, no, the response was not that great. It was never about sexual transmission in my
reason is
area.
different in your
Reason,
area.
They don't want to
The
get tested.
problem comes,
It's not, they
the
don't want
problem
to
doesn't arise
That's
when
because
they
they're
come for screening.
asymptomatic. That is
Problem
another big
arises
drawback.
when they're
The
tested
drawback is
positive
the
for
asymptomatic.
And the way we do the test,
Till
it
then,
is
no
very
problem.
inconvenient.
See, like the story you said, no, I spent 5,000 rupees and nothing came out of it. So I tell them the same thing, that you have to look at it differently. I have invested 5,000 in my health
Here it is,
health test, and it has come negative. I'm happy for that.
No,
That
here
it has
it is
come
like-
negative.
I-
Would I
I
have
understand.
liked it if it had come positive? No, you wouldn't have liked it, right?
Sonia, like
So
what
that-
happens?
So you have to look at the context. Your baseline should be correct. How you put it will change as per the context. But you cannot change
No, ma'am,
the
actually
underlying
here,
concept that is
zero
there.
cost. Zero cost. I am doing a VIA test for zero cost. Just
But it
only
will cost a
thing-
future for the treatment.
but for them, it is
No,
getting
what we
the tested.
do as individual counseling, okay, versus a test which is going to be offered at a population platform where all these explanations, though very true and contextual, cannot be passed on at an individual level. So you'll have to think from the programmatic perspective whether, I mean, though this is very true, and like, I mean, this is what it should be, but whether we will be able to transfer this kind of a counseling and explanation to individuals where it is needed probably may not be programmatically possible.
It is possible, ma'am, like especially when as a clinician, when we are dealing with the patient, the cervical
Again,
cancer.
hospital.
Yeah.
Not
So-
community.
So when it comes to community,
But even
you
if
have
we
to
are-
give them information
No.
that cervical cancer screening
Yeah,
needs
we
to
can
be
do
done.
that.
All
We
women
can
from
do
this
that.
need to
Even
be
at community level.
She wants to tell
I just wanted to share
The snowball,
my
snow
experience.
rolling.
My place, we had offered this free HPV testing for the staff. Many of the staff didn't take part, but most of them had taken part. And again, we have two positives, but we were dealing them with that we are putting them for the follow-up. But there is one is having some positive changes on the cervix, but it is not that going into the extreme. So we are just telling them that it is some infection only, not suggesting that it is sexually contracted. So that solves the problem. They are not at all having any issues. So we just wanted to tackle those issues. But we can very well tell them it is an infection just like any other infection. That will save. That is what I have to tell you, because we need not worry about this.
Yes.
Yeah, that is.
But we need not worry about it. But
It's
it
actually
is something
transmitted
that
only will carry the problem. So we need not tell. It is just like an infection. You all can contract HPV.
No, here there is a contrast.
So when we said
You are
no,
saying
when we
to
say
tell-
no, when I'm saying that, when I
Yeah.
say it is a common infection where the risk increases once you're sexually active. I do not say that everybody is going to get infected, because there are instances where they don't have to be sexually active, but there are still people who are HPV positive. In fact, there is a study that they're doing on virgins to see whether they are having HPV infection or not.
Yes, that will be a good study. Actually, there may be a chance.
There is, but it's that. But will they develop cervical cancer? That probably their risk is much lower.
Because even in a study, what we had some women who were never married.
So when you're looking at the country guidelines, you are not going to subject somebody who's at a very low risk of developing cervical cancer to a testing, but you're going to do a population-based screening for those who are at a higher risk of developing.
Yeah, but
so we know that we are going to target people who have already been sexually active.
So I think we had a wonderful discussion, and it went beyond time, I guess. Thank you very much for the active participation. I think the audience was, very good, and we had great discussion points. Thank you very much, and thank you, speakers.
Thank you, ma'am. I request Shamla madam to hand over a token of appreciation.
No, even a community ma'am.
All these students who are doing MBBS
snowball rolling,
have to
it is very difficult. It is possible with the proper counseling.
Same like
Yeah, it depends on region to region, cultural barrier.
That is the thing, what is tobacco cessation ultimately? It requires
With this, we conclude day 1 of our conference. We've traveled from global strategy to grassroots innovation, and we're just getting started. Please join us outside for high tea and networking, because as any researcher will tell you,
Is it possible, because we won't meet them tomorrow? Is it possible?
Yes.
We'll have us.
Nothing like not possible.
whichever groups you can take, we'll take. Yeah, do so. You won't get them. So whichever group is available, we'll take.
You're talking about a cervical photograph.
Put the main.
Yeah.